online.
You are live, you can start.
Yeah. Good afternoon and good evening to some of the delegates from some part of the country, some part of the world. And dear friends, welcome you all again to an interesting webinar focused on live surgical demonstration of interesting skull-based pathologies by expanded endovascular approaches today. Today is something which is very, very significant day for us because it is the 17th webinar of exploring the Explore ENT with the legends. And today it is the 16th program with Dr. Satish Jain. And all this idea has been mooted by Dr. Rajiv Pacheri, and you have been witnessing the effective moderation by Dr. Paramita. And today we have Dr. Rajiv Kapila also with us for moderation. And yes, of course, my heartiest welcome to you all once again, and my special welcome to Dr. Satish Jain, Dr. Rajiv Pacheri, and we have a guest emeritus today with Professor Vijay K. Anand from New York, and Dr. Professor Theodore from New York, and we have the moderators, Dr. Paramita and Dr. Rajiv Kapila. Being a very, very special day, and there are a lot of significance attached to it. I mean, as I said earlier, where I would request my boss, Mr. Ramesh Juneja, who is our cluster head, to give a brief about it. Yes. Sir, over to Mr. Juneja. Sir.
Thank you. I, Ramesh Juneja, Vice President of Sun Pharma, want to sincerely thanks to each and everyone. During this tough time, we know that last 100 days of COVID in India was a really tough time for each and everyone. But I at Sun Pharma, on behalf of the entire company, I would like to say thanks each and everyone for participating in this online learning fest. We at Sun Pharma, we conducted almost 700 webinars in last 100 days.
Oh, good.
More than 7 lakh doctors from India and abroad has attended this learning fest conducted by Sun Pharma. But no event lasted more than 3 hours, except the events taken by our own Dr. Satish Jain, and the brain behind the
Sir, we have lost you.
No, maybe some network issue. Today, lots of network issues are there.
Okay. So what I do, before boss get into, I would request Mr. Ramris also to talk few words.
Yes, yes.
Yeah, indeed a matter of great pride for all of us to bring so many ENT surgeons on one platform, and the kind of interviews which many doctors commented is something like encyclopedia for ENT. So great efforts by Dr. Jain and Dr. Rajiv Pacheri. Indeed, very, very thankful to Dr. Paramita, who had been kind enough for giving us her time. And then she had been spending a lot of hours. We have actually crossed more than 120 hours so far in our webinars. So, which is definitely something has to be written in the Guinness Book. So, thank you very much, sir. And of course, we are always there, and we'll run such kind of programs in the years ahead as well. With this, over to you.
Yes, sir. Thank you. Sir, always there is a saying that you should not forget the people who are really helping us and who is helping the mankind also. And today being the very, very special day and a very significant day, being a 17th program of Explore ENT with the legends and 16th program with Dr. Satish Jain, I would like to felicitate, because there would be a small gap in our series of this program. Then we will be starting later, but there will be a small gap for the next 1 or 2 weeks. So today I would like to make a very special felicitation to start with Dr. Paramita. My colleagues there at West Bengal, that is our regional zonal manager, Mr. Gopinath, I request Gopinath to hand over, felicitate Dr. Parimita Saha. Yeah. Thank you, madam. Thank you very much for the wonderful moderation you have been doing, making the sessions more lively, interesting, and making it more, giving more clarity to those who are attending really. And it is a wonderful job. I don't have any other words to speak about. Yeah, Dr. Rajiv Pachori, do you like to comment on that?
No, see you can say, that's finish that part. Again, congratulations.
Yeah,
So,
congratulations and thank you. Thank you.
We started the program and see the energy of the program because see, take out the questions, see just you can awake us in between because whenever there's some questions are left, see just take out the question and just take us all on the track. So that is beautiful from her side.
Yeah. I would say that sir, throughout the day, because sometimes then it goes up to 11:30, 12 o'clock. I saw the webinar which are around 12 o'clock in the midnight. Then I see that when she's very energetic and it gives a lot of life for those who are attending also. Yes. Again, all this has become possible. It is only I would like to thank Dr. Rajiv Pachori for the wonderful gesture and wonderful help you have done for the entire ENT fraternity and for Sun Pharma also. Today, Sun Pharma is being talked across the industry because of this webinars. And Pharma Care Division, which is dealing with Cipodem and Recipar and Montec FX and Beta Watt. And today, it is really appreciable and is very, your contribution to this webinar is immense and significant. I would like to felicitate through my colleagues Saurav and Nikhil. Yes, sir.
Okay.
Yeah. Oh, great, sir. Great, sir. Congratulations, sir. Thank
I think we can all clap.
Thank you, Dr. Rajiv Pachori.
Yeah.
Thank you very much.
Yeah.
Thank you very much. And
yes, of course. I would like to felicitate Dr. Satish Jain also because, since he is in the theater, our star who is in the theater, then we cannot go into the theater. So already my colleague has felicitated Mr. Ajay Mathur, our regional manager. Yes.
Good.
Thank you, sir. Thank you.
You have always been a big help.
I'm really grateful to you, sir.
And your love and affection
it's not a help,
is
sir. It is
there.
not a help. Yes, sir. Yes, sir. I'm totally moved. I am speechless. Yeah. Once again, since Mr. Our boss is not could not connect, I would request.
I'm
sir,
there.
yeah.
I'm there.
Few words, sir. Few words, please. Yes, sir.
Attended this webinar. Want to thanks to you. Sincerely thanks from everyone. Your years of research, your depth of understanding of each subject has made
there is some internet issue.
Yeah, some internet connection.
Internet issue.
Yeah, I think okay, no problem. We'll move ahead. Actually, boss has collected all the details. More than 100 hours of live webinar, and more than 10 international speakers, and more than 40 eminent speakers across the country. That is, in the particular field, and we have covered almost, from 0 to 100. Almost we have touched upon all the subject in the ENT facility, ENT fraternity. So it's really great for this team, led by Dr. Satish Jain, Dr. Rajiv Pachori, and Dr. Paramita. Once again, thanks to all of you. And with this small note, and once again with a sincere thanks from Sun Pharma, this is Mahindra Varman who is handing over the session to Dr. Rajiv Pachori. Thank you, sir. Thank you very much. Please do take over the session, sir.
Thank you very much. Thank you very much. All again, thanks to Sun Pharma for all this organizing this academic event which is going on, and only 1 week we will be there on 9th, and then I will start. Thanks again by Dr. Satish Jain, and again this is the 17th webinar. 16th webinar with our Dr. Satish Jain. And I would like to thank everyone for this being with us for since almost 2 months are over there. And today we have Professor Vijay K. Anand from US and Dr. Theodore, Dr. Swartz from US again, and Dr. Kapila and Dr. Paramita as well. They are the backbone of this. So I will not take more time, and it's a team effort from all of us. And I would like to move on to Dr. Satish Jain. Dr. Paramita, you want to say something?
I would like to just thank Sun Pharma for this gesture. What you all have thought about. It is such a beautiful gesture in this pandemic situation where you have sent your representatives in Kolkata, Jaipur, and Agra. It is really wonderful and really appreciable. I mean, really thankful to Sun Pharma for being such a support to all of us. Thank
Madam,
you.
it is our privilege. It is our privilege.
So we will, I think we have a wonderful session today. We have such rare cases kept by Dr. Satish Jain, sir. It is really so much rare to see these cases and to discuss and to make these difficult surgeries look easy for all of us, for beginners, for the residents, for all of us. It is really creditable. And in this pandemic situation, especially to arrange these cases and to operate and to teach us is really remarkable. Thankful to Dr. Satish Jain and Dr. Chauri sir for this. So I think we will start with today's session. Once again, thank you, Sun Pharma, for everything that you have done today for us. Thank you.
Thank you, madam.
It was a big surprise.
It was a big surprise. It was a beautiful gesture.
Thank you.
Thank you. And good afternoon, everybody. It's a pleasure seeing you all again. And I believe today is a very, very important day for us, as a lot of legends are going to join us from US, the top in the stream, who have revolutionized this science of endoscopy skull-based surgery, Professor Ted Schwartz and Professor Vijay Anand, who are going to join us a little later. This is 4:30 morning in New York now, so they are going to join us later in probably in the next to next case. And as we discuss about the webinars, we have completed 120 hours or so. Believe me, this credit goes to certain people. Special thanks to Sun Pharma for all the way supporting, unconditionally supporting. Their gesture to academics is something, I have no words to express my thanks and gratitude to them. And of course, big thanks to Rajiv Pachori and Paramita, without whom this would not have been possible. Besides that, certain people, so senior people, you can't imagine, who have seen their life this ENT, and they are still with us, guiding and, helping us, encouraging us throughout, right from the day one of the webinar till then. I'll enumerate certain people. Professor Sethi from Singapore, who has always been, the biggest support to us. Our own, 87-year-old Professor Majumdar, he did not miss even a single minute of any webinar. That is what is commitment. Professor Kirtane, Professor Movani sir, and today we have Prakash Munka sir with us, who has always been a big support and encouraging us like anything and being part of every academic event. Thank you, sir, for being with us. Then,
thank you, Dr. Satish, to give me an opportunity. Though I reached nowhere near the people you have enumerated just now. So,
thank you, thank you. Then we have, I can see on screen, Dr. Narayan Jaishankar with us. As I told you, he's a 360-degree surgeon. He's not, he's been earlier known as a lateral skull surgeon, but I know him the way he does pituitaries, angiofibroma, and all endoscopy skull-based surgery. Is something treat to watch him operate. Thank you, Narayan, with us. Then people who have been supporting us from their heart, Dr. Ashim Bhumkar, Dr. Ashim Sai, who have, like brothers to me, have always been a big support in every academic event I have ever done. Thank you all. And today with Paramita, we have a young dynamic superstar, Dr. Rajiv Kapila. We belong to same college. I have a very good memories with him in Jaipur when he was here. He is presently the director and consultant, the chief consultant at the prestigious Deep Hospital in Ludhiana. Endoscopy is his favorite subject, I know. And besides that, he is a keen interest in cochlear implant surgery. And that's how he did a lot of efforts to start first of the implant in that area, and that is what his commitment towards the academics. He has been regular feature of many important academic activities. And Rajiv, thank you for sparing your time today with us.
Sir, we also have Dr. Jain with us, who has been always supportive and always been there in all our webinars.
Yes, yes. Thank you.
Thank you, Satish. Thank you, Paromita. Rajiv, thank you very much.
And
Dr. Satish Jain, I, Ramesh, on the behalf of Sun Pharma, would like to convey sincere thanks to your OT staff and Dr. Satish Jain, ENT Hospital, and entire staff who has really made this event successful along with you, sir.
I am grateful to them.
Almost 12 hours.
It's obviously a teamwork, and I am always grateful to them, the way they have been supporting every time, day and night, without any issue. Thank you. And today, for this special session, we are starting with our first case, and that is a proven case of olfactory neuroblastoma, which is a very interesting and challenging pathology for us. And for this session, we have our own pathologist who has joined us. Can I see her on the screen? Dr. Ritu Garg. We met earlier our pathologist, Dr. Archana Parikh, and this time we are pleased to have our other pathologist, Dr. Ritu Garg, with us. Dr. Ritu, can you hear me? I think she's joining again, logged out. Yeah, she's going to join us for this session. So,
sir, I'm here. Sir, I'm
hello, good afternoon.
Good afternoon, sir.
Thank you. Ritu, has a keen interest in oncopathology. She has worked in Rajiv Gandhi Cancer Institute, did fellowship there. Then she was a faculty in a medical college in Jaipur, particularly in oncopathology. And she has been part of our pathology team. And again, most important thing, giving us unconditionally 24 hours frozen section services. Thank you, madam, for being with us.
Thank you, sir.
And she is, like today's case, she has worked up all cases. And in today's cases, pathology has a big role, which I'm going to share with you. And in our team, besides the pathologist, as I mentioned, our radiologist, today we are going to have our endocrinologist with us in the pituitary case when we start, who is an integral part of our team. And our closest ally, our dear friend, Dr. Pankaj Gupta, is with us, who is a neurosurgeon. He is always an integral part of our all skull-base cases. Thank you, boss, for being with us. Thank you. So, can you connect? Let me show you some of the details of the case first, then we'll discuss something before we start. This patient, this is a 40-year-old patient, 41-year-old. Can you connect? Are you getting any MRI picture?
Yes, you got it.
Okay, you get one. So, this patient presented with a history of nasal blockage, recurrent epistaxis, and headache, and some, funny symptoms in the head sometimes, all those weak symptoms. When he was scanned, he had a CT scan done earlier showing some mass in the nasal cavity rising to the roof or going to the roof. Then we got the MRI done, which is the investigation or imaging of choice. After that, we took a biopsy as well, which revealed as a olfactory neuroblastoma, and I'll take madam comment when we come to it. So, once you have a tumor like this, we all know olfactory neuroblastoma arises from the basal layer of the olfactory cells, olfactory epithelium. Olfactory epithelium is one epithelium which has a potential to regenerate as well, and the cells which regenerate the cells are the basal cells from which this tumor starts. And we all know the olfactory cells are in the upper part of the nose, in the roof of the nose, in the cribriform, upper part of the septum and the turbinate, in that region, limited to that. There could be some scattered olfactory cells elsewhere in the nasal cavity as well, uncommonly. So this tumor, I will just show the extension through the MRI and some of the important input we get from MRI from the management point of view. As we all know, with the advancement in the endoscopic technology, more and more such lesions are now being addressed endoscopically. Whether they are limited to the nasal cavity, attached to the skull base, or even gone intracranial, except some exceptions, which we will discuss. So for this particular case, if you see in the coronal image, let me take you like this, from anterior to posterior, this was the nasal packing when they was scanned. And see this enhancing lesion in the left side of the nasal cavity. See why MRI is so important, the contrast MRI. Let me put up the T2 weighted along with this. This is important for us to understand the, if we keep these two things together, the T2 and contrast.
Satish boss, your image is, your voice is echoing.
Echoing. Now, better?
A little better. Still
कुछ करना, echo हो रहा है. So, see this, on T2 weighted image, whenever there is a cellular tumor, it will appear hypodense. And whenever the secretion will appear hyperintense. On the contrary, the tumor will appear hyperintense, the secretions as compared to the tumor in contrast will appear hypointense. That's how you can easily differentiate where the tumor is and where the secretions are. And see this tumor right from anterior to posterior. Anterior to posterior, as I go behind, here it is, I don't see any separation from the cribriform plate. I can't comment at the cellular level, but yes, see it is very, very well in close proximity to the cribriform plate here. Now, if I come anteriorly first again, this is the maxillary sinus secretions. This is the frontal sinus secretion. See hypodense in the contrast and hyperintense in the T2. Then the most important thing about the skull base invasion is this hypodense line all the way along the skull base. See this bone of the skull base? Bone in every MRI sequence will appear dark. And that is how the hypodense line segregating the extracranial to the intracranial space on MRI. And here, this is in close proximity, like breaching the hypodense line. So I'm suspecting involvement of the cribriform plate, which is common because these tumors arise from the olfactory area in the same vicinity. And that's how, see this high intensity tumor supposed to be vascular as well. The most important thing to ascertain in terms of surgical planning is involvement of the orbit. And the best sequence to know, this is very important. In the past, this has been a standard practice. In the past, this had been a standard practice. Whenever the periorbita is involved, was an indication for orbital exentration. And that was too, regular treatment for such lesion. Let me put up the best picture to see the involvement of the orbit. Now see in the axial plane first on T2. Whenever it comes to orbital involvement in tumors, the best sequence is T2 weighted. And what you see here, see this? Let me enlarge it. The fat is hyperintense. This is the medial rectus muscle. Fat is the hyperintense. And see, this fat, this is a hypodense line separating the tumor from the orbit. That is classical of, the extension towards the orbit. The orbit is actually not involved. In the past, even a slightest indication of periorbital involvement would have been the indication for orbital exentration. Now in this era, even if the periorbita is involved, when you are doing endoscopy, you can remove the periorbita with a safe margin, confirm unfrozen section and avoid an orbital, exentration. So this is very important to ascertain on MRI whether the orbit is involved or not. This is so clear. Now, a CT scan will tell you only the lamina papyracea, but MRI will tell you exactly everything. See this, the orbital muscles, the fat inside, everywhere bright is the fat. Everywhere bright is the fat. And see, this hypodense line separating the tumor from the orbit is good enough an indication that tumor is not invading the orbit. Can you see very clear? And this is how we can easily spare the orbit. Olfactory neuroblastoma generally are orbital sparing in the beginning. When they become so massive, they can involve anything. But generally in the beginning, they spare the orbit. And this is their nature. Sometimes you have a tumor involving both the orbits and it is difficult, looks like difficult to spare. I remember there was an amazing publication from Tata Memorial Center from Dr. Anil De Cruz, Prathamesh Pai and all. They did a study with a pre-surgical reduction by neoadjuvant chemotherapy, reduced the tumor in all responsive tumor when they separated from the orbit. They did the surgery followed by the radiation therapy and had a good survival as compared to those tumors. If you don't do a cytoreduction earlier by neoadjuvant, was a straightforward indication for either inoperable or indication for orbital exentration. That is how you can plan in certain situations. Now in this era, with the availability of a lot of good adjuvant therapies, chemo and radiation therapy, you can spare such valuable function of the orbit in those situations, particularly in these tumors who are really responsive to chemo and radiation as well. So this is an important protocol, and imaging will tell you what to do. This is a decision making, whether to give any pre-operative neoadjuvant therapy or not, whether to do an orbital exentration or not. For me, the straightforward indication for exentration is if there is direct involvement of the intracranial space with the involvement of the orbital muscles or the orbital apex. That is a straight away indication without thinking twice. Otherwise, all these initial involvement of the orbit you can always spare. Now, again, bringing the same picture, the contrast together. See this, anterior to posterior if I am going. This is the skull base, which I believe I may have to resect a part of the skull base to get a free margin. This is important, and where the frozen section has a value. Because all what we need in this malignancy surgery is to have a negative margins. Earlier people would believe that an open craniofacial surgery will give you a en-bloc resection and good oncological, better oncological clearance, but now it has been proven. As long as you remove the tumor with negative margin, the results are same. So that's what we are going to do this. We have a huge series of now olfactory neuroblastoma with, even with the intracranial extension, you can remove them with good indications. So what all you need is a negative margin, and here is the value of the frozen section, which we are going to discuss when we remove the tumor, and will not think twice as the cribiform is involved. We'll take a safe margin and resect the skull base and reconstruct it. Because this is malignancy, you can't take a chance. Oncological clearance is more important than anything. Now, going behind, see now, look, keep an eye on both the images. This is tumor, this is tumor. Hypotense on T2 and hyperintense on contrast. And now as I enter the sphenoid, see this tumor has a good distinction from the sphenoid margin all around. And this tumor is limiting itself, and the carotids are far away, miles away from the tumor, you can say. That is how. And if you want to have an additional information about the anteroposterior dimension, we can add on the sagittal as well. And sagittal picture will exactly tell you the tumor, how tumor is limited, prolapsing in the sphenoid with no attachment anywhere on the critical area. This is important from resectability point of view. This is so important. This is the area where the tumor is attached to the cribiform. This in the center where the tumor is attached, I believe. This is the closest margin of the tumor, and this is where the hypodense line is obliterating, you can see. Are you getting this picture?
Yes.
See, this hypodense line is obliterating. What an amazing picture on MRI. That's how it is invaluable in planning, in decision making and planning. And this looks like the secretion in the sphenoid at this point of time. Now the another thing which we need to evaluate, once we plan an endoscopic resection, the another important thing is reconstruction. We all know when you resect the skull base with the availability of the vascularized flap, which yes, Narayan.
Yeah, Satish, just before you go on to the reconstruction, two things you must lay emphasis on. One is the staging of these tumors, the caddy staging, that is one.
Yes.
And again, you already spoke about chemotherapy, which I thought you'd speak at the end. So when you're talking of neoadjuvant chemotherapy like cisplatin plus etoposide, which is commonly used,
yes,
your resection margins go wider?
I know. You are supposed to take the previous margins to stay oncologically sound.
Since you already got that point out, maybe you could just lay emphasis on those 2 points.
I understand your concern. It is so valid. When you do a cytoreduction by means of neoadjuvant therapy, and during surgery later on, you are supposed to take the margin which were before. But here in the function preservation surgery with the availability of, the good chemo and radiation afterwards as well, after surgery, you can certainly take care of this and preserve the function. And in any case, in their series also, they had some failure with the recurrence in the orbit, which they salvaged with the exentration later on. But they could preserve a lot of orbits because of this, strategy of neoadjuvant therapy for the preservation of the orbit. So this is very important concern, orbital preservation as well. Now, what I was telling from the imaging is the reconstruction part. Why I'm saying so? Because if we give a skull-based defect, the best is to reconstruct with a vascularized flap. And now in these tumors, particularly olfactory neuroblastomas, they tend to involve the septum very early. Sometimes, unfortunately, you don't get a flap as well, as the septal flap, entire septum is involved by the tumor, which how you can assess preoperatively, because in case your septum is involved, you have to plan preoperatively bringing some other flap from outside, like pericranial, temporoparietal fascia, or some other vascularized flap. It has to be vascularized flap, by and large, when you give a large resection, large defect. So here, how can you assess? See on this MRI. Let me start from anterior. This is the tumor on this side. Can you see the nasal septum as a dark line? Can you see?
Yes, sir. Yes, yes.
And the mucoperiosteum or the flap on the other side. Very clear?
Yes, sir.
Now, if I go behind, now see the change. Keep an eye. See this. As I go behind, see now what is happening. I am not sure at this level behind, this tumor is invading the septum, maybe pushing it, or maybe invading the opposite side. Not very sure, but what I can see, the deflection and the lower part is absolutely preserved. Anteriorly, the entire septum was free, and posteriorly, the lower part is looking very much preserved. So still, I have a good, see this lower part is completely preserved. I have a good chance that I get a good flap. I may not get superiorly or behind a flap, which anyway, I don't even want that to preserve. Generally, you don't take in hadar to preserve the olfaction. But here we have to be very careful, and this will be our first part of the surgery to begin with. Maybe we may, debulk this part of the tumor and then go into the other side and elevate the hadar first to ensure that we don't damage it further. We raise the flap, preserve the vascularity, and park it in the maxillary sinus on the opposite side of nasopharynx somewhere, so that we can ensure a good vascularized reconstruction. And here you can see on MRI very well whether you will be able to get the hadar or not.
We can include the floor of the nose in the flap cost in case
yes,
there is...
yes, that's what. In case you don't get a width, or the width what you are getting is inadequate, or your resection, defect is much bigger, like Rajiv said, I can not only take the floor, if taking the floor makes it adequate, it's fine. Not only that, I can take the floor and lateral wall as well, and make the as big a flap as I want in any given situation. So this is one. Second thing.
On the same picture.
Pardon?
On the same picture, you show mucoperichondrium on the opposite side, which is preserved.
Yeah.
What on the ipsilateral side? Is the mucoperichondrium involved on the ipsilateral side?
Looks like, most likely it would be involved.
Yes.
Because olfactory neuroblastoma, you can imagine, the upper part of the septum gets easily involved in the early stage.
So then would you consider alternative flaps, or would you still go with the opposite mucoperichondrial?
First, I will go and elevate. If I find the opposite side uninvolved, I'll elevate the opposite side and park it somewhere. If I don't find, and I have a slightest doubt of involvement of the opposite mucoperichondrium, I will don't think twice. I'll not think twice, and I will think of the other flap like pericranial or some other flap. I can bringing the pericranial flap inside the nasal cavity in case required, any point of time. So
the status of frontal recess and the posterior frontal table here.
Yeah. Let me show you. See this frontal. I have already mentioned. See this. The frontal sinus has secretion only. There is nothing up in the frontal sinus, Rajiv.
Okay.
It is nothing. The tumor is centered. It looks like arising from here. You can see very well.
Yes, yes.
See how vascular it is. These are vascular tumors, they enhance with contrast, and I've been giving it a good course of antibiotic and steroids for the last 4 days to minimize the inflammation. Now, the another important information, what you get in these tumors, when they come to you and you on an imaging, you always have in mind whether it is benign or malignant. So the thing on MRI, which has a high sensitivity, is the diffusion weighted MRI. And now see here, this is the tumor. Can you see?
Yes.
And see this particular part on diffusion showing restriction. This is a class of a malignant tumor on diffusion weighted imaging. By and large, without even having pathology, you know, I can say this is malignant tumor in my mind. This is how, and this has a significant implication when you plan a biopsy as well. Because when you plan a biopsy, you are supposed to take the sample from the area which is showing maximum diffusion restriction. Many a times, the tumor on the surface, when you go into the nose for the biopsy on the surface, whatever tissue you take may turn out to be negative, in spite of having a malignancy behind. So it's always better to take the help of diffusion weighted MRI and go for biopsy to the area where it is showing maximum restriction. This is a significant implication. Many a times tumors, I have seen patient coming with 2 or 3 times biopsy already done, and saying negative. And when we got the diffusion MRI and found a deep tumor which is malignant, and a deep biopsy proves a malignancy. So this is very important in surgical planning. Another important thing, earlier it was too radical to remove the orbits and on the basis of CT scan or whatever finding. Now with the help of diffusion, we can have a very good idea about the tumor and peritumoral inflammation. Whatever tumor you see CT and MRI are over. They demonstrate something more than what the tumor is because of the peritumoral inflammation. And when you see on the diffusion, you will find exactly the level of the tumor. See this tumor here, this is the whole tumor at the level of the orbit. But see here, this tumor is not that big. All that around is the inflammation which is hyper, showing no restriction on diffusion. So you can have a very good idea on diffusion about this function preservation and all those things if you take into consideration. This is about the radiology of this particular case. And see this olfactory neuroblastoma, their diagnosis is sometimes so difficult. Not for us only, but for the pathologist as well. Yes. Because they represent a group of, pathologies. And it becomes a tough time for the radiology, cytologist to find out. And that is what, to know some of the insights about the cytology from Madam, Dr. Ritu Garg is here. So let me put up my version first and then we'll have her opinion. So like we always discuss with her, there are certain parameters, to establish the diagnosis we take into consideration. All these, immunohistochemistry parameters, what this tumor, whether it is olfactory neuroblastoma or not. Secondly, the differential diagnosis, very, very, very close differentiation. This is, I would say, a spectrum of diseases, a spectrum of malignancy from a well differentiated to the most poorly differentiated. Olfactory neuroblastoma at the one end of the spectrum, which is most differentiated, very well behaved tumor, as compared to the most undifferentiated tumor on the small cell undifferentiated carcinoma at the other spectrum. And this is what Narayan was asking about the staging part. We all follow Caddy staging, A, B, C, but then the Morita modified it to include the stage D for the metastasis. And this is valid because metastases have important role. Let me put up to 20 to 30, 35% of these olfactory neuroblastomas in their lifetime, they develop cervical lymph node metastasis. May not be at the time of presentation. At the time of presentation, only 5%, 7%. But in long run, maybe 10 years down the line, up to 30 to 40% develop metastasis, particularly higher T-stage tumors or tumors with poorly differentiated grading, which Madam is going to tell about. So we need to understand the involvement of the cervical lymph node is an important prognostic factor. There has been a lot of, debate going on whether to include the lymph nodes into dissection at the time of primary surgery or not. Some people are doing a elective neck dissection, a lot of studies done with a high stage primary tumor, T4 tumor going intracranial, imaging showing no lymph node but still elective neck dissection, but this has not been supported very well. What we have been doing in our practice for higher stage tumors, when we are irradiating the primary, we include the neck into elective neck irradiation. That is what we have been doing only for high stage primary tumors, not low stage and good prognostic tumors. So that is one of the strategies. There is another classification by Dural. Dural had done a lot of work on this olfactory tumors, and this is now the time for the madam to comment. I have first question, madam. When we send these patients, how do you, how sure about the diagnosis on the histopathology? Your mic is, you have to unmute, madam. Unmute, yes.
Am I audible now?
Yes, yes.
Yeah. So the first time I saw this slide you sent me, it looked typically like a small blue round cell tumor. And there are a lot of differentials in small blue round cell tumor in a sinonasal cavity, as you have already illustrated in your previous slides. So this slide contained both true and false rosettes, which is a pointer towards that we are dealing with probably olfactory neuroblastoma. But at the same time, one focus showed a lot of polygonal cells with keratin in the cytoplasm. So those look like squamous cells. And so the differentials of other differentials like SNUC or NUT also come into the picture. So I went ahead and did, and also melanoma, because in melanomas they look bad. Some cells they look bad. They look
all small round cell tumors.
Yeah. Even rhabdoid tumors, even rhabdomyosarcoma, even rhabdomyosarcoma can look like this.
All these tumors look alike on histopathology.
Exactly.
All have a basic feature of small round cells in the in the histopathology.
Because of the rosettes, my inclination was more towards olfactory neuroblastoma. So first of all, my intention was to rule out epithelial malignancy. I had put a primary panel of cytokeratins, pancytokeratins, EMA, LCA, also to rule out a lymphoma. I say it's not looking like a lymphoma, so I also put a lymphoma marker. And of course, I put synaptochromo CD56 and also an S100 to rule out a melanoma. So the result was that only pan-CK was patchy positive, more so it was squamoid looking cells, and around 10% of the small round cells were also positive for pan-CK, which was membranous positive, and synaptophysin and CD56 were beautifully positive, but chromogranin was negative. So in view of positive cytokeratin, I also put P16 to rule out SNUC and to rule out nut carcinoma. I put a cyclin D1 also.
Can I
so
ask
cyclin D1 came out. Yes.
First of all, for the audience, this is so important to differentiate amongst all these malignancies, because all these have different cells of origin,
prognosis,
different tumor biology, different prognosis, and different management protocol.
Yes,
a slightest mistake in the beginning in reaching a proper diagnosis can result in overall failure of the treatment.
Yes,
you know.
yes,
to
exactly,
reach exactly. All these have a different set of tumors, different biology. So, madam, question number one: when do you suspect a nut midline carcinoma? Why I'm asking for the audience, out of these, the nut midline carcinoma is one of the most aggressive tumors with a life, I say life expectancy of few months, and having same small round cell tumors. Sometimes you can't differentiate unless you have a good immunohistochemistry.
Yes.
And this is very important to understand, to prognosticate, to tell patient what kind of tumor you are having.
So I had put cyclin D1, which is which is very much cyclin D1 and CD34. Cyclin D1, you know, it points us that we are probably dealing with a nut carcinoma. So cyclin D1 and CD34 were negative. But then again, in view of the morphology, just to be sure, I also put a nut carcinoma marker, which is a new marker. It's an IHC marker, which is readily available with us, and that came out to be negative. Now this marker
was a big
shows
relief.
100. Yeah, this marker shows 100% specificity.
Yeah, that is a big relief. Had this
yeah.
been a nut midline carcinoma, the prognosis would have been worst.
Yes.
And you have to tell your patient, in spite of whatever you do, the results are never so good.
Yes.
Another important thing, madam.
Yes, yes, sir.
Like the histological, yes, Paramita.
What about the cytokeratin that madam?
Yeah, the cytokeratin. See, the cytokeratins are they are known to show ambiguous and aberrant expression. So that is why I had put EMA, which is epithelial membrane antigen, and it highlights only the epithelial tumors. So EMA was negative. So pan-CK, we can say that it was probably an aberrant expression of pan-CK that we were seeing in these cells.
So, you know, why again I am emphasizing this fact. In these patients, whenever you get MRI done looking like olfactory neuroblastoma, you can't tell your patient anything, what you are having and how your tumor is going to behave. You need to have a good histopathology, and more than that, this histopathological grading. Because after having this histopathologic grading to me, available to me, then only I can sit and discuss with the patient what is going to be the plan and what is going to be the prognosis. Madam, how effectively you can give this grading in every case?
So in this case, yes, ma'am, you were saying something.
Ma'am, what about the calretinine that is there? That is the 29K DA.
Calretinine was negative.
Okay, but calretinine is a marker for olfactory neuroblastoma.
Yeah, some of the olfactory neuroblastoma is a specific
because it's
marker.
a high grade. It's a high grade olfactory neuroblastoma. That's what I'm trying to say. That's what sir is saying. At Heinz histological grading, if we do this tumor, if we do Heinz histological grading on this tumor definitely belongs to either grade 3, most likely grade 4, because this showed a lot of necrosis. There was marked atypia in the nuclei, and the nucleoli were also prominent in some. But like there was neurofibrillary matrix, which sir has also included in one of the slides. Neurofibrillary matrix was also included, which should put it under grade 3. But in view of necrosis and bad nuclear morphology and the way it is presenting, I have graded it as a grade 4 tumor. And in grade 4 tumors, a lot of aberrant markers and a lot of markers that are usually present with olfactory neuroblastoma might be absent.
Okay. So ma'am, then can you just, to conclude, you can just tell us that what made you decide it is a grade 4, which were positive? What made... So,
okay, I'll just tell you. See, the first differential diagnosis is small cell carcinoma, which is a neuroendocrine tumor. Okay, that was negative. That was that I excluded from my diagnosis because pan-CK showed membranous positivity. And any neuroendocrine tumor does not show membranous positivity. It shows dot-like positivity. Okay, so that is excluded. Now, CD56 synapto and chromo is expressed in both small cell carcinoma as well as olfactory neuroblastoma. But small cell carcinoma in turn does not show this rosetting, and what I said, the membranous staining of pan-CK. So we have ruled out small cell entirely. Now comes an alveolar RMS, which also is a round cell neoplasm. So desmin, vimentin were completely negative. Myogenin was completely negative. Now we come to nut carcinoma, which we have already discussed. That nut marker, which is the most specific, 100% specific marker, was negative. Now we come to SNUC, SNUC, which is sinonasal lymphangitic carcinoma. So P16, which is associated with HPV DNA, that was negative. So Then lymphoma, of course, it was not looking like a lymphoma, but again, LCA was negative, so lymphoma was also ruled out. And what else do we have? Plasmacytoma, perhaps?
Lymph node sampling.
P63, like we had the CK, it also showed aberrant positivity, which can be seen in olfactory, high-grade olfactory neuroblastoma.
Madam.
Okay.
Madam.
Yes, sir.
Dr.
Yes,
Ritu, if I can ask just a question.
sir,
Hello?
I'm not. Your voice is cracking. Yes, sir. Hello.
Yes, sir. Satish, sir. Yes, sir.
Now, what can the final histopathology change with the final histopathology specimen? Do you expect any more tissue for more information?
Yes, sir. We still have a lot of aberrant markers that are being expressed in this particular tumor. So, if we get an excision specimen, we would like to reconfirm all these markers again, and 9% it will definitely come out to be an olfactory neuroblastoma. But again, there is a small doubt of a sinonasal carcinoma, again because sinonasal carcinoma, few of them can show P16 negativity, and also perhaps I don't think anything else, because nut marker is negative, so nut is ruled out. The only thing that can be.
Thank you, madam. Thank you.
Yes.
If anybody has any question to madam, otherwise we'll go ahead with the surgery.
Dr. Ritu, just I wanted to ask one thing.
Yes,
you
sir.
rely more on your immunohistochemistry markers than the actual histopathology?
No, not like that, sir. What I said when I started speaking was my first guess was that we are dealing with an olfactory neuroblastoma. But then to rule out everything else, to rule out every other small round cell tumor, and there was a lot of aberrancy in the primary panel that we used. Pan-CK was aberrantly positive. So that is why I went ahead and excluded every other thing that was possible because of CK positivity.
Okay, that's fine.
Thank you, madam.
Thank you. Thank you.
Thank you, sir. Thank you. Very. Thank you. Thank you, sir.
Satish.
Hello.
Satish, I have a question.
Hello.
Yeah.
Yes. Narayan, are you saying something?
Yeah, I wanted to ask you, what is the role of PET scan in these patients, and when would you do it?
PET scan?
Yeah, in these patients, and when would you do it?
See, generally we don't get PET scan when it is a proven olfactory neuroblastoma. Olfactory neuroblastoma in this, amongst all the sinonasal carcinomas is probably one of the most well-behaved tumors. Not to metastasize so early to the distant areas. At this being a undifferentiated carcinoma, small cell undifferentiated or sinonasal undifferentiated carcinoma with T4 category, I would definitely, think of getting a PET scan done, because then the chances of metastasis are more. With a proven case of olfactory.
Satish, was any role of lymph node sampling in this case?
Not really. We got the scan done clinically as well as radiologically. Clinically as well as radiologically, we don't see any evidence of any metastasis in the neck. Secondly, if it turns out on the final histopathology grading, in the HIMSS grading, it turns out to be having a poorly, differentiated or grade 3 or 4 in HIMSS, or involves the cribiform plate or skull base. Anyway, we'll plan our post-op radiation therapy as well, and then we'll include the N0 neck into post-op radiation therapy. A lot of people observe the neck without doing anything, even when the metastases appear, like in up to 30 to 40% patient after the long periods even. And if they do a neck dissection and radiation to that, it has a good survival. So hardly there is any difference in both the strategies. So according to the primary tumor features and your availability of resources and other thing, you can take your call. But generally our call is to give elective neck irradiation when we irradiate at the primary,
Any specific subsite in is always skull base of the this region, a specific subsite, like since it's an olfactory crest tumor, so any specific area we.
What?
Any specific subsite in the skull base for this tumor?
Yeah, in the olfactory region. Mostly they arise in the olfactory region, in the upper part of the nose. Now see, this tumor I told you is quite vascular.
Yes.
And the first part, my first part is, you know, this debulking of the lesion to reach to the area of attachment. See, just fast debulking by means of using this microdebridement and all can minimize the blood loss. If you go faster, if you go quick, you take less time in debridement and the overall bleeding will be less. Generally broad, generally broad. They almost always have an attachment on the nasal septum. They are lateral wall spring. Yes, sir. See, sir, these tumors arising in the upper part of the nose have a tendency to grow on either side. They may, in the early phase, they may go up, erode the cribriform and go up in the brain. Similarly, they may come down, both ways. Incidence-wise, not very common, but not uncommon as well, I would say. Yeah, it can go either side. See, this is all luminal component which I am debriding. All luminal component. Yeah, sir, exactly, sir. Yeah, I will, at the appropriate time, I will mention. See now, this was all luminal component, wash. Luminal component which is out. See this part of the septum which is involved, can you see? This part of the septum is completely involved by the tumor. And we knew this from the, radiology as well. And see, the lateral wall is completely spared. This is all pressure. This is the, lateral wall, the nasolacrimal duct region. This is your uncinate. See this? This is your ostium area. And this is all completely spared. Now, in the larger lesions, they can involve the ethmoids as they grow. They can go up inside the brain. They can spread laterally also, but preferentially they don't spread laterally. I told you, they are, orbital sparing lesions most of the time. Yes, it can. Very commonly. As it grows behind, it can involve. We have seen couple of times. And that's why your planning reconstruction is always in question. See the luminal component further, and majority of the blood supply to these tumors comes from the ethmoidal vessels. That's why when we reach to the site of attachment, we coagulate the ethmoidal vessels first. See, this is all attachment above. You are asking about the attachment, it is so diffuse. Everywhere, see this? And ultimately, our goal is to take a complete margin of resection. Coagulator is a very, very important tool. All these vessels are by and large coming from the anterethmoidal system. So this is the debulking on this side, you can see now. And I will just leave a pack for a while. My field is good now. I can see my area of interest very well now, which is circumscribed. If this tumor goes intracranial, we have many times addressed even the huge intracranial lesions by endoscopy. Except some certain contraindications, these tumors can be very well managed by endoscopy because they grow in the superior inferior axis, not laterally generally. So those contraindications to me, if you ask about the endoscopy, the first is the involvement of the orbit. If the involvement mandates the orbital, exentration, I have to convert to an open approach. That cannot be done endoscopically, number one. If it involves laterally, lot of brain tissue laterally or the due laterally above, you can't resect and reconstruct thoroughly. If it involves the brain massively, obviously is a contraindication from endoscopy. If it involves the frontal sinus bone, facial tissues, any soft tissues on the face or anything, it is a by and large contraindication for endoscopy. Rest, whatever big tumor it is, whatever up it is going in the brain is not a contraindication. So this now the picture is much better for us. Yeah. Yes. दूसरा. Yeah. Yeah. See, Narayan, I tell you, if you compare with the past studies in these sinonasal pathologies for anything, maybe benign, malignant, whatever, there is significant change what you see in the literature because the development of this endoscopic science. Now, majority of the lesions which were considered to be inoperable by endoscopy earlier are now being taken up by endoscopy much better with much better scientific indications. So now the philosophy has changed and you can't compare the results what you see in the literature in the past with the open approaches. Things have drastically changed. The reason is visualization offered by the endoscope. Our next case is a huge, intracranial spread. That's a chondrosarcoma, you will see. But still my preferred approach is endoscopy. Our plan is a combined approach, but to begin with endoscopy with certain advantages which I am going to share in the next case as well. Now see where I am. Where I am in the opposite nasal cavity. Can you see? And here, as I mentioned during MRI, my goal is to ensure the Hadad flap where it is something I can elevate or not safely. Safety is a big concern because the septal mucoperichondrium is involved on the opposite side. We never know whether it is through and through involving the opposite, nasal septum or the mucoperiosteum of the opposite nasal septum or not. Wash. Hope the picture is good. See this is the choana and this is the middle turbinate. This is the septum on this side. I have little lateralized the inferior turbinate and now I have a good picture of this nasal septum looking nice by and large so far. Now I will medialize the turbinate. Yeah. Yeah, depending upon the resection, how anteriorly you are going. If you are going right to the frontal base, you have to have a long Hadad. Otherwise, it will fall short. And if such a situation, you can, bring in the pericranial flap. The easiest and the fastest. Yeah, you can take even without any issues. Even if that falls short after that, then you have to bring in something from outside. If you really want a vascular flap, because in that situation, once you have such a big effect, the free grafts are never good. Now see some more anatomy coming. Yeah, this is the superior turbinate, inferior, the middle septum, and this is the superior turbinate. Now, anyway, we have seen the MRI. We have to do a proper approach with wide excision. We have to resect the superior, the middle turbinate on both sides. Scissors. See, this part of the septum is dicey. Can you see above? Even I have a doubt of infiltration. I have to be very, very careful. So what I am doing here, removing this part of the middle turbinate, the vessel at the posterior end. Yes. Yes. Now the issue is involvement of the posterior most part, whether I will be able to get the hadad or not. See this still. This part of the septum is not looking good. Yeah. Even if I get the lower part, I will be more than happy. See my pedicle there in the lower part? And if this part, if I find intact, anatomy of normal side lateral wall flap. I can harvest the lateral wall flap, but for bigger defects, again that is inadequate. In smaller defect, we have used couple of times. It's a good one, but for bigger defect, again it's not a first choice. Best, pericranial is so fast, so versatile. Now see the region of the sphenoid ostium above, here. Here is the region of the sphenoid ostium, you can see. See that? And see that is the region of the ostium, and that is the region of the choana, and that is where my flap is. Now this upper part of the septum is something I will not include. See this? I knew. See the importance of radiology. MRI already told me that this area you have to be careful. Yes, that's what. If I find I am away, nowhere, going into the tumor, then only I will go ahead. This was our original plan to, debulk the tumor on the opposite side and then come to raise the hadad. That is the first part.
Yeah, raising the hadad is the first part of the step of the surgery.
Yes.
The septum looks so soft. If you don't have a bone, it's more likely that the septum is involved in that on that area which you are palpating.
Yeah.
Don't you think it is involved?
Pardon?
Yeah, that's what he's saying.
There is no bone over there where you are palpating. It looks like tumor is pushing against the septum.
Yeah, it looks like in the upper part.
Yeah. So do you want to get this hadad, or do you want to still go for?
No. I have already mentioned.
Yeah.
In my posterior area where my pedicle is, I don't want a big hadad going up from there. I will be happy taking the narrow pedicle from behind and then taking the anterior part. See, it is absolutely free anteriorly.
Yes.
Yeah.
So, only issue is, will I be able to pick up my pedicle free of disease? That is the main question.
Yes.
Let me see. Panjal. See, that is level of my that is the level of my ostium.
Yeah, boss. The upper part of the pedicle.
I am making this horizontal incision just below the level of the ostium. Can you see?
Yes, boss. So, boss, can you feel the cartilage here? I'm in the bone here.
I can't say for sure. Now, let me see. Now this next step will tell me. Yes. Yes. Can you see this region?
Yeah, we can see the bone posteriorly.
Yes, absolutely good.
Yeah, boss. Yeah, we
And
can see the
this
bone.
part of the septum appearing very good from appearance, you can say. See this? Can you see very well? See this?
Yes.
Yes.
Now let me remove the pack of the opposite nose, because it is giving pressure.
Yeah.
And you'll be able to appreciate better now. It is so good. I am so happy here that I'll be able to raise the hadad safely. Can you see very well?
Yes, sir.
No involvement in the region of the hadad. Can you see? Agreed or not?
Yes, sir.
Yes, sir.
Why I am raising that I may need this flap for the reconstruction. I can't raise it afterwards. So in case it is not required, I will replace it. Okay?
Yes. Absolutely.
But I should have liberty to raise this flap, and that is only in the beginning. See now, this area I have left absolutely intact.
Yeah, boss.
Yes.
Agreed?
Yes, sir.
And now I can raise this flap. Now I can ascend high up in this region where there is no tumor, I can say, anteriorly here. See this?
Yes.
Yes, boss. So
Absolutely
boss,
good.
Absolutely good. Anterior part is good, boss. So boss, we can even lengthen a little the length of the flap by pediculing the flap exactly at the sphenopalatine foramen also. If we need a little more length sometimes.
Yeah, you can. If you want to, lengthen it.
Yes.
You can do that. Oh.
You can see the spur on this side.
Yeah. But I had a small nick on the flap. It will not affect. No worries. So I will just, elevate it and park in the nasopharynx. My first concern is over. I had a big concern whether I will be able to elevate the hadad or not. And now I can say I have a reasonably good hadad. And the Rajiv, like you said, you can include the skin without any issues.
Right, boss.
And see, I am not infiltrated at all. Never.
So, why, boss? Why?
In flap, you don't want the infiltration because you don't allow the vessel to go in a span. You don't want.
So can we hydrodissect the
yes,
flap?
You can inject saline if you want. But see, we being otolaryngologists, we have been doing septoplasty often.
Yes.
And we are good at raising the septoplasty flaps. We can manage it.
No problem, yeah.
But you are right. In case you find difficulty, you can always do a hydrodissection. See, this is so uninvolved flap.
Yes, sir.
Again, you can confirm. At any point of time, I have a slightest doubt of the involvement. I will not think twice. So sacrifice it. I hope it is sound and clear.
Yes, sir.
Depending upon the need of the width, you can raise number one. Number two, I don't expect a huge, broad defect because my area of interest where I am suspecting the skull base involvement is not very big. That is still doubtful. I am anticipating the skull base resection, so I am elevating.
So Dr. John Shadow from Australia is asking, will you do a frozen section of the rescue or the Hadad flap before using it?
Or the Hadad flap?
Yeah.
Hadad flap is not needed. I told you, see, I have an endoscopic visualization and the field. On the slightest of the doubt, I would sacrifice. I have other options. I will not keep my patient in this big trouble of inserting a flap which is involved by the disease. See the superior part?
Yes.
Left behind?
Yes, sir.
Only the inferior part of the flap is going to be elevated. And this is something we'll park in the nasopharynx. See, this is I have to further elevate and park. You have to be little careful here, not to, because you are not sure about the integrity of the bone or the cartilage. So stay a little extra careful here.
So Dr. Vinod Kumar is asking, what are the behavioral similarities of the olfactory neuroblastoma with retinoblastoma, both having the common ancestral cells in
the location? Retinoblastoma is, the orbital tumor. See this flap?
Yes.
I have a pretty good flap. Separated. And I am just pushing and pushing it in the nasopharynx. And here being extra gentle. Because I don't see at every place behind the bone. Because of the pressure or maybe involvement. See this?
Yes.
You have to be careful. Because you are not supposed to go out of the plane here. Put up. See, this is a very, very important part. Yes. So now, what I was doing was pushing the flap behind.
Yes.
Elevate. Wash. Wash, wash, wash. Yes. Push my flap behind, you can see.
Yes.
Completely elevated and push. See the part of the flap. Can you see?
Yes, sir.
I will not disturb it much here. I will leave it like this. And this is now away from our area of interest. Okay?
Yes, sir.
Yes. Clear?
Yes.
Now coming to the original part. Once we remove this part of the septum, then only we will be able to see the rest of the extension of the tumor up. See, this is my flap which is left behind.
Yes.
Yes. We can see.
So this is parking of the flap.
Yes, boss. Yes.
This is not a classical Hadad. Every time, according to the situation, you have to modify. Good?
Yes.
Now, give me the debrider. Publicator. Now, looking at the involvement of this, septum, I will take my cuts accordingly on the septum. Can you see here?
Yeah, we can see that.
Can you see here now?
Yes.
Yes.
This is the septal involvement, and I am going a centimeter away. See this?
Yes. Yes, it is clear. Boss, can you tell in this case what are your anterior, posterior, and lateral limits of dissection?
According to the tumor, see this? According to the involvement of the septum, I took a call of septal removal.
Yeah.
Because malignancy involving the septum, you can't leave it, and you have to have a good margin as well.
Yes.
See this now?
Yes.
Crystal clear. Ultimately, the resected margin should be negative. Ultimately, the resected margin should be negative.
Absolutely.
See this septum?
Yes, Satish.
This is what I am removing at this point of time to give me, because ultimately it has to be removed. But this will give me extra space.
Yes, yes.
Here I will remove it, and then I will go into the deeper areas. Wash. बोलना पड़ता है.
Boss, in cases where the disease is only limited to one side and the septum is not involved, find any difficulty in four-handed maneuvering?
You don't require 400 always. Why?
So because you are moving through only the one nostril in that case.
Yeah, you can manage. You can manage. थोड़ा बड़ा देना pack. See, until now we were using only one nostril.
Yes.
Yes.
Still we are using 4 hands.
Yes.
That is a classical technique, but many a times it is not possible. Now let me clean the area and show you our margins. This is malignancy. You have to respect the oncologically, sound procedure. And every time we have to define our margins. Removal of the piecemeal removal of the disease is not affecting, the outcome. Outcome is affected by ultimate margins. Now below, there is nothing. I kept my flap in the coina, and these are the, gauge pieces over the flap. Let me show you again. On both sides, I have removed them just to give you a overview.
So these gauge pieces protect the flap from being sucked by the suction.
See now, and whatever lower septum I left behind is absolutely free of disease. Agreed?
Yes, sir.
Yes, yes. Looks healthy.
And we have already taken the margins all around. Very good margins. This is the part of the nasal septum, uninvolved, but here I am removing the upper part of the nasal septum to give us a good picture of the cribriform above.
Satish Jain, sir, Dr. Vinod Felix here. Would you really try to get an end block resection in small tumors? Because even though we say that piecemeal is okay, but I always feel it's better to go for end block in small tumors. Do you concur or differ?
First of all, welcome.
Thank you, sir. Thank you.
It's a pleasure to have you. For audience, I welcome Dr. Ipacharian, who is a fantastic Vinod Felix. Sorry.
Vinod Felix.
So, Vinod, your question is valid. When to take an en bloc resection? As I mentioned, even if you do piecemeal with the margins taking en bloc, the results are same. En bloc you can take for very, very small tumor, not for all. Number one. See my anterior margin I have defined, I had seen in the beginning. I had seen in the beginning where my tumor was reaching up to anteriorly, and I've taken with the coagulator my anterior margin way beyond. Is that clear?
Yes.
Yes.
I have taken my septal margins below. The only area now I am keeping for the last is the sinuses, and then the midline skull base. See why I am exposing this midline skull base, so I can see whether the tumor is going to the opposite side or not. See, this opposite side here is absolutely free.
Yes. We can see
My
the
area of
hormone
interest,
mucosa
my
on the
tumor is here. Can you see here?
Yes, yes.
Yes.
Very clear.
Yes, boss.
Yeah, divider, no? See, the opposite side is crystal clear here until now.
Yes, okay.
See this. See, I am on the opposite side of the septum. Just to give you an overview of the skull base. Can you see the skull base?
Yes.
Yes, sir.
And this mucosa absolutely normal. On the opposite side, see, very clear.
Absolutely.
What my aim is to circumscribe from all around, so that we can focus on the area of interest.
Yes.
See, we have circumscribed from the opposite side as well. We have circumscribed from the anteriorly. We have circumscribed from inferiorly from the septum. The area where tumor is attached to the anterior ethmoidal skull base on this side, and that I kept for the end, so that I can remove it under vision with good margin. Opposite side.
We have very good margins on right side now.
Yeah, yeah. I knew from the MRI the tumor is not going high up on this side. You could notice on the MRI.
Yes, yes, boss.
See this? Now my area of interest starts on this side. But tumor is predominantly left side. We saw the tumor was not going inside the eye. What was in close opposition with the lamina papricea. Okay? And
Yes,
now I will start dissecting my ethmoids on this side. So far it's just, at one by one area I am circumscribing the tumor. That's it. And now I can...
So what about recurrence cases, sir?
Again, if it is resectable, the primary treatment is surgery.
Okay.
See, for any residual disease or whatever, adjuvant therapy is never an answer. That is always adjuvant. That is not primary therapy.
Resection is
there. Yeah. For such tumor, resection is the only answer.
Okay.
And adjuvant therapy cannot take place, the primary therapy, in the sense that if you see, you have an option of giving radiotherapy and leave some primary tumor. That is not acceptable. That cannot work.
And what about post-op radiotherapy, sir? In which cases?
Mostly in advanced cases. Mostly, in cases, even in the small
neck
tumors.
is involved.
Small
neck
tumors.
dissection.
Yes, neck involved is always. Small tumors, when you are not sure of margins.
Okay.
Or your margin turn out to be positive.
Okay.
Then obviously. If you have a frozen and if you have a good status of margin, doubt about the excision of the margin, you can immediately extend your resection.
Okay.
So in cases where the brain parenchyma is involved, do you consider pre-op chemo RT to shrink the tumor and make it resectable?
Yeah, if the pure parenchyma is involved, this is something you have to think twice before going endoscopy. Yeah, because then it is difficult to control the adjacent vessels, number one. Difficult to give a safe margin from below. In the patient's interest, if the brain parenchyma is involved as such, we should go, from above. Now, with this picture, Posteriorly are the this septum, posteriorly are the nasoseptal flap we have parked. The opposite side is skull base we have seen, and now we are going to our area of interest on this side. And first, I am quite sure this tumor doesn't invade the orbit, and it has not invaded the orbit. How would I now get to know? First, I will open my maxillary antrum and follow the medial wall of the maxilla. See quickly.
Yeah.
Yes.
Red 40. In a minute's time, this is my maxillary sinus, you can see. See the retained secretions?
Yes.
You saw on the MRI retained secretions?
Yes, sir. On contrast.
MRI can easily differentiate between the secretions and the tumor. On CT scan, everything looks same opacified. Now, see, keep an eye on where I am going. This is the roof of the maxilla. And from here, following the uncinate, see this? I want to reach a very important landmark, that is lamina papracia.
Yes.
This will make very, very clear what our MRI was saying. See this absolutely clear?
Yes.
Yes, Satish.
I told you this olfactory neuroblastoma is generally orbital sparing. See the lamina with good mucosa over it.
Yeah, we can see it, yeah.
All the way.
Yeah, so boss, will you include lamina in the specimen now?
Pardon?
Will you include lamina in the specimen now or not?
No, not really. I can see the good mucosa over lamina, boss, all the way. This tumor was coming here. It is not invading. See this?
Yes, yes.
That is the advantage of endoscopy. You can have a good, see this is tumor. See this?
Yes, we can see.
But is it not better to get a complete bony box around the tumor? So if the tumor is going till the lamina, you get a lamina also.
See, I have such a good margin.
Okay.
Good visualization all around.
Boss, Dr. Abdullah from Iran is asking, what if eustachian tube is involved by the tumor?
Eustachian tube is unlikely to be involved by the olfactory neuroblastoma, number one. Involvement of the eustachian tube requires, if you are operating for a tumor, with the aim of radical resection, it requires a nasopharyngectomy.
Okay.
You can do endoscopic nasopharyngectomy. Probably very soon we are going to keep a case of nasopharyngectomy for a malignancy endoscopically. Post radiotherapy it was. See this now on this side. See this margin. See the surface. Can you see the tumor? And can you see the underlying surface everywhere? Absolutely normal. Can you see or not?
Yes, we can.
Yes.
That is important because endoscopy, that is the advantage of endoscopy, that is visualization. Now, anteriorly it is not involved. I will come with a 70 degree to show you the, that is the area of the frontal sinus. Going up, I am with a red 40 blade with 0 degree only.
Okay.
See, that is the area of the frontal recess.
You can see the frontal sinus recess opening.
Recess outflow here. So that is, again we knew that was free. See now, I am circumscribing from the left side as well. Coming to the site of attachment. Okay? This is our tumor. Laterally it is nowhere. See this?
Yes.
Very clear?
Yes.
Very clear.
But Dr. Satish, when you send for frozen, this will be only tumor and no margin, no free margin we are sending for frozen on the lateral side.
On the lateral side, when the tumor was?
No, when we are removing the tumor for frozen section, we cannot have the margin, whether the margins are free or not, because this is all the tumor we are sending.
Yeah, so in endoscopy, this is very common that the surgeon has to decide, because this tumor, see, I have elevated this tumor.
Yeah.
See the tumor
we can
surface.
see a free area, It's a healthy lamina,
so here you don't
so
need
why
margin.
we should disturb it?
Here you don't need margin, once you are sure. Margin will be needed, I am coming, sir, to the area where the margin will be needed. That will be to the site of attachment.
And by now you were using only debrider. Any place of coagulator here, because suppose if it bleeds, to stabilize, do you use the debrider?
Yeah. Debrider is has a ability to debulk faster. So I was removing with the debrider not only the mucosal surfaces but the septation as well. It expedites the procedure. See this now to show you. Absolutely clear?
Yes, sir. Actually, a beautiful dissection, but I think most of the cancer surgeons always ask us to remove the lamina also, because the tumor is right in contact with the lamina.
Had I been having a slightest, doubt of attachment on the lamina, I would have been removed by now. It is just coming, falling upon. It is not taking any attachment there. That's the difference. And that's the anterethmoidal artery. Can you see?
Yes.
And this is the big source of, bleeding. I told you. The ethmoidal arteries are the important source of bleeding in these tumors. And here, to minimize the blood loss, I am going to take this artery. See this?
Yes. Boss, Alina from Australia asking, any role of narrowband imaging to see involved mucosa?
Yes, it's an important question. In all these tumors, the narrowband imaging can give you a fairly good idea, differentiating the extent of tumor on the surface from the normal area. On the surface, narrowband imaging, assesses the surface vascularity, doesn't show the depth. So, like suppose my tumor is attached here on the surface at this point. And if I see my narrowband imaging showing this extent of tumor extension on the surface little beyond, if I don't have the narrowband imaging, I can miss that, and that can turn out to be, if turns out to be positive, then it is not your adequate resection. So narrowband has a value in decision making. Point all. कहाँ से आ रहा है ये? Midline. So now the question is, where do I ablate this vessel? See this course of the vessel?
Yes, we can see it, the orbit and the cranial end.
Once you have a coagulator, it is a better tool.
Yes.
See this? I will first ablate, coagulate.
Yes. Boss, I have also read in few of the texts, but never seen putting clips on the anterior ethmoidal arteries.
Yeah. It's not actually not essential.
Very visible.
See this now, the artery is transected.
Yes,
see?
Yeah.
Very clear? This is the area of the skull base where the tumor is attached to.
Yes.
Now we'll come again from all around and we'll do a little bit of the debulking of the tumor. Again, see this. Let me remove this debrider. That's a very important, interplay between the coagulator and the debrider in this surgery.
In fact, most of this head and neck surgery means nasal surgery.
This is also one of the biggest advantages, that we devascularize the tumor from below first.
Now see, the opposite side is good.
Yeah.
This is the area where the tumor is attached to.
Yes.
Yeah, seeing clearly.
Now give me the debrider to debulk this tumor little more. See this tumor here on this side, this one?
Yes, yes, yes.
Yeah.
Yes.
So I will debulk to reach towards the attachment. The aim is to reach towards the attachment. See, whatever tumor, this big tumor is visible, is not having that way an attachment.
Yes, yes.
Okay, give me.
Till now, have you sent any specimen for frozen?
Not
Dr.
really.
Satish?
I want to send a margin, sir.
Yeah, so you are still not sent anything, I think.
Yeah, yes, I have the diagnosis. I still can send a part of it.
Yeah.
But
More interested in the margins. Yeah.
Yes, that is most important.
Yeah. And as a message to all, is it mandatory to have a frozen section facilities in your place where you are
Yes,
operating?
yes, sir. For such tumors, I would say yes.
Yeah.
That is the
Because that
most
only,
important
that
part.
only can make you sure.
That
That
is
only
the,
can make us sure.
that is the most important part of your decision making.
Yeah.
Yeah.
So that is the part that is going inside the sphenoid sinus as we push.
And see, this is the part where the skull base is dehiscent. Can you see this?
Yes.
Yes.
Yes, yes, yes.
This is the part where the skull base is dehiscent. See this bone?
Yeah, yeah.
See this bone?
Yeah.
And that's the normal dura you can see.
We can see the normal dura bone.
Can you see very clear?
Yes.
Yes. We can see the medially the dura is infiltrated also.
So
Is
we
the dura
have
involved
very
medially?
Clear anterior limit now, boss.
There is a dura infiltrated medially.
See this mucosa? I am elevating this along with the mucosa so not to leave any chance of, That's it. See?
That's it, yeah. Yes.
And our MRI has shown that to be the upper limit of the growth. Is that correct?
Yes. And see this area.
Yeah.
Section. And now I will resect this at this point of time. This is absolutely fantastic. Skull base behind.
Yeah, you got a nice margin all around, Satish.
This is all secretion in the sphenoid. See this?
Yeah.
See the secretions?
Yeah.
This is all retained secretions.
Yes.
All
The
retained.
tumor, the tumor came out from the sphenoid sinus. No? We
Yeah,
saw
yeah.
the
Only,
tumor.
only this area of attachment. See where I am. This area of attachment I have to handle. See here above on the cribriform plate.
Yes, yes.
Only this area of attachment.
Just posterior to the normal dura that you just
Yeah, yeah.
shown.
I will show you the normal dura and all. This is all I have already removed. I am just giving you a inside picture of the sinuses. That is the inside picture of the sinuses. See this? Both sides? All good?
Yes.
Yes, yes.
Yes.
See the sphenoid sinus on this side as well as this side. I told you it is not involving the sphenoid at all. That is the level of the sella behind.
Yes.
Give me the coagulator. That is the level of the opposite, looks like septal branch. That's it. Divider. And now I'm reaching up to the skull base where the cribriform is, which is of area of interest.
Yeah.
This one.
Yeah.
The opposite side is pretty clear. Now there is always a debate, you know. Once the skull base is involved, whether to remove the bone, whether to remove the dura, whether to remove the olfactory bulb or not, to what extent we should remove in such neuroendocrine tumors, you know.
Yeah.
There is no point if there is no gross involvement inside, region is going up to the dura. See my area of the olfactory area.
Yes.
In the center now, which I am going to remove as my safe margin. See this?
Yes.
Rest is all clear, right? Right from lateral to medial, you can see curved section. Everything is pretty clear.
Yeah, yeah.
And this area of interest, I am going to remove.
Hey, Satish, in your view, what is your view when people say that removing the cribriform is enough without resection of the dura? What is your view on that?
I can't hear you.
I said, what is your view when people say resection of the cribriform plate is sufficient without excising? What is your view?
Your voice is breaking.
No, the question is, what is your extent of resection the cribriform plate? You go to the dura, whether you go to the olfactory bulb.
You have to take a margin, you know. Now, if my lesion is going up to the cribriform, here, I will take a margin of the dura over here. See this?
Okay, sir.
One level margin you need to have, curved section.
So if it is going to the dura, you will take a margin of olfactory bulb.
Yeah, then obviously, then you can't take a chance. See this retained secretion in the frontal.
Frontal sinus.
Okay, sir.
That is maxillary. That is your level of the orbit everywhere. See this?
Yeah.
Completely free. That is your skull base. That is your skull base. That is your sphenoid on both sides.
Yes, yes, very clear, very clear.
Skull base on the opposite side now you can see.
Yes.
Yes.
Everywhere. And that is your ethmoidal artery on the opposite side which I am going to take.
Okay.
And that is your frontal sinus on this side. Though I didn't do a formal frontoethmoidectomy on the opposite side, you see.
Yeah.
That was not required. In a more midline tumor, more extensive tumor, I would definitely do that. Glue. Now see with a 70 degree.
Yeah.
Can you see?
Yes.
Yes, yes.
That is the frontal sinus on this side. That's the maxillary sinus. That's the entire orbital surface. And I will clean the skull base and show you something. Let me. This cribriform is not good. And in a malignant tumor, in a 40-year-old, my goal is radical.
Yeah.
And these are, believe me, favorable tumor. A good radical surgical resection gives a cure in majority of the patients. See the opposite frontal?
Yeah, beautiful.
Yes, Satish.
First. I hope you are all oriented where exactly I am.
Yes, yes.
Yes, yes.
This is called transcribiform approach because we are going through the cribriform plate. If had been a far anterior extension towards the frontal bone, I would do a draft 3 and expose the more and more posterior table of the frontal bone. along with the transcribiform. That is the indication for the draft.
Yes.
In this approach. Now see, this is my cribiform plate on this side. Oh, sorry. This vessel on that side.
Anterior ethmoid on right side.
Yes. And this tumor is behaving so well after devascularizing from this side, anterior ethmoidal. You can see only this involvement, attachment to this region I have to clear off. See the vessel?
Very clear, boss.
And now I will completely devascularize it.
So Satish, if you get a good resection margin,
yes, sir. Yeah.
If you get a good resection margin, but a poor Hyams grading, will you still subject the patient for radiation?
This I will take the decision on the basis of pathologic grading, Hyams grading.
That's what I asked you.
See now, the entire thing is in the center. If I have more necrosis, mitosis, poor, grading, it is better too, because otherwise the recurrence at the primary site is more difficult to deal. These patients generally do not develop the classical distant metastasis in the beginning. They develop leptomeningeal metastasis in the brain, in the dura, and those are more difficult. So frustrating, helpless you are then to do anything. So best is never take a chance at the primary site. Secondary, I told you, even if you don't do a neck dissection and the metastasis develop later on, you can take a call with hardly any difference in the overall outcome. But primary, you can't take chance.
So in your decision making, when you have a good resection margin, but you have say Hyams grade 1 or 2.
Yeah, then I will not.
Then you will not send the patient. So what will be your then for the patient?
Just follow up. See that?
Yeah.
That is the area of the cribiform which I want to resect. Clear? Gila. Hello?
Yes. We can
now,
see.
Yes.
See the picture now. I hope the picture is good.
Yes, very good.
This is 70 degree to show you the picture of the cribiform plate. I can remove this cell as well. Debrider. See the panoramic view of the skull base.
Yeah, we can see both frontal, both sphenoids and the complete skull base in one go.
Everything in one view. I have not done the classical, ethmoidectomy on the right side. I didn't open the maxillary sinus, didn't open anything. Whatever required, they have already come in view. See the sphenoid there upon the opposite side. See the frontal opposite side. And the ethmoidal labyrinth as well, which is in relationship. Now I have to decide a good margin. That is something most important, Cloud. Recently you see so many publications and sinonasal malignancies, and more emphasis is on histology driven treatment. There's a classical example of a transcribiform. See this?
Yes.
This part of the dura. First of all, give me the drill. Here up is the crista galli, which we'll remove. Here up. See here in between. See this bone?
Yeah.
That is the crista galli.
Okay.
That is a part of the perpendicular plate of the ethmoid bone. You know?
Okay.
So as we go there, we will remove that later.
Also, you told that the cribriform plate at that point doesn't look good. So what was you implying at that time? Where?
Pardon?
You told that cribriform plate at some point doesn't look good.
Cribriform plate at?
Some places.
It doesn't look good anteriorly.
Yeah, this one.
Yes.
See, now I am defining my limits laterally, anteriorly, posteriorly, everywhere where I find the fresh area. Can you see this?
Yes.
In the classical transcribiform approach, when you have a big lesion, you may have to go right laterally up to the orbit.
Yes.
Here I don't think. I have a good margin around. See this?
Yes.
Yeah.
First of all, I am defining.
I think you're getting a fantastic margin around.
Yeah, beautiful.
Are you happy, Narayan?
Yeah, very happy. Satish, you've got a good margin.
In fact, you can go more anterior, I think.
Yeah, I will not hesitate if I find the need. Lothrop is not needed in this case.
No, not needed. No.
I see this is my coarse diamond bar.
Yes, beautiful.
30 degree from the Medtronic.
Yeah, it's cutting beautifully, boss. So this drill is must for Skullbase if you are doing Skullbase.
Yeah, certain equipments are invaluable. This camera is a Carlson's Spice camera. By and large, I cannot operate without this camera. So addictive. Don't see anything without this.
Yeah.
Telescopes, Carlson's. Certain tools are invaluable, you know. Instruments, even the fine instruments, most of them are from Carlson's. See the normal dura, which I am trying to find all around.
Yeah, it seemed quite clearly.
See, this is tailor-made approach. You are not supposed to go by, you know, that you have to go right till the orbit it is necessary. You have to take margin. The call is something you have to take in drop. There's nothing hard and fast.
Yeah.
Section. Carry some, no? Section. See, I can see the good dura inside. Uninvolved area. Can you see?
Yes.
See the good dura?
Yes, looking good.
You're doing such a good drilling with your drill itself. I mean, you were drilling beautifully with the drill. So now why are you trying to use a punch additionally?
Yeah, I thinned out so that I can see better now with the punch. I want to assess with the punch. I can feel it. Yeah, it is better, you know, under your control. See this dura all the way?
Yeah.
Since the dura looks healthy and uninvolved, we don't have to resect dura.
Olfactory bulb. You don't have to.
Yeah, Satish.
Punch is better.
Yeah.
See your cresta?
Yes. First olfactory neuron, it looks like.
How the entire plate is coming, boss?
The olfactory bulb from either side you will remove?
No, if it is not involved, why to? क्या हुआ?
Yeah.
I am taking this dura as a margin. See, in the center and the margin all around.
Yeah.
Yes, yes.
This is classical of the transcribiform approach. Now, this 30-degree, 15-degree curve on this drill
makes the life very easy.
Yeah, that is game changing.
It doesn't obstruct your vision. That is the main advantage.
Yeah, your shaft doesn't come in the way.
Yeah. One basic question, since we will be leaving some part of the olfactory bulb as it appears right now, patient will have some smell?
No, the smell is going to go.
Going to go.
Because you are taking out the epithelium.
Yeah. And that we cannot leave.
Yes.
Yeah.
Even that this patient was not having any issue with the smell at that time. So I think we have to
carry some. Now, I will go later. I will make an entry inside and see. Yeah. Sometimes you get surprises, even your imaging has not shown you something.
Mm-hmm.
You know?
Yeah, yeah.
There is always a possibility of surprises. See now, this is our area of interest, very clear?
Yes, yes, yes.
Nice.
Yeah.
सीजर्स तैयार रखना मैं बाद में लूंगा looks good. Yes, here inside is the fox.
Yeah.
Here inside is the fox cerebri.
You can see.
I will show you. See, I am entering on one side, strictly sticking to the dura.
Yes.
Can you see?
Yes, yes.
See the gyrus rectus.
Yes, nice.
Yes,
nice.
About to come.
Okay. हल्का. Yeah, just a minute.
Difficult to manipulate at this level with the
yes
very narrow area and
is it dura? This part?
Yeah, that is dura.
Yeah.
That is dura. Yeah.
That is dura.
It looked healthy, so we thought probably you will not open up.
Yeah, I am going to the healthy dura.
Yeah.
Can you see?
Nice.
See the olfactory bulb.
Excellent view. Yeah. Now it is there.
Let me show you. Look now. Inside. Show देना. छोटा मेरा cell. See now. Can you see the olfactory tract?
Yeah.
yes, beautiful. Going down here.
See, this dura is involved here. See this. See this involved dura.
Yes.
Yeah.
And bulb behind is absolutely clear.
Yeah.
It's not matter of preserving that is going to preserve us something, but that is something showing us merocell, small merocell. I will just push a small merocell inside.
Yeah.
It will help you create plane, yeah, boss.
This small merocell to protect.
Yes.
Protect the brain tissue, okay?
Yeah, boss.
Now see what I am doing. This is my region of the fox, anterior, yeah, anterior.
Boss, you always
with my coagulator.
Yeah.
Yeah, I'm just coagulating this. Coagulating this region with the coagulator. See this?
Yeah.
See this.
Why coagulating that reasons, Dr. Satish?
This dura, some vessels, and I am. Yeah.
Because there was hardly any vessel visible.
No.
Achha.
That is not here.
Yeah.
But as I go toward the midline, I'll be approaching the fox.
Yeah.
Yeah.
Now I'll show you a better picture. See this?
Yeah.
Inside is pretty clear.
Yeah.
All these vessels should be respected here. And this merocell creates a very good plane. See this?
Yes.
My resection is a pure tailor-made resection.
Satish, since spell is already gone, then why to preserve the olfactory bulb?
No, nothing. But why to unnecessarily? That's a part of brain tissue.
Just for the...
Why I may start any issues inside with the bleeding or anything. Unless it is required, I will not think twice.
Because when we are removing crista galli, so how to prevent injury to the fox cerebri?
Fox cerebri? That you have to coagulate. That's it.
Okay.
What's the matter of injury? See this, what I'm doing exactly what you are asking.
Okay.
See this region?
Yes.
I'm using my coagulator. See this?
Yes.
Dr. Satish, the dura open brain behind, is it a good idea to use coagulator or a bipolar?
No, coagulator is pretty safe, sir.
Okay.
In fact, more safer than...
Coagulator is ultra safe.
Yeah, it is not generating any heat. You can say that way only
not at all. Not at all.
Yeah.
It is irrigating also.
It is much better than bipolar, I tell you.
Yeah, it is better than bipolar.
It doesn't give collateral damage, even that given by the bipolar.
Because I have seen most of the neurosurgeons, they are using bipolar. They hardly...
Yeah, bipolar is standard. I am not denying it.
Yeah.
But we have a better alternative.
Right.
Which probably many of the my neurosurgeon uses coagulator very freely.
Okay. But most of the neurosurgeons don't.
are not exposed to coagulator, part of the
Yeah.
cresta.
Yeah, that's the thing.
So that is the fox. And see, let me define my lateral side on this side as well. And also, yes. Oh. छोड़ो मेरोसिल
Can't you anti-tumoral?
No, anti-tumoral is nowhere. No vessel. ऐसे no, अबे भाई ये देखो. Hardly anything. Just I am pushing my, gel foam behind. This marrow cell behind. See now that gives me enough space.
Yes.
To work.
See this?
And it prevents bulging of the brain tissue from inside.
Yes. Coagulator. Coagulator. See now?
Yeah.
Yeah, beautiful.
You have plenty of space.
Yeah.
This is exactly your fox.
Yeah.
Fox, yeah.
First I use the coagulation. And then I use the ablation.
Okay.
This needs a very precise feel because the tip you are at times is obscured by your instrument, isn't it?
Pardon?
You have to feel the tissue, otherwise your tip sometimes obscured by your instrument.
Yes.
The coagulator, yeah.
See, there's a small vessel.
Yeah.
This Satish boss, for this fine dissection, can we use LW and of the coagulator?
Yes, that is much finer.
Yeah, that is finer and it has a very, tip.
See this vasculature inside?
Yes.
That's the fox cerebri which I have cut. Can you see?
Yes.
So all this I am doing as a safe margin,
Yeah.
Other day. This is just for the sake of safe margin. Once I have resected this dura, I can see such a good margin around.
Yeah.
Yes. छोड़ना.
Boss, Dr. Shambhu Nath from Guwahati is asking about anterior falcine artery involvement.
Anterior falcine artery supplying the fox is a branch of anterior ethmoidal artery.
Okay.
That's why when we divide the fox, you have to keep coagulating it,
Okay, boss.
See now, such a good margin all around.
Yeah.
See, this is tailor-made, nothing like measuring in centimeters, millimeters, or this or that landmark.
You just follow the disease and keep a safe margin.
Yes.
Just a question. For the margins, for the histopathologist, is it better to use a scissors or is a coagulator equally good to assess margins?
Yeah, it may spoil a margin for a few millimeters.
Yeah.
Scissors. The more important thing is to orient your specimen. Section. See, this is the final cut I am taking. And then I will show you all around.
It looks good, Satish.
Scissors.
That's why in the frozen, we always level as is the up, down, left, right, isn't it?
Yes, yes, yes.
Because then the...
Because that gives you an opportunity,
yeah.
in case you have a closed margin or positive margin,
Yeah.
orient karo, margin ko sahi kar de.
So we must know which side it is and where it is.
Yeah. So I can go and refresh the margins, you know.
Right.
Let me show you what I have done so far. I hope you are oriented.
Yeah, right now.
And see, many a time once you do such cases, your field tells you that what you have done.
You have done.
See here?
Yeah.
Yeah.
Very clear?
Yeah.
Yeah. With olfactory.
Yes, that is a gyrus rectus. That's the dura here, which I can.
That part of dura also you will remove.
One question.
The one you are touching now.
I can remove this. There is nothing.
Yeah, because it doesn't look smooth.
Yeah, that was the reason where the crista galli was going. See that?
Right.
Yeah.
Which we removed.
Yeah.
Yeah, Satish was one question. Could we have done this case without removing crista?
No, man. How would you go on the other side?
Yeah.
Crista is nothing. It's the extension of the perpendicular part of ethmoid bone forming the nasal septum.
Okay.
That is the extension, upper extension of that. That's it, nothing else. See that?
Yes.
Absolutely, you know, I can say, to me, it is margin all around. I don't see anything dicey anywhere.
Yeah.
And that is the part of the brain. See that?
Yes.
Yeah. It's very smooth and healthy sort of thing.
Yes, wash. Now is the reconstruction, and it's very simple. We have a Haddad flap. We have already harvested fat. Oh, under kar diya dusra. Next case is ready, and that is a massive case with a huge intracranial extension. And the third would be pituitary. So this we are going to be over soon, in few minutes. I just have to first place the fat inside.
Yeah.
Facial, yeah. Fat, fascia, glue, and then your flap. Because in such cases, you can't take a chance of CSF leak. CSF leak is one thing which starts the series of events further.
Satish, I must make one comment.
When you indicate radiotherapy in these cases, when you miss doubt or you just send for radiotherapy.
Hello?
When you send these patients for the radiation.
Radiation will be, you know, this is, to me, is not Kaddish 3 or so. But the skull-based involvement is one thing which warrants. Number two, we'll see the prognostic factors in the final histopathology.
Yeah.
Okay.
And if there is too much of necrosis and pleomorphism, it is better to take a call of radiation. See,
Dr.
now we have
Satish,
a good resection with free margins all around. You can see close up.
Yeah.
Yes.
Okay, yes.
Dr. Satish, before close up, you will see the here frozen section, all reports. They are with you.
I should, but here I am closing. I have sent for frozen. That's why for last few minutes what I am thinking to close it or not.
Yeah.
That's why I am critically analyzing if there is any possibility of staying close to the margins, which I don't think here.
By the look, it doesn't seem to be, but since we have taken a frozen, why not wait for a few minutes and get the report?
Yes.
One comment I would like to make, Dr. Satish, the way you do to a person who is watching, it seems very easy and very simple. But I will like to give a message to all. Behind this is years of your experience of cadaveric dissection understanding the radiology and anatomy, and then only you reach up to this stage. So just by watching that it is so easy, probably it is not so.
Yeah, but
I think you will agree
sir,
with me.
that's how we have, planned our webinar initially. Every time more and more focus on the cadaver.
Yeah.
We have done this cadaveric anatomy, then a lot of radiology we have discussed.
Yeah.
Actually, radiology gives you a three-dimensional picture in your mind.
Yes. Yes. And I think it's a, you have to graduate step by step. There is no shortcut for reaching to a skull base. So I think one has to graduate step by step.
Yes. So in case the positive margin comes,
yeah,
either go and resect or send a patient for post-op radiation therapy.
But I think primary surgery is always better than sending for RT. Yeah.
Yes. Always.
Yeah. But yes, I agree. There are hardly any chances.
Okay,
looking, but that is the fun of frozen section.
Can we see the posterior thoracic artery in this case? Satish?
So what we'll do,
Satish,
I will wait for some time.
Satish, can you show us the posterior thoracic artery? People are asking.
I didn't go far behind. The posterior artery is right here. Had I done a classic, posterior artery is the posterior limit of transcribiform approach.
Yeah.
Or the anterior limit of transplanum approach.
Yeah.
See this? That is planum behind.
Yeah.
Posterior artery is somewhere here.
Yes,
I didn't go much behind because the tumor was not dictating. But in a classical transcribiform, yes, your posterior artery need to be taken.
Yeah.
But here not needed. See, such a nice rectangular opening.
Yes, beautiful.
Which now I am, all set to close, but see, this is dura all around.
Yeah.
Normal dura.
Yeah.
Normal dura. See this.
Yeah.
Better you should close it.
I can close in no time. What I'm waiting for the frozen now, 0 degree. And meantime, what I will do, I will go to the next case radiology and come back.
Yeah, that's a good idea, boss. Yeah.
Suction.
Yeah, that's better.
Suction. Let's see our flap as well first.
Yeah.
Yeah.
Now the flap is the most important thing. See how the posterior margins are decided by how the septal margins are decided by tumor.
Yeah.
Under with the coagulation under vision, we sacrifice the part of the septum. See this?
Yes.
Nowhere is a compromise in terms of closed margin or going through the tumor or anything. Everything is still clear.
Yeah.
One question. So here our repair site is a bit anterior. So will you make the surface raw posteriorly for a Haddad flap to rest?
Where everywhere is raw, man. I've already done.
I mean the sphenoid sinus.
See, no, not needed. I'm not going to place on the sphenoid surface.
Okay. So
not going to be placed anywhere on the sphenoid surface for that matter.
So it will hang like this. I mean anterior to sphenoid.
Yes, on the anterior face.
Okay.
This is the flap you are taking out, isn't it?
Yes.
Yeah, this is the flap. Yeah.
This is my Haddad, which is going to go like this.
Yeah, long enough.
See, this is quite adequate.
Yeah.
I am not placing now, just checking.
Yeah. So it is perfectly fitting, boss. Yeah.
I think, Satish sir, I delayed your closer,
See, this is coming so well. Before that, we'll place our,
fat.
We'll place our fat, fascia,
and glue.
Sometimes we use, that the Duragen in bigger defects for Dural regeneration. That's a good material.
For those who have joined late, can you just reorient again?
Okay.
Yeah.
See, if this is with a 0 degree. This is with a 0 degree. This is the coin on both sides. The terminates on both sides. See that? And this is the sphenoids on both sides.
Yeah.
This is the lamina papyri on this side. This is the ethmoid, little bit ethmoids left. I didn't remove one on side. And those are the frontal sinuses on both sides up.
Yeah.
Up there. And this is what the defect in the cribriform. I didn't raise this part of the, flap earlier. If you want to give more length, I have a lot of options, See this?
Yes.
Yes, yes.
I can give further length to this flap. Dhira, dhira.
Yeah.
As much as I want. See this?
Yeah, yeah. I
Some
think
more
it's
length.
more than adequate.
Yeah, it is already adequate.
Yeah.
Smooth, hai? This is just a rehearsal.
Okay.
We are waiting for the frozen.
So in the meantime, just to boss, how you orient yourself about the mucosal surface and the periosteal surface.
Yeah, see the vessels.
Yeah.
See, this flap should never be tension. See, it should never be in tension. Okay?
Yes, boss.
Merosel. Yes. Now quickly, I wash out and show you the radiology because it may take some time. Okay?
Okay.
This will take 5 minutes for the closure. That's it.
Yeah, yeah.
Yeah, thanks, boss.
You could have done by now.
Demonstration, wonderful job, boss.
And now, quickly coming to the radiology of the Oh, Yogesh ji.
Amol.
Hello.
Amol is there, and Dr. Patil also was there. Arvind Patil.
Arvind Patil is there. Hi, Arvind. Arvind
Amol
and
is there. Arvind was there.
Oh, they are amazing
Arvind is
people.
trying, but is not connecting.
These are the people I have lived my life with them. Believe me, so amazing.
Must fellows.
So committed. Are you
So
getting
what-
the? Ye lagao na. Are you getting the picture?
Yeah, we're getting
Yeah, you can see it's a huge tumor, boss.
So this is a young guy, histopathologically proven, grade 2 chondrosarcoma. And this is something, a pathology we need to know about. This tumor,
Yes,
this is T2 weighted. This tumor, I will show you first the entire extent. This chondrosarcoma are so growing tumors with very low potential of metastasis.
So
They are
it is-
considered as a favorable tumors.
So
See
what
the extent in all three planes. Can you?
Yeah, we can see, boss.
Yeah.
This tumor, as I said, arises from some of the cartilage remnants, chondroid tissue.
These are T1, boss. T1.
Yeah, T1, it is classically hypodense. Let me show you.
Yeah.
That is a property of the tumor. See this? These tumors, T1 classically hypodense, T2 hyperintense with variegated, appearance inside. Can you see? This is all chondroid myxoid material.
yes.
With necrosis. See all this variegated appearance inside with hyperintense. And At the same time, there are good contrast enhancement as well. Let me put up the this thing. Contrast.
So
See,
what
this
about the origin of this tumor, boss?
most likely from nasal septum. This guy couldn't come for last few months because of the lockdown.
Okay.
And he came with huge proptosis now. Absolute painless tumor, very smooth on appearance, very, very smooth. These chondrosarcomas have characteristic, radiological findings. Characteristic, these are all three contrast pictures now. Same like T2.
Yes.
This is all chondroid material, which is, necrose material inside, which is not enhancing everywhere. Now see the extent, number one. I will take you all the three pictures, one by one. If we start from here, most anteriorly, see the nasal septum.
Yeah.
Where it is broadening.
Yeah.
Broadening. That is the primary tumor where it is starting. On examination, we took a biopsy. On examination, it is all smooth surface, all around.
Okay.
All around smooth. And see, this is huge tumor going up towards the cribriform. Then the same tumor is going, three chondrosarcomas have a tendency to go eccentric. This is how many a time they are differentiated from chordomas, because they go eccentric. Yeah. And this is how, see, eccentric, it has gone going towards the left side pterion. Yeah. And see, this is how it is giving proptosis here. And this is the tumor rising up and compressing the brain with no brain edema. The reason is, it is not invading. They have a classical appearance of scalloping lesions with compression of the surrounding structure, including neurovascular structure, with no involvement as such. And see, at this point of time, this is T contrast. If I put up the T2 coronal, see this. There is no brain edema at all. See this.
Yes.
See the scalloping margins. See such a good margins all around.
Yes, yes, yes.
Not invading anywhere.
So it is extradural, boss?
It is extradural, but they involve dura. But
they
don't invade and become pure intradural. It is not so invasive. In spite of such a big, tumor growth, patient was asymptomatic. Only presented with this thing. Proptosis. No pain, nothing, no intracranial signs, because it is slowly growing, expanding with scalloping margins. Now in the axial, see this, if I see from below downwards, this is completely, see the septum all around.
Yes.
Arise from the septum. See the septum here, it is missing.
Yes.
And as you go up, see the maxillary sinuses on both sides with fluid, which is not enhancing.
Yes,
that is because of secondary blockage.
Yeah, boss.
Secondary blockage, see the complete septum involved. And now, see the orbit, see the plane with the orbit. It is not invading as such.
Yeah.
See the carotids behind. Yeah. It pushes the neurovascular structure but doesn't invade.
Yeah.
See this everywhere. That is how, see this lobulated appearance all around with expanding margins with no involvement. And same is, same in the coronal.
Yeah.
See the frontal sinus not involved, just collection.
Yes.
Yeah.
See this elevating the dura.
Yes.
And see this multiple lobulated elevation. And behind also, see this is pushing. See, normally this is the site of the anterior cerebral artery.
Yeah.
Now with this tumor, see, it is pushing behind. See this?
Pushing behind. Yes.
Pushing. All the way pushing. Now here you can see better with the T2 of the sagittal.
Yeah.
See this? See the brain margin all around, no invasion at all. And see the anterior cerebral artery pushing.
Yes.
Pushed by the tumor. That's the carotid behind, the cavernous carotid. And see how this is expanding in the clivus. with good distinct margins all the way.
Yes. Yes.
Everywhere.
So,
And for these low-grade tumors, the primary aim nowadays is removal of the lesion with minimal neurological sequelae. You don't have to be as radical as, like, aggressive cancer.
okay.
They have their 10-year survival, if you do with a good resection and radiotherapy, is more than 80%.
So, boss, generally we say that if the tumor is lateral to mid-orbital line, we don't do endoscopically.
No, that concept has changed now. We have many a time do orbital transposition. We have seen
So many things.
so many extended draft approaches and all, depending upon the tumor. If it is a squamous cell carcinoma, aggressive cancer, you are right.
Yes.
You can't take a chance to be so aggressive.
Okay.
Yes. So nowadays, the things have changed. Now our plan, I will go inside the tumor and hollow it out.
Okay.
We have a neurosurgeon with us, Dr. Pankaj Gupta. I told you.
Yeah,
So our plan is to go from inside everywhere and let's see the dural involvement. Depending upon the dural involvement, we'll take a call of combined approach. And if we combine, that will be the simplest with the bifrontal craniotomy.
Okay. Boss.
We'll come from above, remove whatever the dura which is involved and put a pericranial flap from above. Simplest way. So, first of all, we'll hollow it out from inside and let's see if anything else is needed.
Boss, is the clivus eroded here or the clivus bone is
all because of expansion, not eroded.
Okay.
See this.
Compression.
See this clivus.
Yes, yes, yes. Boss.
Everywhere the tumor is expanding.
Relation to the basilar here, boss?
Basilar is behind, man. Basilar is here behind. See there. It is here behind.
Okay, boss. Right. Right, boss.
Now this one. This is basilar.
Yes, yes. So
So it is nowhere close to. This is all Chondrosarcoma.
Yes.
This is grade 2. We had, biopsy and got it, tested thrice, 3 different pathologists. What I wanted to rule out whether it is mesenchymal or not. There are 4 kinds of chondrosarcomas.
Okay.
The classical, the most common, having the best prognosis, then the clear cell another, and then the worst is the mesenchymal. Had this been mesenchymal, I would have been treating like any aggressive cancer.
Okay.
For them, the survival is overall survival is less. You have to be very aggressive in primary surgery as well as adjuvant therapy. So here, our goal is to go from inside and hollow it out. This is not very vascular as well, I tell you. I will show you how you can easily reduce this tumor in no time. You have to go all around wherever the scallopings are. You have to respect the outer wall. You are not supposed to breach the outer wall. And then immediately as you hollow it out, the brain will expand.
Okay.
Because this is just compressing. It is nowhere invading. Such a good, distinction with the brain all around.
Right.
And once...
Dr. Satish, what was the duration of development in this patient? Must be very slow.
Very slow growing. If it is asymptomatic, even this patient didn't develop nasal obstruction. Because the tumor is arising from the septum above and going up.
So his only symptom when he came to you was proptosis.
Proptosis. That's the only thing. And now in pathology, our goal is to rule out mesenchymal tumor.
Right.
Mesenchymal variety, then you have to treat it differently. Otherwise, it's a favorable variety. And most of the, if you go to the world literature, 80% of the literature is in favor of subtotal resection and radiation. Not to damage any surrounding neurovascular structure. Because they have extremely good prognosis. Why to give patient morbidity unnecessarily? You can remove as much as safely possible and then follow with the radiation. Though he's a young guy, will be little towards, achieving complete resection. So let's see how it goes from inside. Kaya?
But in this case, you don't need any radiation or anything, isn't it?
Negative.
Maybe post.
In this case,
yeah.
In this case, you don't need to go for any radiation or anything, no?
100% we have to go with radiation.
Okay, you have to.
With you know, function preserving radiation like IMRT, IGRT. If this is a big tumor, had this been a slow one, even with a stereotactic radiosurgery, but this is too big an area to be covered. So function preserving radiation, radiotherapy is the call.
Can we give radiation first or then go for surgery to debulk?
It will not work. But this tumor has a lot of necrotic material inside.
Yeah, inside it.
The radiotherapy is not going to work. It's not going to work at all. Radiotherapy works in areas of good oxygenation, good blood supply. And this in such a massive tumor, you can't expect that.
You got the frozen, I think.
Yeah, kya? Negative? Negative. Margins good. So we'll close it. Okay?
Good.
So I will go. Get wash up, and the other case is already induced.
Yeah.
5 minutes. We'll be back with the closer.
Okay. Dr. Jay Narayan was?
Yes,
so what would be your approach? Suppose this case, in your case, what was your
first case or the second case?
This first case.
First case, the olfactory neuroblastoma. Yeah, I think the approach would be the same. There is a role for neoadjuvant radiation in case the tumors are much large. In this particular case which Satish showed, I think the tumor was well within his reach. He was very confident he'd get good margins. But if the margin is a little bit more pronounced or a little bit larger, then there is obviously a role for neoadjuvant chemotherapy, shrink the tumor, and then go out and do the surgery. That's one point. Surgery-wise, I think he got a fantastic margin everywhere. And, you know, exactly as he saw, we decide not only on the Kaddish staging, but we also decide primarily on the HIAMS histopathological grading. So if the histopathology shows, even with his resection, like he said, if the histopathology shows a grade 3 or a grade 4, like the pathologist said, it looks to be a grade 4, then this patient would definitely go in for a post-op radiation. But if the HIAMS staging in the tumor is grade 1 or grade 2, then you put this patient visually, of course, but also repeat serial MRIs over a period of 5 years. So that's how we decide on these olfactory neuroblastomas.
And about this case, would you go for this the second case?
This chondroblast, okay, yeah. So Satish gave me this picture yesterday, and he asked me my opinion. Now, to be honest, I told him I think it may be. He had obviously not received a histopathology biopsy report, but we were debating, and I told him it could be a round cell tumor. I had a very big round cell tumor a similar way, but of course, you know, these are all MR pictures, and obviously there are multiple differences, multiple differentiations, and your treatment, like Satish already showed in one of his slides, is totally based on the histopathology of the report. Debating whether it's A, B, or C. So I had a similar patient which was a round cell cytoma, and you know, I remember doing that case, and there was a lot of bleeding, and you could see a lot of vascularity in the tumors. Now, this being a chondroid tumor, chondrosarcoma, I think the bleeding would be far lesser and more amenable to resection. Obviously, better outcome because post-op radiation will help the patient. I wrote the patient is 24-year-old, so I think, and yeah, probably I would have to have a combined approach. But knowing Satish with his skill, he would probably do it a lot more endoscopically. There's more chances of him doing it purely endoscopically. But I would think I would regard a sort of a combined approach in such a huge tumor.
Narayan.
Yes, Satish, go on.
We are all set for the combined as well.
Yeah, I know, Satish.
Whenever you feel like, you'll immediately convert to a combined one. But
correct,
anyway, even if you plan combined, you have to start with the endoscope from the nose.
That's true. That's true. Absolutely.
That's what we are doing, and we are all set with the combined. I'm quite open about it. We will not take a chance anyway.
Yeah.
Are you getting the picture?
Yeah.
See my flap.
Yes.
Beautiful.
Yeah.
That is the value of Haddad. Now, first of all, 70.
Satish, are you using fascia or are you using Duragen? Have you any experience with using Duragen inlay?
Yeah, sometime in larger defects now, I use Duragen.
Okay. The result good?
As an additional layer for regeneration of the dura. Now see, everything clear?
Yeah, wonderful.
Now my first goal is to place the fat. This fat is same like we always use, soaked in
Yes.
rifampicin.
Yes, yes, yes. How you make the rifampicin solution? Is tablet?
This is to take care of Staph aureus.
No, how you make that solution? That
250 milligram per ml, like 5 ml of solution and 15 and 6 ml of solution, 6 ml. We open up 3 capsules of 600 milligram.
yes, yes. Okay.
Where from this fat was taken?
Pardon?
Thigh.
This fat was taken from thigh?
Thigh, sir.
Yeah, good.
See, I am pushing it inside the dura.
Yeah.
See this everywhere?
Yes, yes.
Yeah. So nice.
थोड़ा और देना. Glue.
Dr. Arvind Boss, afternoon, evening. Dr. Arvind Patil.
Hi, Arvind.
Good evening, sir. Yeah, good evening, sir.
Hi, man. Nice to see you.
Yeah, thank you, sir.
Such a simple guy. You won't believe.
He does everything.
And done, so many olfactory neuroblastomas, particularly at Arvind's place.
We did a camp, if you remember.
Yes.
I think
And one of his patients, I can never forget that 75-year-old male.
Yes, sir.
What a cardiac issue and all that. See
It's
this?
difficult.
This is the initial placement of the fat.
Yeah.
Yeah, Arvind and Abdullah.
See now the pulsation. Pulsation shows the area is closed.
Yeah. And the role of chemotherapy in these cases?
Not really. Not really. Chemotherapy has hardly any role. See, this I will push at the margins.
You're talking about chemotherapy is neoadjuvant chemotherapy, not post-op. Post-op chemotherapy has no role.
A new adjuvant, yes. And we have already discussed in situation where we intend to preserve the function like eye and make the tumor resectable. To make the unresectable tumor resectable. See this?
Resectable.
Yes, beautiful.
This is a very good idea to push the Surgicel at the margins all around.
Sir, you remember the defect of, in my case, it is right from frontal to sphenoid sinus, huge defect.
That patient was, and that patient was so determined. He was
Yes,
a
sir.
75-year-old, had triple vessel disease. I said, boss, this is too risk. He got angioplasty done. We did the surgery. But such a massive tumor. It took us 6-7 hours. And it's been so many years, he's doing so well. Some patients do well.
Willpower, actually.
Yeah, I don't know. There are certain factors beyond our control.
Arvind, you remember the newspapers recently?
See now what I'm doing?
Yes.
I'm just pushing my glue.
Okay. In that case, the tumor was protruding out of nasal cavity. It was so huge.
Yes.
Oh my God.
And defect was almost from frontal to sphenoid sinus. Complete defect.
Arvind's setup is one of the best I've seen. Whenever I operate outside, I have so many issues, but his setup, he has got each and every equipment. It is so.
Pune King.
His anesthetist also, the team.
Satish boss, there is a question that if the fax cerebri is involved by the tumor, so would your approach would be a bit different?
I will resect it well. Fox involvement in tumors, if it is, would be limited.
Okay.
Generally it doesn't. See, this is beyond the margins of the fat.
It is totally encased, rather, encasing the whole thing.
Any role of cartilage we can could have put over here just for the better support?
Cartilage has no role.
Moreover, boss, if we are planning to give radiotherapy, it can cause chondronecrosis.
Yes. The question was that, that's why I asked you. Dr. Supri Singh, that's why I asked
Boss, can you elaborate about the pericranial flap, how to bring in at this site?
In next case, if we do bifrontal, we'll raise the pericranial flap and then we'll show the raising of the flap. Here about how to bring in.
Yes.
Let me show. See, this is frontal sinus.
Yes.
Pericranial raised from outside. You can bring in through the opening made in the nasal bone also from outside. Or if you are doing a draft. Many times the draft is a part of transcribiform approach. Then you can bring through the frontal sinus.
Okay, boss.
See now?
Yes.
This is onlay, right? Onlay fascia.
This is only, man, only.
That's what I said, only.
You will put it to a tube between frontal sinus and maxillary to drain, make it patent.
Yeah, in case it is smaller.
Yes.
Satish was, what happens to the glue? Does it get absorbed with the
resolves. It resolves in few hours.
Okay.
But it incites such a great fibroblastic reaction which is required, because what we require is the fibrosis.
Yes.
See the flap?
Yes. Yeah, beautiful.
It should not be under tension at all. See that?
Yeah.
Yes.
Can you see? This is a vascularized tissue. This will give blood supply to the area.
Yes.
And this will give a primary healing.
Yes. And the frontal sinus drainage is completely clear. So,
yeah. Patla dena section. Frontal. Yeah. In case you have a doubt about the blocking the frontal sinus drainage, I can put a temporary tube.
Okay. Which tube? Which tube?
Between frontal sinus and
cut a IV set.
Okay.
बंद करके खोल दे. See, this is frontal sinus. बंद कर.
Yeah.
Otherwise, what you can, I can put IV set, cut the IV set tube, one tube from here to the maxillary sinus.
Okay.
And I will remove it at the time of removal of the pack.
All right.
Just to prevent the, blockage of the frontal sinus. That's it. Got the idea?
Yes.
See now how the flap is looking like? Hello?
Yeah, it's good.
Wonderful.
It's good it has covered all whole of it, yeah.
Satish, nice job.
Yes?
Even sinuses are
Nice job.
And
do you use Merosil pack over it or some other pack?
Pardon?
You use Merocil pack for it or some other pack?
No, no, not Merocell. This is, first of all, I am using the gel foam.
Okay.
Gel foam, silastic.
I am using the gel foam.
Mm-hmm.
Scissors, scissors. Gel foam is a thing which has the ability to swell up more than its volume, you know. And when compressed, it exerts smooth pressure.
Yeah.
See this?
Do you use Foley's catheter and inflate it over the
Merocell, simple Merocell.
Okay.
Yeah.
Foley, sometimes it is too much. See this?
Yeah.
And I will swell it up with the antibiotic solution. See this?
Yes.
This is very well. And once it swells up, it exerts a smooth pressure. That is the beauty.
Yes, yes. Yes, that is.
And that is what I want.
Boss, what is your follow-up protocol for cases?
We'll remove this pack after 4 or 5 days.
Okay. So
that's it. And then we'll start saline.
I mean,
you know,
and the long-term follow-up.
MRIs
and to see the
not
recurrence.
before 3 months.
Wait.
Nothing before 3 months.
Okay. And how long is the follow-up?
Yeah, this is lifetime. Okay. Because they have many a time late recurrences.
Yes.
Late secondary recurrences in the neck.
So every 6 months or what?
Initially every 6 months, for 2 years, then every year, and after 5 years, every 2 years. See this? What a uniform pressure it is giving.
Yeah.
Yes, yes. This patient, okay. We have to go for any MRI after 6 months.
3 months.
See this is what I am pressing with.
Silastic.
Gel foam.
Gel foam and wrapped in a silastic.
Yeah.
See to exert the pressure. See how the pressure it is going to give now. This horizontal gel foam, Merocell. See this?
Yes.
And when I remove the Merocell, the silastic will be non-sticky.
Yeah.
Now it is completely pressing it. And then we'll support with 2 Merocells from outside.
Yes.
This is betadine solution.
Yeah.
Low.
Sir, in one of our case, post-operatively, we faced the problem with pneumocephalus.
Yes. So pneumocephalus is something, means you have some skull base defect.
That is valve mechanism is there.
Yeah, there are many mechanisms which by means of which it can grow. Sometimes it can become tension pneumocephalus. Arvind, I remember that patient. He is doing very well now.
Yeah, I met him, sir.
Anil.
Yeah, Anil, yes.
And now we had to make a burr hole, if you remember.
Yes, sir.
For the pneumocephalus.
No, just I wanted to enumerate, Kiki, we have to take care of pneumocephalus post-operatively. We have to see in that way of every skull-base patient, because many times we may miss in that post-op management.
So, boss, how did your patient presented to you? Suspect headache or seizures or what?
He came with nasal blockage and mild headache. Intermittent headache.
Pneumocephalus, if it is expanding, it can lead to disorientation and make the patient unconscious as well.
Yeah.
Pneumocephalus is a difficult problem. You have to be prompt in, handling that. Yeah, any patient post-operatively after such procedure become irritable, drowsy, you have to get a CT scan done. And that will pick up if there is any pneumocephalus or anything forming. And that
Any
gives
chance?
you, that should give you a first suspicion of a defect in the skull base. See that now?
Yes, yes.
We have 2 more marrow cells I have placed in the floor. We'll fill up them with the betadine and that is done.
Any chance of cerebral vein thrombosis in such procedure?
Any chance of?
Cerebral vein thrombosis while doing such?
CVT?
Yeah.
That DVT, CVT, that is all unpredictable.
Unpredictable.
So but generally it doesn't happen. But yes, in all long surgeries, we use the DVT pump, in the leg to prevent DVT.
Rajiv, I think such complications are not related to any specific surgery.
Pardon?
But that's, yeah.
I am going to the other case. Yes, you are asking something?
No, I said, Rajiv, these DVTs and all that, they are not specific to a particular surgery.
Yes,
It can happen with any surgery.
Yes.
So any angiography been done in second case, this case? Any,
Boss, is there
you have
any
angiogram of the
staging
second
system
case?
for chondrosarcoma like in the case we are operating?
Hi, Satish.
Hello.
Yes.
I could hear Ashish. Was it Ashish?
No, Dr. Cherian.
Dr. Cherian, yeah.
Hello, boss. How are you?
I'm fine, Satish. How are you doing?
Oh, welcome. We just finished a transcribiform olfactory neuroblastoma. On this case, are you getting the picture?
Yeah, I'm seeing it.
This is a chondrosarcoma.
I see.
This is a chondrosarcoma. और लगाना coronal वो दिखाना. I have watched up for the next case. This case, so Sandeep will show you the chondrosarcoma. There's a huge one, young guy, low grade, intermediate, I would say grade 2 chondrosarcoma.
Yes.
And expansion into the brain, orbit, nasal septum, intracranial fossa, everywhere.
Yeah, I can see that. Yeah. Do you have the ACA vessels seen?
Yeah, all are pushed.
Yeah.
See, chondrosarcoma is a tendency to grow, push everything aside.
Yeah.
Involve the vessels. It pushes. And our plan is, since it has started most likely from the nasal septum, has gone up. And see the picture.
Yeah.
We'll start from below. No vessels, no important structures are there within the tumor. It is always pushed by the tumor. You see the scalloping margin all around.
Yes.
It's a low grade, slow growing tumor. So, and it's a very, very favorable tumor in terms of prognosis.
Yeah.
So, our goal is, we'll start from below. In case required, when we go up, if the dura is extensively involved or something like that, or we are not able to remove it, we'll convert immediately to bifrontal craniotomy. We are already prepared for that.
You probably won't need a bifrontal. You would probably need a simple thyreonal on one side. You would probably only need a simple thyreonal, a frontotemporal on one side. You won't need a
yeah, let's see. The question is, can you run the scan?
Yeah.
Question is, it is going across the midline as well. See this. थोड़ा चलाना इसको. Coronal. Yes, see this. Go back. Go back. Yes. Can you see this?
Yes, yes. Yeah, but even then you won't require a bifrontal. You would require
Maybe
only.
it is the Pankaj boss who is going to take the call.
I see. I see. Pankaj is there?
Yes, yes.
Okay, good. Regards to Pankaj. My regards.
Being a neurosurgeon, see, as ENT surgeons, we would approach your teaching differently, endoscopically, and then, if required, bifrontal. But as a neurosurgeon, what are your thoughts? What would you do for this sort of tumor?
Yeah, I wanted the same question.
You're asking me?
Yes,
as
yes.
How I would
So,
go?
for everyone, 6:30 we are going to take the pituitary case. 6:30 will have Professor Ted Schwartz joining us, Professor Vijay Anand joining us. This is the second case, and yeah. See, this is not intradural at all. Can you see?
Absolutely.
It is completely lifting up the dura. Nowhere it is intradural. This was the pack after biopsy. This was the pack after the biopsy. Are you getting the endoscopic picture?
Yeah, we're getting now.
I just removed the pack.
Okay.
See, this is the tumor which is coming from the, like this, from the septum.
Yeah.
Bilaterally. See this bilaterally. Coagulator. So our plan is to hollow it out from inside first.
Okay.
What I want to show here, chondrosarcomas are slow-growing tumors. We should not be frightened with the extent of the tumor. They still have a good prognosis.
Hello. Your voice is broken. Not so.
So this is the initial preparation. I use this marrow cell pieces. This tumor is classically hyperintense on T2 weighted and enhances on contrast. See the surface vessels on the tumor.
Yeah, very much.
This is where the pack was. Use of coagulator is to just improve your field. See, it improves your surface coagulation. The field improved dramatically. Hello?
Yes, very clear.
I'm listening to you.
Yeah. I am staying anterior to the tumor and trying to go inside. I can feel my septum here very well.
Yeah, we can see.
See the septum and now see the tumor.
Yeah.
Yes, we can see.
Immediately behind, this is what we saw in the MRI.
Yes, yes.
I'm just opening up this, pocket. Just opening up.
While hollowing from inside, any structure particularly you have to bother about?
Bother about?
Dr. Satish? Any structure you have to bother
Not
about?
really. Not
Yeah.
really. We are in the inferior part of the midline of the nose.
Right.
Nothing, very, very critical over here.
Yeah.
What I'm trying to show is, I want to stay inside.
Yeah.
See, this is the wall of the tumor, this is the septum, and this is from where I will hollow it out.
Yeah.
Let me remove a little bit of this, or just to widen the exposure.
Yeah.
See the pocket. This was the surgical kept at the time of biopsy.
Is it a crackling type of consistency or what?
Pardon?
Consistency of the tumor? Is it a crackling type?
Consistency is like a jelly, I would say. Soft to firm.
Okay.
This is on this side. The same thing, I will open up from the other side. See this?
Yeah, now I can.
We have to define our borders first.
So
now I am opening into it.
Yeah.
That hours here, right?
Chondrosarcoma, generally you will find in the petroclival region, generally.
Yeah.
In the skull. The commonest location is petroclival. That too, nowadays, more and more being addressed by endoscopic approach.
Yes.
See, why I am purposely using the cobbler on the surface is to keep the field good.
Yeah. Devascularize.
See, this is the consistency, sir. You were asking about it. Now
Yeah,
see,
yeah.
now see, this is the consistency, like this.
Ah, yeah, yeah.
You know,
Is it like a cheesy material or what?
it's a chondroid material.
Chondroid material.
Chondroid field.
Look how later, you know. ये surface coagulate करूँ. I will take the debrider later on to expedite the procedure. But this surface, you know, wherever the surface is vascular,
Yeah.
debrider, straight debrider. That will open up the nasal air space. See how unusually it has grown up and gone laterally.
Yeah.
अंदर घुसा ना. Back. Now I will use the debrider here to quickly take away this.
Boss, if we can see the external camera and how the orientation of the patient and your assistant.
Same, the patient is lying in the, okay, I'll show. Is lying in the neutral position. No extension or anything. Give me. See this kind of material.
Yes, yes, yes.
This is pure chondroid material.
Yes, yes, I can see that.
Forceps. See the surface from outside. Nowhere you will find the invading margin. Everywhere are the expanding margins. Beauty of the debrider is it expedites.
That's true.
Cartilage remnant. This is redundant secretions.
Yeah, sinus, full of sinus.
Maxillary sinus. No, right angle.
Your suction is wonderful, ultimate. You should have suction like this.
Suction is the favorite thing here. Debrider. See, this debrider works best only have a good suction backup. See, that's why I mentioned it started from the septum. Can you see?
Yes, yes.
Yes, sir.
The condition of the septum.
Yeah.
This is where the chondrosarcoma starts, in the nose. So whenever is a thick chondrite material, you have to use your instrument. Otherwise, keep debriding.
Yeah. No.
Dr. Tanuj Thapar is asking, can we do a septectomy anterior to the tumor and then approach it?
Yeah, we'll do complete all around. I will do a complete septectomy all around the tumor. See this tumor margin?
Yeah.
Now you can remove with whatever tools you have, cobbletter, debrider, forceps, lux, whatever.
Yeah.
Doesn't make any difference. This margin of septum will definitely remove. I am just opening the space.
Okay.
This is just the beginning. Too big. आ गया उसमें डाल दे फ्रोजन भिजवा दे एक बार और जल्दी भिजवा Frozen. I'm just sending for the frozen to reinforce our diagnosis.
Okay.
But here probably frozen is not mandatory, isn't it?
Not mandatory.
Yeah.
This is all. See the value of suction.
Yeah.
Yes, ultimate. Super. In fact, the suction is cutting tumor like it looks like.
Yeah, right. It is sucking away the tumor. Yeah.
Otherwise,
basically you have to scoop out everything.
Otherwise, it makes the life so difficult, so frustrating.
Looks like a pituitary tumor.
Yeah.
At any point of time, we are within the limits.
Yeah.
This is the classical appearance of Chondrosarcoma.
Yes,
sir.
Wherever it is.
Boss, how is the consistency different from a chordoma?
Vessel, coagulator. See the branch from sphenopalatine.
Yes, we can see.
दिखा दो. So we have almost cleared the nasal passage.
Yes, sir.
This is still. This part of the septum will remove with wide margins. Okay. Inside the tumor. Right angle.
Even the turbinates are so
We have a
thinned
long
out.
way to go. बड़ा ले लो. ये नया मजाक कर रहा. See the tumor is shocking the section.
Is it the boss bilateral superior turbinates we are looking at on both the sides?
One side.
That is the level of the esopharynx.
Yes.
Can you see below?
Yes.
Yeah.
Hello?
Yeah, we can see.
Yes, we can see. We are with you.
Hello?
Yes.
Yeah, I couldn't hear you earlier. See, I'm just doing intratumoral debulking.
Yes, we can see.
Nothing
Lots
else.
of bleeding and.
The fast you do will be overall less bleeding. But this is expected.
It is.
See the posterior wall?
Yes.
Hello?
Yeah, we can see.
Yeah.
That's the clival recess.
Here. The paraclival carotid on the right side.
Yeah. Section. See the clival recess nicely.
Very nice. It was right, it is completely thinned out here by the tumor.
Yeah, obviously. You have to be quick in, wash. The bone is intact. Absolutely fantastic, normal. The carotid looks decent. I will show you. Doppler dinner.
Yeah, that is the sella, boss?
Yeah. Sella. And see the tumor margin.
Yes.
See, this is tumor margin.
Yes.
Watch. Let me remove some of from the lower down the interior wall of the sphenoid and all that. Gila gauge. Debrider. Sevlon de na.
The bone is intact. You can see it clear.
Yeah. This is coming in the way. Now I will show you a clear view once I let me remove this little bit of the tissue below, because this is important area. We have to be
very careful. Yeah. Fibers.
Give me a small pack for a while. Says where the bleeding is from. Oh, give me a copy.
Oh, this one, spinal palatine.
See middle turbinate end which is compressed.
Yeah.
That is the middle turbinate end. See this middle turbinate.
Yes, yes. Compressed, totally compressed.
Totally compressed. And give me a pack. क्या दिया इतना? See now I have ample of space to work around.
Yes.
And
Yeah.
one more pack. Now I will take the margins of the sphenoid for the septum.
Yep.
See such an ample of space, and meantime I'll just leave a pack on this area to improve my field. And now I will take the margin. Hope the picture is good now.
Yeah, very good, very good.
See this septum.
Yes.
Which is involved. That I have to ensure and void margin from this area. See this. Coagulator. What I am showing, see superiorly, this is the margin I am taking. This is the anterior margin.
Yeah.
Now below. See inferiorly.
Yes.
All that involves septum has to go.
Yes, boss.
Yeah.
Completely means completely. This part, see now all around I have marked.
Yes.
Yeah.
You can see what.
See through the cartilage going on with the coagulator only.
Yeah.
Because whatever margins I have missed, marked, I should not miss. See my margin?
Yes.
Now give me the scissors. See this. This part of the septum, which is the site of origin of the tumor, has to go, completely go. Yes. See this, what a...
Here also we take a healthy margin, some 4 mm, 6 mm, something like that.
Not really, sir. Here, looking at the pathology chondrosarcoma,
Yeah.
if I am sure that I have taken a margin, is good enough.
Okay.
Lot of people even do a subtotal resection.
Yeah. That's why I asked.
Boss, Dr. Tharum from Vietnam is asking, is there any role of image guidance or navigation system in cases like this?
Image guidance I'm going to show. We had a lot of requests coming to show the navigation. So next case I'm going to show you, but practically, image guidance keeps the pre-operative image data. In such cases, when you remove the tumor and the soft tissue shifts, image guidance has no value.
That's true. That's true.
Yes, image guidance is always valuable to improve your local.
Dynamic thing, you follow the tumor, isn't it, Dr. Satish?
Yes. Exactly. Now I have a debrider. Coagulator. See, in next few minutes I'll be over through this nasal part, and then we'll focus on more important areas.
Yeah.
Any trickling coming from the septum here will keep on spoiling your telescope.
That's the most frustrating.
Yeah, so you have to be the debrider. See now septal margins I have taken, and I am sure debrider. This part I will take. Forcibly. See now you can say no tumor in the inferior part.
Yes, sir.
In the nose, no tumor, not only in the inferior but the lateral part as well.
Yes.
See this. Wash kar. See this panoramic picture. This is from the nose now.
Yeah.
Now when I go up, I will change to a different endoscope.
Satish boss, will you do smart-ectomies to improve your...
Yes, will do at least on the left side.
Okay.
That has to be done because the tumor, the way it is compressing the orbit, I have to reach there.
Yes.
I cannot reach without that. So smart-ectomy will be required on the left side. Right side, I don't think. See now the interior of the sphenoid, opticocarotid recess.
Yeah, we can see lateral OCR on right side.
Yes, OCR पे लगाना section. Yeah. See the OCR?
Yeah, very clear.
Now see, this is our on करना Doppler. Section. Now I am with my Doppler.
Yeah, we can see the both right side. We can.
Not very decent. Can you hear?
Yeah, we.
See, up is the optic now there, where the section
Yeah.
This is OCR, this is Sela, And this is your carotid artery here.
Yes, yes.
Do you hear?
Now.
Can you hear?
Yes, now we can.
Yes, yes, boss.
That is the carotid. And now we'll move further. Let's see on the opposite side also. Do something. Give me a letter there. This is spoiling my telescope, no? This one. See this one? This spoiling my telescope again and again. Yes. Now. So that picture is good now?
Ultimate.
Now I will come from the left side, do the ethmoidectomy, follow over the orbit, then go over the anteriorly over the intracranial fossa. Deep right. 40. 40. That's the maxillary sinus ostium pressed laterally.
Yeah, yeah.
That's the ostium?
Yeah.
नहीं चल रहा है.
Septal ostium.
We're just going to stick to the lamina.
Pardon? I will go along the lamina.
Along the orbit.
Yes, yes, because that is the most important area for this.
Yeah.
Also, even the floor of the sphenoid is also very thinned out, na, in this case.
Yeah, because of the pressure. Everywhere it is the pressure.
So I think we can would be very clearly able to see the Vidian nerve there.
Vidian nerve, let me see if I can.
Yeah, yeah. So we can
see, this is the tumor.
Yes, yes, yes.
See this tumor?
Yeah.
See this tumor?
Yes, yes.
See this big tumor?
It's huge.
So it has gone below the middle turbinate, boss?
Not below.
It has come from superior.
Yeah, it has pressed the orbit. See now, I will make it through and through by removing this. This is the tumor here, which was pressing on the orbit like this. See this?
Yes, yes, boss.
So Satish,
see this?
Satish, are you going to think of orbital transposition and try to access this tumor laterally?
It is already transposed.
Yeah, I understand, but are you going to do it?
Orbit is already transposed by tumor.
Yeah.
Literally transposed.
Our uncinate is also gone on the left side, no?
Yeah, I removed. This was a uncinate was very small here. See this?
Yeah.
This one.
Yeah,
the upper
yeah.
part.
Okay.
Look at this. हटा बोन हटा दे. See, this is how the tumor was going up.
Yes, yes, yes.
Ah, cough later. Cough later, cough later. Ethmoidal artery.
Yeah.
Short.
Yeah.
See what a vessel. Bone है. Everyone see the intraethmoidal artery?
Yeah.
Yeah, Satish.
Monopolar.
Yeah, there is a bone all around. I will open this bone later
Yes.
and catch the vessel later on. This was good enough for right now. Section? Remove. Use component.
Yeah.
See this? Use.
Yeah, big.
Wash. Yes. Clean the field. This is, yes, posterior superior to the orbit, and this is all internal debulking.
Yeah.
Lot of tumor components.
Dr. Satish, any role of warm saline irrigation for the hemostasis?
Yeah, we are using only.
Okay, thank you. Yeah, we can see the bleeding, yeah. That is from the anterior ethmoid.
I don't know. This is something different.
Okay.
Are you planning to leave cuff of tissue anterior-superiorly so that you can clear the tumor posteriorly and prevent the prolapse of the dura down?
I don't expect much of prolapse of the dura.
Okay.
I don't think there will be prolapse of the dura in such tumor conditions. Opposite side.
Yeah. That's the wall of the tumor, or still we are internally?
Yeah. This is wall of the tumor.
Yeah, that looks like, yeah. Now it is coming clear. As seen in the CT, as seen in the MRI, it is hardly any attachment,
Attachment means on the soft tissue walls.
Yeah.
I can see the vessel here on this side also.
So I think I am sure 99% people have seen this intraethmoidal bleeding first time.
Yes.
Really?
Bleeding anterior artery first time.
Now in the extended procedure, this is hardly anything. In FEST, it is most important.
Yes.
So all depends what you are doing, what is your goal.
Spinopalatine area, boss, right? You are working on?
Down.
Wash. Give me a good wash. Mm. Mm. See, every time you have to reorient with your landmarks.
Yes, yes, that's
The
true.
rider.
Many ENTs comes to your place to learn. I think I will send my staff to learn so many things from your place, from your people.
Oh.
So many things are
We can send our staff for a training course to Tua.
Yeah.
Yeah, I'm doing internal debulking.
Suction pressure is amazing. That is.
See, this way looks like the tumor is also falling down.
Yes, it's going down, coming down.
So
I think it is important to note one thing, that he, although the tumor was like a big chunk was coming down where he's now working, he's still internally debulking and then trying to take down whatever is the loose part. He's not pulling on it because
yes.
Then you don't know what all from the brain is going down.
yeah, we have a very close relationship of ACA posteriorly.
Yeah.
Any role of Valsalva or raised IJV at this level?
Not really. It's too big a component. Why Valsalva and all this when you have a solid tumor?
Once in the last, just whatever is there, let it come down.
Oh, see, that is the surface.
Yes.
That is the brain surface, That is the dural margin.
Okay.
Could you see?
Yeah.
So now that is the indication that the dura here is involved. And I can see. That's what I am showing that. Yes, the dura is.
Yes.
Involved.
Yes. And that gives you an indication that your bifrontal is going to be, or cannot be, is going to be done.
Yes. And we would need a pericranial flap for this.
When you raise the craniotomy section, that you'll always raise section. I can see the dural margin. Did you notice or not?
Yes. So in this case, we cannot have hadad flaps. We cannot have lateral wall flaps.
No.
Pericranial.
You have a pericranial. See now the dura from inside.
Yes, boss.
Yes.
Yeah.
See the most superior portion of the tube I am sucking out. अरे ओए वंडर कर उसको सुनता कम है यार see now
Yes.
this is with section. See the dura.
Yeah, you can see very clear.
Coming out nicely.
Narayan.
Yes.
Now once we come from above, we'll see this portion of the tumor. Superior portion.
Yes, boss. Dr. Thorung from Vietnam is asking, will you put a lumbar drain, or you have already put a lumbar drain because there is a large CSF, large skull-based defect.
That is not the indication of lumbar drain for that matter. That is not always the indication for lumbar drain.
You have the
You have to
system.
relax him a little.
Then he requires the lumbar.
See, in this patient, when you have debulked this, see this?
Yeah.
Lumbar drain is your choice if you want to. This is not essential. See?
Now you are going laterally on the left side.
I'm already going laterally up to the outermost part of the tumor.
Yes.
That
Supraorbital going towards that area.
ये हटा ना.
Yes.
हाँ हटा दो. You can't. हाँ इधर भी. Yeah. So our goal was from beginning was to go from inside and hollow it out completely. Yeah, I will show with the angle telescope also later on. Tumor, all this component. Hello?
Yes, Satish, go on, we are listening to you.
Had this been an elderly patient,
Yeah.
I would do a subtotal resection and radiate because of the, the nature of the tumor, slow growing. With good 10-year survival. But this is a young guy. I want to give radical clearance. The only thing, posterior model artery. Hello?
Can you show us again?
I will show again. See the posterior model.
Yes.
Yeah.
Right, absolutely. Clear. You will bipolarize now, boss?
Yeah. Now, once we have decided to go from above, see, once you do a combined approach,
Yes.
you have to ensure both the territories giving full clearance. Now, here,
All areas should be clean. Yeah.
here, once you come from above, there is nothing about the dura. Dura is the limit. What's my point?
Yeah.
What you have to do is remove the involved dura and come out. The main job is below. If you are going to leave the tumor behind, it will always be below.
To live intact inside.
That is the supracellular component, boss. You are using.
Yeah. Because there is nothing about the dura in this patient.
Yes. Everything is below dura. Yeah.
So we have to ensure a complete clearance from below.
Yes.
Dr. Satish, as we keep on removing the tumor, dura itself will fall, isn't it?
May not be, sir. This is a tumor which may be infiltrating the dura.
Okay.
So that is not like arachnoid in the pituitary.
It is not a cystic. It is not cystic tendon now.
Okay. Because the way it seems the margins are so thinned out, and as we remove, the dura may fall because of the intracranial pressure.
No, see the tumor on the dura.
Yes.
Yeah. Yes. That is there.
We have to.
Bipolar artery.
Yeah. Probably later. So we have to. Thank you. I hope you are oriented how we are going about.
Yes, yes, everybody is.
Yes.
This is the right candidate for the clipping, you know?
Yes.
Who was
Yeah,
asking? Rajiv, you were asking about
Yeah.
the clipping,
Yeah,
no?
yeah, I was asking, boss. Yeah, yes.
This could have been clipped.
Yes.
कर दो. No problem.
So again, that's Dura is uniformly involved, boss.
Yeah, yeah.
So boss, it looks like it is the tumor is pushing the optic chiasm up, you know. So does the patient has any visual vision loss?
Not pushing, not pushing. See, the optic chiasm is here, Rajiv. Here
Okay.
below. Here is below. See, the optic now is below.
All right. So the tumor is above the optic chiasm. Okay.
Yeah.
boss. Yeah.
Yeah.
See the both sides optic pulse.
Yes.
See this side as well. This one.
Yes, we can see. We can see now, boss. Yeah. So
This is the optic canal of this side.
yes. The tumor has gone transplanar into the posteriorly.
Everywhere, wherever it could go.
Yeah.
And safest instrument is the section. See, complete exposure of the dura. So far we are going as per our planning.
Yes.
I told you in the beginning.
So here we are very close to ACA, boss.
That is beyond the dura, man.
Yeah.
I am with the section inside the dura. See this?
Yes.
See this, how the tumor with the section.
Yes, boss.
Yes.
Dura is coming down. See this?
Yes.
See how the majority of the tumor has come out.
A beautiful demonstration of the anatomy also.
Look. See, the aim of demonstration of this case is, number one, chondrosarcomas, we need to understand these are slow growing tumors. Unless it is mesenchymal, so cytology is important.
Yeah.
Your pathology, everything is important, number one. Number two, these are surgical candidates where you can give a long-term, outcome. See this angle?
Yes, boss. Yes. So.
Yeah.
Oh, right.
ऊपर से जाओगे ना
We can see the dura very clearly.
Yeah, now we can see the clear margin.
Healthy dura.
I'm trying to separate from the dura everywhere.
Yeah, boss. That is a plane. Yeah, we can see that. Literally.
This is in the supraorbital region, isn't it?
Yes.
Right now?
Yes. See the optic now in the middle.
Yeah.
I hope now you are understanding what was our goal in this.
So
case.
not dehiscent, isn't it?
Watch the camera lens.
You don't have to terrify with the scans.
Yes.
See what I'm trying to see, the dura. And dura is now looking very, very soft.
Yeah.
It started falling also. See now?
Yeah.
See now, it started falling also. Majority of the tumor is out.
Yeah, that is what I was telling Dr. Satish.
Pardon?
Once the tumor is out, the dura will itself come down.
Yeah, it will.
Yeah.
It will, but you cannot ensure the microscopic clearance from the dura.
Yeah, that's what. But otherwise, on the lateral side, it looks very smooth and as if devoid of any mass, isn't it?
Yes.
On the left side.
Yeah, many of the places it is quite smooth.
Yeah.
Yeah, this is the rent in the dura. See this? Could you see?
Now I see.
Hello?
Yes.
Yeah.
So that will take care from above. Lot of people may not go up from above and finish it off and follow with the radiation. This has been the standard treatment in the literature. But see, this is a young guy. 20 years.
Yes.
And we have a chance to give him cure. We have a chance to give him complete cure by means of doing one more procedure to come from above.
Yes.
See, the dura is falling.
Yes.
Now
we can ask for Valsalva, so you can take out from the corner.
No, I will go with the angle telescope first.
Okay.
See this Chondrosarcoma, jelly. Same story, we have done more than this, the petroclival Chondrosarcoma. There are more common. This is not so common. Chordomas and Chondrosarcomas are more common in the clivus, chordoma in the center. See now the proptosis has gone. The patient's proptosis has gone, I can see. Give me the divider. Now little bit on this, after this medial wall clearance, I will come with a 70 degree to show you up and behind. That will be the final component.
So wonderful demonstration was. I think we are seeing this anatomy for the first time like this.
See, this is anatomy we can learn best from cadavers.
But
see the medial wall of the orbit.
Dural folds like they are present here due to the disease.
See, this is the medial wall of the orbit.
Yes,
to apprise you, this is the optic now.
Yes.
On this side, the posterior we have coagulated here.
Yes.
This is the tumor behind. See this?
Yes.
This tumor. And this is the stump of erythroid here. That we are left because of some bone over it. See now the things are much better. Majority of the tumor is out. See the dura. It has fallen down. See this? Now give me 70, 70. कर दो, दूरा हटा दो, मैं कर दो, now see with a 70 degree, लंबा वाला दे, ठीक है, हो जाएगा, see with a 70 degree, hello,
Yes.
that is a part of the entry into the dura here.
Yeah.
Let me show you one by one all areas. First to reorient you. Now see, wash the wash. Just washing it to show you something better. Or there. Is the picture better?
Yes.
Now see one by one. This is right side.
Yeah.
To orient you, this is the sphenoid.
Yes.
Okay? This is your coina to orient you.
Yeah.
Then this is your sphenoid.
Yeah.
Now coming to the right side. Yes, सही डाले यार. Now, this was a little bit of the component going up on the right side, not very big.
Yeah.
See, this part has come down from here.
Yeah.
Right side has minimal component. Section कर देना. Section कर देना. सो कह रहा है. सोचता बहुत है. No. Yeah. This is on the right side where the tumor was going up. And look at the dura. Here is the dura. See, it's fallen down.
Yes.
Now this was not a bigger size. Our main area of interest was on the left side.
Yeah.
Now this is your orbit. See this?
Yeah.
This is your entire dura.
Yes.
And this is behind and above the orbit. Now I am with the 70 degree. I will go more and more up like this. See this much of the tumor left behind?
Yes, yes, boss.
Yeah.
A little bit laterally and little bit superiorly.
Yes, yes. And 1 किलोमीटर दूर से आता है. ओए क्या करता है यार? Don't do this. Sorry. See this part of the tumor?
Yes.
See, this is the farthermost dura.
Yes.
Yes, you can see. So you have reached almost at the Tyrion point.
Yes, yes, exactly.
Yeah. So, Satish boss, do you think we need to remove the dura of this patient and just repair by pericranial flap superiorly and leave for radiotherapy?
I will remove the dura, boss.
Okay.
This is a young guy. Had this been above 50, I would not do. My surgery would have been finished by now.
Yeah.
Young patient. See, this huge component is still there.
Yeah, yeah. And that seems to be adherent, isn't it?
Pardon?
That component is adherent to dura or what?
Not adherent to. Same like other areas. You see this?
Yeah, yeah.
This is a little inaccessible area.
Yeah.
I am working
That's
about the
why-
orbit.
Mhm.
You saw in the MRI that component was coming from above into the orbit.
Yes.
This is that
From
component.
above down it was coming. So that, yeah.
Yeah, the orbit has already come down. No, no, वो क्या नाम से ball probe. See this. This is the orbit from below. I am pressing.
Yeah. Yeah, yeah.
And this is
Yeah,
the
it's free, almost free.
minimal remnant.
Yeah.
See this?
Yeah, yeah. That is what I was talking about. Yeah.
Big chunks over there, na? All over this orbit.
See, how can you leave behind?
No, no.
How was the vision in this case?
Vision was good.
Good.
Yeah. Then, see, this is intraorbital component coming from above and I am removing from below. So this is requiring all 70 degree, 120 degree section tape.
Yeah, Satish.
See, so big a component it was.
Yeah, yeah.
It's a never-ending huge tumor.
It's too end.
He is near the finish line. Huh?
No, there's still a lot of chunks over there.
Yeah.
Yeah,
You've done a fantastic job to reach so laterally, but there'll be big chunks over there still.
So I reached the orbit on the superior surface from below. So that required 70 degree and my 120 degree suction tip.
Satish, if they're doing an external surgery, more accessible for external area?
External surgery.
Yeah, are they doing it? Bifrontal craniotomy?
Yeah, yeah. I will do for this patient
Yeah.
to remove.
If they're doing it, this would be accessible for them quite easily.
Yeah, I understand. What I want to assure here. See now the periorbita.
Yeah, I've seen.
Yeah.
Can you see?
Yeah, we can see that.
Yes, yes.
Yeah, yeah.
These are all hidden areas.
Yeah. Actually, that is coming from above and going behind the orbit, isn't it?
Above.
Satish, this area where you have removed?
Yeah, is above the orbit.
Yeah, it is coming from above and going behind the orbit, isn't it?
Yes.
Yeah, this is the one.
This is the most inaccessible area.
Yeah.
मोड़ यार हाथ घूम पंडा
Just a thought. Do anybody use robotic arm to visualize these areas?
I don't think it is developing. See now,
Yeah.
the periorbital is pretty clear.
Yeah,
Yeah, yeah.
Absolutely clear.
Yeah.
Amazing job.
See the periorbita.
Yeah. Absolutely clear. Yeah, that is small piece.
So very soon our next case is induced already. That is a parotid macroadenoma going suprasellar and compress the third ventricle.
We can use hydrodivider over here to get.
Yeah, we can. Yes, boss. Because that will help in leaving this, separating this tumor from the.
Dr. Dr. Rajiv is very fond of hydrodivider, isn't it, Rajiv?
No.
No, you often describe at the right place, I remember.
This was a suggestion by Dr. John Shadow from Australia also.
Now see the dura beyond.
Yes.
And see the entire periorbita intact.
Yes.
Post radiotherapy, what are the 5-year survival rates of these patients?
Yeah, very good. Boss, even after subtotal resection and radiation, even after subtotal, the 10-year survival rates are above 80%.
Oh, good.
But seeing why I am struggling more and more with this chap, he is a young man. We will never get this chance of operating again. I mean, in the such a best condition, I would say. Recurrence are never, always challenging wherever they are. See the डालना पानी देख रहा है हाँ इसको प्रेस करके रख इधर now see the entire angle
yeah
let me clean it we are on the final stages of the endonasal part.
Doctor, we have removed all the mass and there is a proptosis is gone, the dura has come down and we find just very few areas of dura which seems to be affected. The rest of the dura seems to be normal. What's your feel of that?
Sir, we cannot ensure a free margin.
Yeah, that is a histological thing, no?
Yeah, with oncology, that is most important.
Yes.
Boss, will you resect periorbita also then?
No. Periorbita is absolutely, it has already eroded the orbital plate superiorly.
Yeah. Superior periorbita.
Yeah, no, not needed. There is no, I would say, since the bone is already eroded. See this periorbita?
Yeah.
Why do?
So what we are going to achieve by a cranial approach now?
What I am going to achieve? Yes, sir.
Yeah.
What I will achieve this dura. See this?
Yeah.
Which is maybe microscopically involved, maybe. Though I don't see any involvement now.
Yeah.
But still, I want to resect it and put a pericranial flap. There is no harm in doing that. That will be the best way.
Gives a better longevity.
That will be the best way to ensure R0 resection for this patient.
Yeah.
Wonderful.
Wonderful.
See now my tumor is out. My tumor is out.
Yeah.
You can see any nook and corner.
This right superior margin are also very clear. Can you show the right superior? Yeah.
Right
Yeah,
superior?
right yeah.
Right is good. Only thing in one place.
Yeah, that is what I
opening
was.
in the dura.
Yeah.
Amazing case, boss.
Yeah.
By radiology, it looked like massive and monstrous case which cannot
See
be
this?
endoscopically.
Now the brain is falling.
Yeah.
Yes.
Now the brain is falling. See this? We'll just put a pericranial flap here.
Yeah.
That is our most common flap when we do such approach, combined approach. But rather I would like everyone should know pericranial flap. Not only in neurosurgery or skull-based practice, in many areas as well. That is the simplest of the flap you can do and versatile. See, now the tumor is gone. Can you see anywhere any remnant of the tumor? Imagine when we began with our plan, how we started. This is how such skull-based lesions. So morning was a lesion for the transcribiform approach. This was a different lesion, and now will be absolutely different with a pituitary, suprasellar, third ventricular floor, all those areas. So today was a complete skull-based day.
Anterior skull base, extended in anterior skull base.
We'll have now variety of such cases. These are the basics of the cases. In coming time, we'll do more and more, transcribiform, transcellular, supracellular, clival, so that to complete the skull-based series.
Excellent, Dr. Satish.
Question that as the tumor was going posteriorly, can it cause some hypothalamic dysfunction?
No. It is a slow-growing tumor, expanding. It was not, infiltrating. Brain has an enormous capacity to expand and, tolerate such slow-growing expansions, compressions.
I think if I put it other way around, Dr. Satish, suppose it's a hematoma which develops, say, within hours, probably the effect could have been disastrous with blindness to hypothalamus.
Yes.
It is only because it's a very slow-growing tumor, there was a compensation taking place, and the symptoms were less and less. Am I correct?
Yes, absolutely true, sir.
Thanks.
Agreed. Absolutely agreed, sir. Now, boss, when he does from above, we'll show in between his steps what he's doing.
We will like to know, Dr. Satish, what he will be doing here on. Since you have done the most of the part of tumor removal.
Yeah, I can show you pericranial flap.
Yeah.
But see, we have to start pituitary 6:30 in the other theatre.
Yeah, that you. Yeah.
And
that
here
was
in
the
between,
deadline, I remember.
In between and in the PIP, we'll be having this picture on.
Yeah.
Satish, good clearance you got from below.
Narayan?
I said you got a good clearance of this case from below.
Oh, thank you.
Dr. Satish, can we have the neurosurgeon's view on this right now, if he is there?
Yes. We're discussing.
Can we have his views, please?
Yeah. Look.
My opinion, it was a very good resection, especially behind the orbit and superior posterior to the orbit. And there's some kind of involvement in the dura, we have to resect it in order to make it total clearance.
Okay.
Can you hear him?
Not very much.
Not very much?
Hello? Yeah, miss. We can't hear very clearly. So intermittent some sound is going on.
Boss, can you repeat again? Yeah. So according to him, he's happy with the clearance from below.
Yeah.
And he is of the same opinion to remove, dissect this dura from above and put a pericranial flap. That's it.
Okay.
See, that is the final solution for this guy. Put a pericranial and forget about it.
Just the last word, Dr. Satish, from you.
Yeah.
Had some people left it from here and repair the dural defect and come out.
Pardon?
And rely on the radiotherapy.
Yeah.
So that will not give a good quality of life. But do many people do like that?
No. As I told you, even the most of the literature says do a subtotal resection and radiation. Most of the literature.
Yes.
Subtotal resection and radiation. Time.
Yeah.
This is what most of the literature says. So, this I believe in the young patient, once it is malignant, whatever grade it is, low grade, intermediate, yes, I know, it is important from prognostic point of view. But this is our belief that this patient, only this part of the dura, see everywhere it was a radical clearance.
Yeah.
In the nose, in the septum, towards the nasopharynx, everywhere was a complete capsule around it, which we could remove in toto. Only area is the dura, where this part of the dura, we are not sure of a radical clearance. I know radical clearance is not always wanted in such case, but to stay on the safer side, as this being a young patient, why to take a chance? Just 1 hour additional. Just do a craniotomy, resect this dura and put a pericranial flap. That's it and forget about it.
Absolutely agree. If a person is devoid of a post-radiation and all that, its morbidity reduced by anything, and long-term survival definitely increases. I do agree with you. Excellent presentation, Dr.
Hello?
Yeah,
the Pankaj boss is washing up and he will show us the steps of meantime from above.
Yeah, please go ahead.
Yeah. Are you getting this MRI?
Sure.
Now go back to what we started with. We started from here. See this complete margin we could take safely all around everywhere.
Yeah.
This was possible because there was no critical structure around. And then we went up. Here was a rent. And we could remove from everywhere. This dura we can see. This part was removed in the end. You could see. This tumor was coming from above. And I was going from below like this. Like, let me make this to show you. Pencil. See, I was going from here with a 70 degree and then 120 degree section like here. Because this was a component which was coming from above. Rest was cleared from here like anything.
Yeah.
And we could see this dura falling. Pani dena. In sagittal.
And boss, it is not easy to maneuver 120 degree suction tip with such a fineness that you did. I would say wonderful job in that lateral part.
Thank you. See, this was the posterior part we removed from the sphenoid, clivus.
Yes.
When we saw the clivus recess, and this was how it was going up.
Yeah.
Our vessel was just behind. You were asking about the vessel.
Yeah.
That was beyond the dura.
Yeah.
As long as dura is intact, you can't injure anything. you can hollow it out from inside without any damage to anything.
Which you have already done, boss.
Satish?
Yes, man.
I think I can see 10 shots online. I don't know whether Dr. Anand is already online.
Are they online?
I can see the 10 online. He's not.
Dr. Anand, they're online.
Both are online?
Yeah, just go ahead.
Hello. Hello, sir.
Hello.
Hello.
Hi, Dr. Yes.
Hi, Doctor. Hi, Professor Schwartz. Good evening. Good morning
How
to
are
you.
you?
I know 9 o'clock in New York is good morning.
Good morning.
Thank you. We are so pleased to have you. Believe me, it's like a dream come true for us. It's like a dream come true for us.
It's my pleasure to be here, and I look forward to watching and learning and participating. Should be very
Oh,
interesting.
thank you. You have been, these words from this legend is something I have no words to express. Believe me, what a person he is. Let me tell you something about him. He is not a simple person. He is an amazing neurosurgeon. He has got so many awards in US for the best neurosurgeon of US. Best doctor of US overall. He is a scientist. Presently, he is heading the Department of Neurosurgery and Neurosciences. He is the Director of Surgical Neuro-Oncology and the Institute of Minimal Invasive Skullbase and Pituitary Surgery at the Well Cornell Center in New York. Well Cornell Medical College, New York. He's a special interest in pituitary and endoscopic skull-base surgery. And I will tell you, I have a, there's a gift they have given to the world. This book is something he and Professor Vijay Anand, they have put their life to give us all entire information about this, one of the commonest and the most interesting surgery. Right from the most theoretical point to the most practical one you can think of is there. And I can believe writing such a book takes, decades and decades for a person. This requires everything you can put in. In the epilepsy part, he's a deep interest in, he's heading the epilepsy research laboratory there. And this is something surprising for us because we are not into epilepsy part. We don't know much about it. But he's doing a research work on neurovascular coupling and so many things. For the neurosurgeon, know much better about that. And he's now developed a new brain and mind research institute there. That is something amazing. His academic records, unbelievable. More than 175 publications, 65 book chapters. And like this, 3 more books. What he has authored is something, a gift to the world, I would say. His guest faculty all over. And he's on the editorial board of one of the most famous and reputed neurosurgery journal, World Neurosurgery and Journal of Neurosurgery. He's visiting professor to so many universities in US. So many universities there. Wherever you go, Dr. Schwartz. And, he's very popular on the, for the public as also. He's doing a lot of public awareness program and lot many popular news channel like ABC, NBC, CBS, and so many things. And his articles are published. And we hear a lot of, journal, a lot of newspapers like New York Post, Wall Street Journal, New York Daily, so many things. He is so popular a person and he has committed his life to neurosurgery. And we are so fortunate to have him here to learn from him today in this webinar. From our heart, we are so thankful to sir, thankful to you. Thank you so much for making to this webinar. We are indebted to you. Thank you.
Well, it's really a pleasure to be here. As you know, I've collaborated for many years with Dr. Vijay Anand, and
yes,
worked very, very closely with many ENT colleagues at Cornell and have learned so much about how to do surgery, how to use an endoscope, how to give the best care to our patients, only through collaborations with my ENT colleagues. And so it's really a pleasure and an honor to be part of this symposium. And I expect to learn as much from you as I can hope to impart on you. So
oh my God.
Looking forward to hearing and listening and participating in the discussions.
Thank you, sir. See, sir, the screen, are you getting this MRI on the screen?
Yeah.
This is the case we just finished off. This was a chondrosarcoma. We did endoscopic.
Wow.
This was a tumor arising from the nasal septum, going up to the intracranial fossa. She is scalloping of the dura all over, then going, elevating the entire frontal lobe. You can see how behind it is on the sagittal, pushing all the neurovascular structures beyond, and then falling on the orbit from above. And we could remove with our 120-degree instrument from above, from the orbit, and we had a complete clearance. What we are doing, now our neurosurgeon friend has taken over, and he is doing, our last plan was, since the tumor is almost a artery resection, still I can't rule out a micro-invasion in the dura, though we could clear it completely. So he is resecting this part of the dura by a bifrontal craniotomy and put a pericranial flap, just to be on the safer side, because he's a 20-year young guy. The patient is a 20-year young guy, and we can't, or we don't want to take a chance of a recurrence. This is just, we have finished, and we were waiting for you for the next case to start with.
Wonderful.
Thank you.
How do you know it's a chondrosarcoma? From the frozen, or do you have a biopsy?
Biopsy. We had a pre-op biopsy, which we reviewed by 3 pathologists, and it turned out to be a, a grade 2 chondrosarcoma. And I can see on his screen my favorite Professor Sethi here. You know, Professor Schwartz, he was the one who told me on first instance we should have Professor Schwartz. He's the king of neurosurgery.
Well. Nice to see you again.
He calls you the king of neurosurgery.
Well, you flatter me, and I'm just ignoring all the flattery. It's no good for no good to hear things like that.
I got. So, sir, we are here with our next case now, and this next case is a 42-year-old male patient who presented to us with a bitemporal hemianopia. He was referred after an MRI, then we got this MRI again done. This is our MRI protocol, which I am going to share with you, and we'll have your opinion as well. First of all, after the MRI, yes, I will go through the hormonal and other things. Let me take you through about the lesion first. This is a coronal T2 weighted, showing this snowman. Yes?
I see Dr. Anand has come online.
Morning. Is he?
Morning from
I was waiting for him.
Morning, Dr. Sethi.
Photo loud. Hello, sir. Good morning.
Morning.
Good morning. So nice to have you, sir.
Yeah, carry on, carry on.
Thank you. And let me tell people something before I go beyond about Professor Vijay Anand. He has been our great teacher. You know, he is a very, very popular, sinus for this sinus treatment in New York and many parts of the US. He is into teaching for last more than 30 years. And the book I had shown, this was published by both of them together. And this is the biggest gift, I say, to the world, what you have given by publishing this, besides many other books. He has published, more than 200, he has to his credit 200 publications and more than 40 book chapters. Imagine how much academically he is into it, how much he is oriented and what he is doing for the society. Besides that, presently, He is presently the clinical professor at the, Will Cornell Medical College of the rhinology, and he is the director of postgraduate training. He has been the president of the American Rhinology Society and the Bronchology Society, Laryngology Society. See, these are legends we are having today, and every single word coming from them is like a dictum, what I believe. Thank you so much for making for it.
Satish?
Yes, yes.
Dr. Anand and Dr. Schwartz, they were here at Mumbai in 2011.
Yeah, you told me.
Time with them around. Dr. Anand, of course, remembers, and I remember Ted also that visited Agra, and I think that was his first visit to India, if I'm not mistaken, right, Ted?
Yeah, still my first and only. Amazing visit. It was a beautiful country.
Sir, this is my invitation again to visit Jaipur and Agra, sir. It will be a pleasure for us to host you. Any moment when this COVID era ends or whenever you feel like, please, you'll be our guest.
That sounds great.
Thank you. Thank you.
Thank you, sir. So coming to this case, this was a 42-year-old male presented with a visual field defect and referred to us for this surgery. And the imaging is on T2 weighted. He had this kind of a lesion, snowman kind of a lesion, which is compressing on the third ventricular floor. And I have the other angles as well, which I'm going to show you. First thing, what I look at the MRI, what we should is the extent tumor, the consistency, the idea of consistency can be ascertained by means of an MRI very well, to certain extent I would say. And what I see in this MRI for consistency, the T2 weighted images most importantly, and what I did from my software, I changed the intensity. And see, look at the inhomogeneous appearance. Can you see? That gives me a good idea of having probably a soft tumor. Dr. Schwartz, Professor Schwartz, your opinion, you must be looking at the consistency. There are so many criteria people are taking into consideration. This is one of our most reliable criteria what we believe in, to look at the T2 weighted and inhomogeneous consistency. What is your opinion, sir?
So the brighter the tumor is on the T2,
yes,
usually the softer the tumor will be.
Sir.
In terms of the heterogeneity, I don't find that as useful as just how bright it is on T2. And
okay.
Then if you look on T1, if it's bright on T1, there's usually blood in there.
Yes. So brighter and T2 is generally a softer tumor.
Yeah. I agree. I mean,
Yeah.
I think looking at the images.
How do you look at this tumor? Looking at soft or fibrous?
I think it'll be fairly soft. I don't think it's going to be that fibrous. It looks, bright enough that I think it'll come out pretty easily.
Okay, that's great.
I would like to see the T1
yes.
before I make my final decision.
Yes, I will show you the T1 as well. I will put up together. This is my T1 coronal. I am going to show you all sections. This is T1, and what we can see here is the bright spot of the posterior pituitary up, pushed up. So now, what is your opinion, sir?
I think it's going to be soft. I don't think it'll be too soft. I think it'll be an intermediate consistency.
Yes.
There'll be some parts that are a little bit firmer than others, but I think it'll come out nicely. I'm not worried that you're going to need a special instrument because it'll be overly fibrous.
Sir, so according to you, your opinion is the T2 weighted hyperintensity is the thing which gives you idea about the consistency. That is the best criteria.
Yeah.
Okay, great. That's a great point, sir. Now, if I put up the other sequences we got done, which we usually get done for everything, let me put up this diffusion weighted. A lot of people take into consideration the diffusion weighted MRI for consistency as well. And here for diffusion, this is a mixed, picture, variegated picture with a lot of areas showing restriction, lot of areas not showing restriction. This is simply what you were saying right now, that may not be so soft.
Yeah, I think that's possible. Personally, I don't think it's that important to me, whether it's soft or fibrous. The only difference it makes in my surgeries is whether it's going to go quickly or slowly.
Okay, that's
I don't put too much weight. Whatever it is, you deal with it when you get there.
Yes,
whether
sir.
it's soft or firm, I don't think it really
Doesn't make any difference. Yes. This is the sagittal picture of this tumor, and this is the tumor which is pushed above to push, into the floor of the third ventricle there, you can see here. And this is how the tumor is bulging down in the sphenoid. And this sagittal picture for us is very important. And what I believe we have been doing in the practice, see, let me take a pill. This is our, by and large, cellar opening. This is the going to be our size of the cellar opening. Generally, we make when we open up the face of the cellar, the floor of the cellar. What generally we do, sir, we'll have your opinion. We remove this tuberculum up to here. We remove this tubercular bone, tuberculum cella, up to here and give a huge, this tumor, which is, coming like this. Let me show on the pens differently. Generally, we have this kind of exposure when we see from below through the floor. What generally we do, we remove this bone of the tuberculum to make our exposure little bigger. So this is tumor a little more decompressed. We have a better access anteriorly, and this gives us a better access overall. Do you remove in such supracellular tumors the tuberculum and the part of the bone above?
Yeah, absolutely. I think you have to. I think it's critical to take the tumor all the way up to the planum, and you usually can see, looking at the dura, the change in consistency of the dura as you get up to the planum.
Sure.
And then you also have to take the floor all the way down to the floor because you want to remove all of the bottom of the tumor as well as the top of the tumor.
Sure. Then we have, for the audience, we always get, when we get MRI done, an MR angiogram in all the pituitary patients, irrespective. And this is our MR angiogram to have a complete idea of the carotid and the vascular structures all around the lesion. See this? This is now the cavernous carotid going up, and this is the vessel where it is dividing into anterior and middle cerebral vessels. We can see this very well to see the relationship better in the coronal plane. See, here is the vessel, and see this vessel, carotid, around the tumor. This is paracel carotid, this is paraclinoid carotid, and see how these vessels divide into, around the tumor, into anterior and the middle cerebral. And this is why we get done this, to have a information about the intercarotid distance. See, this is the narrowest area, the paraclinoid carotid, where the intercarotid distance is minimal. And I can measure it in this patient. This is more than 2 centimeters, sir. That is a favorable thing for us to have a good intercarotid distance. In the lower part, even it is more. So we have a huge access into the cella. See this. It is more than 2.7 centimeter lower down. And second thing, what we see, earlier we used to take the NOSP classification into consideration about the invasion of the cavernous sinus. But now, with this dynamic MR angiogram, we are not generally taking the NOSP into consideration, because many a time the NOSP is overrating the cavernous invasion, because that is not dynamic. You draw the line on the static picture where you see the paraclinoid and the cavernous carotid in one picture. And we draw a line like this. In NOSP, what we do, in NOSP we draw a line like this at the medial end of the carotid, lateral end of the carotid, where the tumor is falling, whether it's medial to it, in between, lateral to it, or complete involvement, something like that. But now with dynamic MRI, this MR angiogram, that has proven to be absolutely useless to us, what we believe. See now what I'm trying to say. This is my cavernous, carotid, paracellular. Now if I see dynamically, you may find through the NOS classification in this particular patient, looks like the cavernous is invaded. But practically, if I see dynamically, keep an eye on this vessel. Keep an eye. See, this tumor is nowhere going lateral to the vessel at all. It is just pushing the medial wall of the cavernous sinus, that's it. There is no question of invasion of the cavernous sinus. By dynamic information, we can assess the invasion of all the 4 parts of the cavernous sinus: posterior, superior, anterior, inferior, lateral, medial. And this dynamic to us gives a better information about the involvement of the cavernous sinus per se. I know for an experienced surgeon like you, cavernous sinus involvement or little bit of the cavernous sinus involvement is never a big issue. Like you said, whatever the consistency, you have to remove it. For you have been so experienced. So, but cavernous sinus involvement for a novice surgeon, beginner, less experienced people is a big issue, and most of the time it is frightening. Because of taking the NOS classification into consideration, most of the time the surgeons are frightened as find the tumor is involving the cavernous sinus, but most of the time in those level 1 or 2, grade 1 to NOS, we have seen many a time, we have confirmed with this dynamic imaging, it is just pushing the medial wall of the cavernous rather than involving the cavernous. Your opinion, sir? How do you assess cavernous?
Yeah, I don't think that the NOS classification guarantees that you're going to get actual cavernous sinus invasion. The NOS classification is a radiographic classification, and based on that, you can try to calculate what the likelihood of actual cavernous sinus invasion is. So NOSP himself realizes and knows that if you have a grade 1 or a 2, the chance of cavernous sinus invasion is very low. And it's only in a grade 3 or a grade 4 that you have a higher NOSP classification. I think that this MR image is beautiful for sure to have the vasculature highlighted, but even on a more traditional MRI, you can see the vasculature. It may be black instead of white, and you can also see the cavernous sinus invasion and make a NOSP classification on a traditional T1 coronal with contrast. But cavernous sinus invasion for a NOSP 0, 1, or 2 may be 20%, whereas for a 3 or 4 it goes up to 70 or 90%. And the classification is really just a great radiographic criteria that allows you to try to determine what the actual invasion may be. The other point is that the NOSP classification doesn't take into account different compartments of the cavernous sinus. And when you're looking at a scan like this and you're embarking on a surgery, it's not just important to say yes or no whether there's cavernous sinus invasion, but to actually try to mentally picture in your head where that cavernous sinus invasion is going to be. Is it going to be inferior to the carotid? Is it going to be between the carotid siphon? Is it going to be posterior to the carotid? There are many different compartments of the cavernous sinus that need to be imagined in your head, and then the images from the MRI superimposed on that. So you have to investigate the proper areas in order to get the tumor out.
Oh, super. So this is in every case when we get MRI done for pituitary, we get this 3-dimensional MR angiography done. It gives us a good information about the cavernous sinus involvement, status of the carotid artery, any, in a rare situation, any pseudoaneurysm or anything, fistula or anything in the carotid you can make out very well on the MR angiogram. And this doesn't take additional time. When you are doing MRI already, you can get this additionally done in all those patients. Then another sequence we get done for all these patients for our purpose. For you, I know it is not that much value, but this is 3D flare sequence. We get 3D flare sequence, we went to the literature and found everywhere people quoting, if you have a, inhomogeneous appearance of the lesion in 3D flare, contrast 3D flare, it is most likely to be a softer one. So this assessment of between a soft and a firm tumor, fibrosis or a collagen tumor, is better distinguished according to the recent literature by means of a contrast 3D flare. Once we get MRI, we get this sequence as well. This is just to share the information of what we are getting done.
Can I make a comment?
Yes, please. Yes, please.
There has been so much literature written about trying to determine if the tumor is going to be soft or fibrous. And I think that the reason that was so important and has been important in the past is that when we used to take these out with a microscope and we would make a smaller opening in the bone because we were afraid to make bigger openings, couldn't see, it was critical if it was soft or firm, because if it was soft, the tumor would deliver itself and you'd get it out. And if it was firm, it would not deliver itself. But when you use an endoscope and you do an expanded...
It's no more a problem.
What's that?
Yes, sir. Once you are trying to say when you use endoscope, it's no longer an issue.
Yeah, I don't think it's as important an issue because you come around the capsule, around the outside of the capsule, and you can manipulate and push down on the capsule to get the tumor to deliver itself. And I think it's no longer as critical an issue as it used to be. And I think we make a lot of statements and noise and put a lot of importance to it. But I don't think it's as important as
So it's a great message from the master that there's no point wasting time into it once you're using endoscope to fall into whether it is soft or firm. But yes, if it is firm, you can plan your surgery accordingly. Because in that situation, you can carry out an extracapsular section and you have to be prepared for it because it's not going to be suckable. So this is something important information. That's it. Now, besides that, we always get CT scan done also, sir. And generally, we don't use navigation, but here I'm using navigation. Generally, we don't use because it is of not much of a value once the tumor is removed or decompresses as the structures, the anatomy changes. So on the CT scan, what we want to see is the status of the nasal septum, any sinusitis, status of the pneumatization of the sphenoid, any abnormal septations within the sphenoid going to the carotid or anywhere. All those things we look into, on CT scan when we think of getting a CT scan done. This is bone window setting, soft tissue window setting, and see all these septations and all these things need to be looked at. Most important is the pneumatization. Sir, you must operating now. You must not be looking at the pneumatization also, because you have been doing so much, whether it is pneumatized or not. Are you doing the conchal sphenoids also?
Yeah, of course. But it is critical to understand the anatomy of the pneumatization, to know how much bone you have to drill out. And also, when you get in there, you're going to see those septations. And those are landmarks that you can use to figure out where the carotid is, to figure out the lateral margin of the tumor.
There must be using navigation, sir.
We do use navigation in every case, but sometimes the navigation is off and you can't trust the navigation. It's not always 100% accurate. So you have to rely on your review of the MRI scans and CAT scans and the sphenoid sinus anatomy, and knowing where those septations are and where they're going to lead you to help you figure out what you have to do.
Yes, sir. So that is important. That is a message from the master. Once you are doing this, you have to be able to do everything. You have to be used to the anatomy as well. So, and in such difficult situation, you can take the help of navigation. But you can't rely much on the navigation. Navigation is not everything, I would say, he wants to say. Now, besides this assessment, this was a non-functional tumor as it came out from the hormonal assessment. And let me introduce everyone. Our endocrinologist has joined us. He is a very senior endocrinologist in our city. And I welcome Professor Sailesh Loda, sir. Can I see him on the screen? Hello, sir.
Good evening. Thank you.
Good evening, sir. And he has been part of our all, endocrine assessments in pituitary surgery. And I want to give a message to everyone, colleagues who are doing, pituitary surgery, endocrinologist and an integral part of the team, whether it is a functional or a non-functional tumor. A lot of people have a misbelief that if the tumor is non-functional, endocrinologists have no role. It's not like that. And endocrinologist has a huge role in pre-operative workup as well as post-operative care. A lot of problem patient may face in the post-op period due to hormonal imbalances, electrolyte imbalances, and so many things, and endocrinologist is integral part of it. See, this is our list of pre-op hormonal assessment, which I learned from Vijay Anand sir's and your book, that these all tests should be done. Sir, we had been doing all this before, except this alpha subunit. Are you getting on a regular basis this alpha subunit, sir?
You know, our endocrinologist likes to get it. I don't find it that helpful in helping me figure out what I need to do, but certainly the endocrinologists do follow it.
Loda, sir.
Yeah.
Sir, your opinion in a patient who is supposed to be a non-functional tumor, as the patient came with the visual symptoms with a huge macroadenoma. What is your, looking at this list, anything you want to remove or add on for the pre-op hormonal assessment?
Yeah, I think alpha subunit is of no utility, just a theoretical importance. So, and actually we don't have it available in most of the centers in India. So I think it should be removed. Rest everything is okay.
Does. Sir, you know why we started following him? As some of the literature says, many of the non-functioning, pituitary adenomas are gonadotrophic pituitary adenomas, which are not showing those symptoms. Subclinical gonadotrophic adenomas, which you can even miss with the LH and FSH testing. And alpha subunit testing can pick up those, because many of those adenomas where the alpha subunit was raised, on immunohistochemistry, the SF1 was positive, which is specific for gonadotrophic adenomas. So it is a belief that many of the non-functioning are actually gonadotrophic adenoma. That's why this was to be done. I don't know the present status, whether people are getting done or not.
Yeah, actually, large part of non-functioning pituitary tumors, they belong to gonadotropins. I agree with that. But still, it is not useful. And one additional point I want to make it clear here, that free T4 is not available at most of the centers in India in a reliable manner. So I would advise not to go for free T4. Instead of that, just go for total T4, which seems to be more robust test.
Okay.
Because it is very important to have normalization of pituitary axis, particularly for cortisol and for thyroid pre-op period. So, and if we are more concerned with cortisol and thyroid in pre-op period.
Even this patient had a low cortisol pre-op, and we have been supplementing for last 7 days, and today morning he has a cortisol level 16. It looks good now. So this is somehow one of the manifestation of these non-functioning tumors. Either they manifest with a visual symptom, most commonly like this patient came. Otherwise, pituitary insufficiency because of the pressure on the pituitary, because of maybe devascularization, pressure, devascularization or stroke, whatever region, pituitary insufficiency is one of the presentation. And many of the patients generally do not present with it, but they have, once you assess the hormonal levels, you get to know the pituitary insufficiency. And this is like sir mentioned about the cortisol. This is something very, very important. Schwartz sir, in your series, you have a huge experience. How many of these hormonal insufficiency patients presenting in non-functional do recover later on once you remove the tumor?
Maybe 10%. If you're hypopituitary, it doesn't always come back. So once you're getting supplemented pre-op, you often need to be supplemented post-op. The prolactin will come down because you relieve the pressure. That will certainly improve. But hormone levels don't always come back. They're already damaged by such a large tumor preoperatively. Wouldn't you agree?
Yeah, I think 10 to 30% of these individuals, they recover. Majority, more than 2/3, generally don't recover. If you are replacing pre-op, you have to replace permanently for rest of their life in post-op period.
Yeah.
So that is a very important thing. We need to counsel our patients also, because this aspect patients are not aware of when they present with a visual symptom or something and get the surgery done, and afterwards they get a surprise that now they have to take the hormones lifelong. This should be a part of pre-operative counseling as well, because most of them are not likely to recover from their pituitary insufficiency. This is a very, very important subject. Sir, Loda sir.
Yeah.
Besides this workup, you mentioned about this patient to me. Once I told you about the prolactin level, you said get done again at dilutions. Any reason for that? Any reason to it?
Yeah, because you see, prolactinoma is the commonest pituitary tumor and easily treatable by non-surgical means.
Yeah.
So it is always better to rule out a prolactinoma at least, because sometimes if the hormone levels are too high, like 5,000, 10,000, then due to antibody reaction, blocking antibodies, then you get a falsely hook effect. That is called hook effect. You get a low prolactin, as it happened in this patient 13. So I thought, although it is a remote possibility, but I thought it may not be a prolactinoma. So it is better to get it in dilutions.
That rules out.
Once you are sure that it is not a prolactinoma, then you go for surgery.
So when you get in dilutions done, it rules out completely?
Yeah, sure.
So that is another important message. And sir, we are here in this webinar, the ENT surgeon, neurosurgeon community. Any message from the endocrine side you want to give? From pre-operative assessment point of view and the post-operative care point of view. Anything from your side you want to add on?
Yeah, sometimes which we commonly see that if only TSH is done in pre-op period, you will miss hypothyroidism. And similarly, cortisol assessment should be done precisely at 8 a.m. These are the two important tests which you need to do pre-op. There are a long list of tests, of course. You can go for them, but the mortality and morbidity pre-op and intra-op and post-op depends on these two hormones. Post-op hypotension, intra-op hypotension, and similarly not getting out of anesthesia if thyroxine is not properly replaced. So these are the few complications which can be easily avoided by replacement of these two hormones. And then post-op period, transient DI should not be treated very aggressively, because then you land up in SIADH, which is again a life-threatening complication in that period. And then reassessment of hormonal axis in post-op period, which may differ from protocol to protocol.
Can I ask one thing? Can I ask one thing, sir?
Yeah.
In functional tumors, you always advocate, obviously, it is required to assess the hormone levels in the post-op, immediate post-op and further on in life.
Yeah.
In non-functional tumors, would you get all this assessment done further in the post-op, and when?
Yeah, in non-functional also, because we know
all this entire list, what you get done before?
1/3 of them are likely to recover, and particularly if the tumor is not huge.
No, my question is, would you again recommend to get all the tests done, what you have done before?
Yes. Generally at 6 weeks, when everything is settled, we reassess.
Yes. Then we should get all the tests done.
If the patient is on replacement, then every 3 monthly we reassess for whether the axis has recovered again. This goes on for maybe 1 year, and once we know that now it is not going to come up, then we leave, and then the replacement is for lifelong.
Professor Ted, we know that 5 to 10% of the patients who were initially pre-op good, develop post-op pan-hypopituitarism. Being a neurosurgeon, from surgical point of view, any message, any tips to avoid that issue?
Yeah, I mean, I think no matter what size tumor you're taking out, all pituitary tumors have a pseudocapsule around them.
Yes, sir.
One of the advantages of finding that pseudocapsule and removing the tumor extracapsularly is not only to ensure you get the whole tumor out, but you also save the normal pituitary gland because you establish a plane of dissection between the tumor and the normal gland. And if you miss that plane of dissection, you may accidentally remove some of the normal gland and worsen their post-operative hormone.
Sir, can I ask you one thing? As from your experience, you know, it is always a big challenge to find normal gland in 100% of the cases. Now, with your maneuvers, your technique, yeah, like you are saying, the extracapsular is staying in the pseudocapsular plane. Any tips for the junior colleagues to find out the normal glands, or you take any help of any imaging like narrowband imaging or any other thing to find out the normal gland? Any tips?
Well, the first thing is to try to see if you can find it on the MRI scan, or at least find out which way the stalk is deviated, because the normal gland will be more on the side where the stalk is deviated, and that will help you. The other trick is to first decompress the tumor in the center. Don't try to take it out all in one piece if it's a very large tumor, because you're only going to find that plane if you decompress the center of the tumor and then try to work the plane. And then I start on the side where I know the normal gland is, because I'm more likely to find it on that side, and try to establish that plane early in the operation so that I can maintain it as long as possible. And if I can't find it in one area, then I move on to a different area and look somewhere else. Keep searching.
Great. That's a great message. So the bottom line is we should try our best to preserve the normal gland to prevent the situation of post-operative and hypopituitarism. And certainly this comes from the experience, and the thing coming from this experienced person is something important. The next part of the assessment was the visual. This patient presented with, and our protocol to get all these tests from our ophthalmology colleague who is part of our team. And this particular patient, when we got assessed, see the fundal picture, the optic disc. On the right side, on the temporal side is pallor, and this is a permanent damage to the temporal vision on the right side. Left side, you know, the margins are good. So though he has a bitemporal hemianopia, the reason for the audience, I tell you, the nasal fibers, whatever we see, the vision what we see has an inverted picture on the retina. So our nasal fibers are responsible for the temporal vision. Temporal fibers are responsible for the nasal vision. And that's how the nasal fibers, when they cross, decussate into the chiasma, that is the area where it is, you know, compressed by the tumor from below. That's how the patient develops bitemporal hemianopia. And since the pressure comes from below, as I said, the picture in the retina is inverted. The superior fibers in the chiasma are responsible for inferior vision. Inferior fibers are responsible for superior vision. So when the pressure starts from below, the initial fibers, you know, the visual defect come in the superior part. So initially patient present with the superior quadranopsia all around, and then further progresses when the all fibers press from below as a bitemporal hemianopia. This is classical of this, and this patient unfortunately has already developed this optic disc pallor on the right side, which is unlikely to recover. Though we have seen some of the patients recover later on. Sir, have you ever seen patient who didn't recover in the beginning, I mean immediate post-op in the few days, and they recover after few months some of their vision?
Yeah, I think you can recover a little more over time. Sometimes there could be a hematoma in the cavity. It takes a while to resorb. I don't think it's common, but I think it's certainly possible.
Okay, so our goal in this patient is a surgery, And we are all set now. I am going for the wash-up, and before that, I would like to, anybody has any questions, you can ask the legions. I will take few minutes to wash up for the city. The case is induced, everything is all set, and we are going to start very soon. So Paramita, Rajiv, any questions? We can have opinion from Professor Schwartz and Professor Vijayan, or anybody.
Most of the things are already covered. Just one question, is there any consensus about the color of the posterior pituitary by which we can differentiate it from the normal tumor intraoperatively?
Yeah, that's a great question. I think it can be very challenging to find the posterior pituitary gland. I think in the larger tumors, you almost never see it, but in the smaller tumors, you do. And it tends to be whiter and firm than normal anterior pituitary gland. So more of a white color and a little bit firmer.
Okay. Thanks, Dr. Schwartz.
I have a question for Dr. Anand.
Dr. Narayan, you unmute to ask first.
Yeah, so just another question for the delegates. When you have a tumor with a tension going towards the frontal lobe, would you change, Anand has been sitting quiet, maybe he can answer, would you change the exposure or would you still work with the same exposure? The bone removal.
The same exposure should work. You just hyperextend the neck, like about 30 degrees. Then you can look supracellular and also in the planum, cellular area. It should be pretty straightforward. I don't think you need to do anything different. All our patients, we do them in fit. And positioning is important. We always look like hyperextension, turn the head towards us so that ergonomically it's easy. So we don't have shoulder pain or neck pain particularly inside the pituitary or the approach. This patient has a large tumor, so we should plan reconstruction with the approach. I think this is a great case for a Janus flap. Use two nasal septal flaps, and I think the spur is probably in the vomer, so it's in the mid-septal area. You need to take the vomer out nicely, and the spine, and then drill out the spinal crust and also the
you had asked me to join to announce
so that you
the
can lay the nasal septal flap well. That's my thought process.
no, he wanted me to announce. He said you join and you announce.
How often do you use the Janus flap? Often you require a Janus flap?
No, not a lot. In large tumors like this, we do. But patient, if it is just cellular or supracellular, we don't. A large single nasoseptal flap should do the trick.
And just a question to you as well. You said you specified with fibrous tumors is still not a concern, but there are certain tumors which are really snowman, which have a constriction at the neck and still very fibrous component going way supracellular. Would you extend your approach? I mean, in the sense, take off a little bit of the plenum as well, or would you just go about with just a tuberculum exposure and then go about hoping that the tumor comes off and go for the extra capsular dissection?
So, if there's a snowman look to the tumor with a narrow neck and a narrow intercarotid diameter, it can make it more challenging. In that situation, rather than removing that much of the plenum, I would use a 45-degree endoscope and angled instruments and try to get up in between the carotids and just take your time, and slowly try to dissect it out till you feel like you get the majority of the tumor out. I don't think I would change the approach that much. I'd like to try to work more inside.
Professor Schwartz, can I ask one thing? You being a neurosurgeon, in your opinion, you are the pioneer in endoscopic pituitary surgery. In your opinion, in the present context, after so much of experience, what are the indications for a transcranial approach? or a combined approach?
Yeah, I have almost never used a transcranial approach for pituitary adenoma, although there are rare giant tumors where I feel that I'm not going to get the whole tumor out from below.
Yeah.
Because if you don't take the whole tumor out in a giant tumor, there is a very high risk of postoperative hematoma within the cavity of the tumor. And so in the really enormous tumors with very anterior extent, where I just don't think I'm going to get all of it out, craniotomy can be a better approach. Initially, you have to go back and do a transsphenoidal approach afterwards, but I think you're less likely to have an intraoperative hematoma when you're coming in from above than if you come in from below in the biggest of tumors.
Dr. Satish, we have Dr. Kirtane sir. I think we can share his experience also. And regarding 9th August program, can you hear some?
Welcome, sir.
Thank you very much, Satish.
Sir, most welcome, sir.
Satish, it's been fascinating watching you all these weeks and months. May I just make an announcement here for your program next Sunday?
Yes, sir, please.
For all of you who are logged in, you usually have once a year a program which is sponsored by the Alchem company. It's called the ENT Conclave, and it's done in different cities in India. At the same time, we have speakers from all over the world. This time, because of the pandemic, this is not going to be possible. So we didn't want to interrupt the chain. So we requested Satish that in this 10th edition of the ENT Conclave, as I said, courtesy Alchem, he's agreed to demonstrate surgery to us, which he's been doing all this time, from 9 in the morning to 6 in the evening. The only thing is he's promised this time to do surgeries which would be basic as well as advanced. Basic because I feel that the take-home message for many of the people who are watching is that they learn something which they can apply in their own practice in the straightforward cases and give better results to their patients. So on Sunday, the 9th of August, starting at 9 o'clock Indian Standard Time, do log in for a treat. He's going to cover otology, rhinology, laryngology, head and neck surgery, and skull-based surgery. So please, this is an invitation to all of you to register for this. The link we will put on Satish's program. So he will send you the link because he's going to be operating, and it would be really worthwhile for all of you to join. Satish, thank you very much.
Thank you, sir. Thank you. And we are starting the case now. And
we are with you.
Professor Schwartz, there are 8,000 people presently logged in to hear from you. So feel free to comment on anything you feel like. Vijayanand sir, please feel free to comment whatever you feel like. Whatever you say, believe me, it's like dictum for us. Please.
One of the key things when you vasoconstrict the nose, we use 4% topical cocaine, and we used 4 cc's of 4% cocaine, and then I inject Zalecan 1% with 1 in 100,000 epinephrine. Always make an incision. I do that on the left side because I'm a right-handed surgeon. So we do a left hemitransfection incision, and I always do it posterior to the valve, the nasal valve. It's important you make the incision in the hemitransfection area and carry the incision inferiorly onto the floor posterior to the nasal valve. Otherwise, post-op, patient is going to have nasal valve stenosis.
Sir.
Also, when you raise a flap, make sure you have a good caudal strut. Otherwise, you'll have a supratip saddle.
Sir, can you see this picture of this patient, endoscopic?
We can see.
Are you getting the endoscopic picture?
But it is not on the full screen.
Hello?
It is not on the full screen.
Not on the full screen. Can you put up in the full screen, please? Full screen pe dalo. Are you getting the picture, sir? Vijayanand
Yes,
sir.
now it is there. Now it is there.
Vijayanand sir, look at this side. The patient has a severe, this is unprepared nose. We haven't put anything inside as a decongestant. And what we see is a septal deflection, deviated nasal septum. What you do in your practice when you find such a deviated nasal septum, do you always do a septoplasty or you ignore this?
No, you have to fix the septum. There is no way in creation you'll have good opportunity for post-op care or even the approach if you don't have the septal correction. You can see the spur along the inferior aspect of the septum, and it is going into the inferior turbinate. So you won't have a good vasoconstriction. You got to do it as atraumatically as possible, because if you are bleeding, it really becomes a problem. So once you decongest the nose, you wait for a good 5-10 minutes. As you can see, he has moved the septum to the midline, and you can see the indentation of the inferior turbinate. I usually use a Goldman bar and laterally displace the inferior aspect of the inferior turbinate, and you should try your best not to have any bleeding. And I inject Zalacan 1% with 1 in 100,000 epinephrine. The key here is once you inject, you have to be patient. Wait for good 10 minutes. There is no hurry. Once you have a good vasoconstriction, it's almost like an investment in time, which will pay dividends during your approach. Good vasoconstriction, good inferior turbinate, and if the patient has hypertrophy of the posterior tip of the inferior turbinate, you use a tissue shaver or a coagulator and reduce it. I usually use a tissue shaver after I get the area. Once you do that, then I displace the middle turbinate and look for the ostium. The ostium is going to be at the posterior tip of the middle turbinate, and also you can look at it and confirm your position with the wand for the image guided approach. It will tell you exactly where you are. When you raise a flap of the septum, you got to do a maxillary, premaxillary approach. What I mean about that is take out the cartilage superior first, and dissect the crest and the maxillary crest on the side which is easy first, so you don't perforate the septum. And secondly, you can do with an endoscope and a sharp cortical elevator, pick out the spur and we use a V-chisel, just like a gouge, and then take out the spur. Once we take out the spur, you can see the sphenoid rostrum. Sphenoid rostrum is a good landmark. It will tell you where you are. Once you see the sphenoid rostrum, you drill that down with that spur, and then both with a cutting burr and a polishing burr. The key is using a diamond burr will get some hemostasis, just like otology. You know, when you polish that area of the inferior aspect of the floor of the sphenoid sinus, all the emissary veins and all the bleeding vessels will be completely sealed. So I usually use a non-penetrating instrument like a free air elevator, and just pack the nose and wait. When you raise a flap also, you got to be careful. You got to leave a good strip of the olfactory epithelium, which is about 2 to 3 millimeters above the vertical attachment of the middle turbinate. So when you have to come posterior to anterior, you have to be careful, be mindful of the position of the vertical lamella of the middle turbinate. It's important because you can preserve patient's sense of smell. Also, when a large tumor like this occurs, we always tend to take out this posterior turbinate of the superior turbinate completely and the posterior aspect of the middle turbinate if necessary.
Sir.
And it is real. And if you have a patient who smells well pre-op and wakes up saying he can't smell anything, I tell them, just wait, be patient. We'll reassess in 6 to 8 weeks.
Nice.
They usually on steroids in the form of a topical spray after good reepithelialization. The olfactory fibers are also in the middle turbinate, not only in the superior turbinate, it's in the middle turbinate. So you have to be very mindful of that. It's easy for us to completely remove the turbinate and resect the tumor. But if we can manage and preserve middle turbinate and superior turbinate on one side, it will be very helpful. I don't think we have any studies to show the relationship of anosmia with preservation of the superior and the middle turbinate yet, but we have to look at it with probably a smell test pre-op and a smell test. And recently, there are publications that using, omega vitamins and also glutathione helps in regeneration of the olfactory epithelium. I'm not so
Hello,
sure.
sir. Hello, sir. Can you hear me, sir?
Yes.
I can hear you very well, no problem.
Vijayanand, sir, can you hear me?
Yes.
So, this patient has a septal deviation on the right side with this spur. And what I believe, we have two options. Either to leave it and go ahead, I can resect the part of the middle turbinate and can do it. Second is to correct this with a limited septoplasty, this septal deflection, and we'll have a better space for demonstration. So what I can show here quickly is a limited septoplasty for this patient. And see, this deflection is quite severe on this side, and that too in this region where we generally raise a rescue flap. So in case I find a problem, I can raise the rescue flap from the opposite side. So what I am doing with the incision on the opposite nose, I will raise a limited flap to do a limited septoplasty to take care of this spur. That's it. My goal is not to correct the septum for the nasal obstruction, but for the spur.
How do you plan to reconstruct?
Sir.
Satish.
Sir.
What is the plan for reconstructing the defect?
Reconstruction?
Yes.
Cellar floor reconstruction?
Yes.
Sir, in case there is a leak, we always, as I mentioned, we always raise the rescue flap. But if there is no leak, we generally don't reconstruct much to the floor. What is your trend? What is your practice? When there is no leak, would you still reconstruct the cellar floor with something?
We do, but I'll tell you the reason why. It helps to reepithelialize the defect nicely. And post-operatively.
So what do you use? What do you use, sir?
We use an septal flap.
Oh, that is when there is a CSF leak. Otherwise also?
Yes, I do. Because it helps to fill the defect nicely. Otherwise, you're going to have a pulsating brain post-op that you can see. It's kind of unnerving. And if the patient, for some reason, has any kind of head trauma, you'll have a non-penetrating head trauma producing CSF leak. So it's not too smart. It doesn't take more than 15 minutes to put a nasoseptal flap. So I always end up doing a nasoseptal flap, and it helps to make the area heal well, and also the defect plugged in quite nicely.
Okay. Oh, that is something great to know. that irrespective of whether the leak is there or not, you always put a nasal septal flap.
Is a big tumor like this? Yes. If it's a small tumor, we don't.
Yes, yes. You never know if you have given a micro leak somewhere.
Correct.
So it is always, according to him, is better to raise the put a nasoseptal flap always, because overall it helps in preventing the arachnoid exposure post-op. So that's a great input, sir. Scissors. So I'm just removing the lower, deviated portion a little bit, along with the spur.
You take nasal swab before surgery in all the cases for culture sensitivity?
Pardon?
You take nasal swab for culture sensitivity in all the cases?
No, if I find the signs of infection or something, you take care of it, otherwise not.
Suppose post CT scan patient develops some sort of sinusitis and you find it on the table, then any precaution you take at that
See,
time?
sinusitis is an inflammatory disease.
Yeah,
There could be associated secondary infection as well. So to us, sinusitis is not an absolute contraindication. Only thing is you have to be more careful in preventing the infection, in dealing with the region by being staying more careful towards preventing the infection. That's it. It's not an absolute contraindication. See, I am removing this little bit of the spur here. That will make my life much easier.
Can I ask you a question?
Yes, please.
Have you done coronavirus testing on this patient to make sure they're negative?
Yes, yes. Yes, sir. It was negative.
And are you confident of the result? And are you wearing any protective?
Yes,
PPE?
yes. All level 2 PPE.
So does that include an N95 and a face mask, a shield, or just a regular?
Yeah. Along with the N95, the whole body PPE, that is level 2 PPE, and secondly, the face shield over the N95.
And you do that even though the patient tests negative?
Yeah, even if it is negative. Had this been positive, I would not have been operating.
Right. Okay. Just curious what
That is the protocol that the government of India guidelines we have to follow.
Satish, can I add a point here?
Your knife. Yes, please.
Yeah, what I have also been operating, but what I believe is apart from a COVID test, what I do is I do a chest CT. I get the patient admitted.
Yeah, we are getting all the cases.
I do a chest CT scan the day prior to surgery. And even the COVID testing, it's not more than 2 to 3 days old. And once I'm confirmed that the CT does not show any changes, then I don't mind taking up the patient for surgery.
Narayan.
Yes.
COVID testing, even if the patient got done earlier,
Yes.
we get it done a day before surgery.
Exactly, that's what I just said.
Maybe we have to repeat it if the patient had already got done. But still, in spite of the COVID negative, we have to follow this protocol. It is necessary or not is a different thing.
Yeah.
You have to follow the Ministry of Health guidelines.
Yeah. So Ted, what is the protocol over there to keep yourself safe? I believe you all are back to almost normal scheduling.
Yeah, it's similar. We do COVID tests on everyone within 2 or 3 days, and then we wear appropriate PPE. We do not do a chest CT routinely.
See, right now I am doing this additional maneuver of correction of the septum to make my life easier in the demonstration. When you have this kind of a extremely deviated septum, I can do along with the deviation, but that repeated, trauma on the nose is something frustrates you. It takes additional 10 minutes, and then you are, you have a better life.
In spite of preserving the normal pituitary and doing good surgery, we get some post-operative pituitary dysfunction like diabetes insipidus, etc. How we can prevent it? I mean, how we can do at minimum as possible? What are the protocols? What are the steps you take while doing this?
Professor Schwartz has already mentioned, boss.
Yeah.
To stay in the pseudocapsular plane, identify the pituitary, observe it, and you can do it in majority of the cases. And this is something which is which comes from the experience. We have tried a couple of times with the NBI, narrowband imaging. That is something amazing, I would say, wherein this is not needed to the expert people, experienced people, but yes, sometimes what you can find on narrowband imaging, you can differentiate between the pituitary, normal pituitary and the tumor by means of a surface vascularity. What narrowband imaging does is, it picks up the surface vascularity, and this is something you can pick up with a narrowband, and you can easily differentiate whether it is a pituitary or a tumor or a normal arachnoid. You know, sometimes becomes difficult to differentiate even the normal arachnoid from the pituitary once it is completely collapsed over it. So narrowband imaging, if you have, you can take the advantage of it. Otherwise, it is the experience and the dissection. If you dissect in the, extracapsular plane, you can almost always preserve it. And like Professor Schwartz says, your pre-operative imaging will tell you where the pituitary is compressed, which side, and you can keep in mind that and take care of the pituitary. This is the usual protocol, what he has said.
Is there any difference between the growth pattern of the non-secretory and the secretory tumor, like non-functional growth hormone and the growth hormone secreting tumor or other tumors?
See now,
do they behave differently in the growth pattern? Is there any difference in the growth pattern of the functional and non-functional tumors?
Hello?
Yeah, Satish boss.
Can you see the space now I have gained? And this will give us, a good space to maneuver our instruments. This is right side, and our approach is, you have two options, either to lateralize the turbinates, or you can resect a part of the inferior part of the middle turbinate to give a cavity and half, exposure. And for demonstration here, for good exposure, I will show you how to put up a stitch here on the opposite side. I will put up a stitch on the pericardial, mucopericardial on the opposite side, so it doesn't come in the instrument again and again. So this small maneuver taking 10 minutes, I have an ample of access now to this. So whenever you think of whether to do a septoplasty or not, it is better do it. Why to struggle unnecessarily? Because the other part of the surgery is more important than this, and compromise with the exposure or anything, something before that can really hamper your overall temperament. So I'm just fixing up this flap. Yes, now let me tell you what is cavity and half exposure. Cavity and half exposure, because we are using endoscope. Endoscope acquire the physical space in the nasal cavity, and for that I will remove the part of the turbinate to park my endoscope when we work in the depth. So this is something, again a small maneuver, but helps you a lot without giving any additional morbidity to some extent. See this is the part of the middle turbinate. I can lateralize it or I can remove it, and that is the superior turbinate behind. And behind the superior turbinate, between the superior turbinate and the septum, that is the site where you will find the sphenoid os. So, ये registration हो गया सर, navigation? We have a fusion system, the Medtronic fusion system, which I've been using for last 13 years. though generally we don't put up in every pituitary case, because navigation is something additional to help you localizing your anatomy. This is not everything, but in difficult situation it is always good to have. And number two, in teaching plans like these courses, it is always better to have it, because this is a good source of teaching as well. So what I am going to do is, I am removing this part of the turbinate now. So now I will cover up my time, what I have invested in septoplasty. I will cut this down, because now my most important thing is the exposure. In this surgery, like Professor Vijay Anand says, you have to do everything to get a good exposure. That is the advantage of endoscopy over the microscopy, where you can really give a panoramic view. And I will show you our exposure, how we can give a panoramic view of the sala and around. See, this is the turbinate. This is the part of the middle turbinate. And this is the superior turbinate coming into the picture. That is the superior turbinate. I can remove quickly, taking care of the septal branch of the sphenopalatine artery, which comes, see, that is the site of the sphenoid ostium. You can see the sphenoid ostium there. You have to stay close to the septum in order to identify the ostium, close to the septum, and this is what the cavity and half approach. See, with time you have to decide on your own about the exposure, how you are comfortable with what kind of exposure. Nothing is hard and fast.
Satish?
Yes, quick.
Yeah, I see that you are only taking out the posterior ethmoids. What's the reason for leaving behind the anterior ethmoids?
Pardon?
I see that you are taking away only the posterior ethmoids.
Yeah.
Okay, do you do a complete ethmoidectomy?
Not really, but my exposure, what I want is from optic to optic, carotid to carotid.
Yeah.
And in order to do that, you have to do a part of posterior ethmoidectomy as well.
Yeah, so I do a complete ethmoidectomy. My reasoning is that it takes additional 2 or 3 minutes, and there is no point in leaving the anterior ethmoids there. What purpose is the cell serving over there?
See, that is the sphenoid ostium. Section 11.
Satish?
Yeah.
Any point leaving the anterior ethmoids in place?
No, anterior ethmoid. Why?
Yeah. You get a better exposure laterally. You have
that you get, I will show you, without doing the anterior ethmoidectomy. Why anterior ethmoidectomy?
Everyone gets a good exposure. That's not what I'm debating. I'm debating why leave behind some smashed cells over there when an additional ethmoidectomy is going to take you just 2 or 3 minutes to do it.
Yes, you can do, but generally we don't do anterior ethmoidectomy.
Okay.
Anterior ethmoidectomy is something which is, I would think, I don't know how you give exposure with the anterior ethmoidectomy more. If it is good, I will certainly like to see that.
Yeah.
Now see, that is my ostium, and what the first thing I want here, because in any case you need a Hadad flap, like sir said, he always needs a Hadad flap. What you can do if you don't need, in this side I told you, I am not going to raise the rescue flap. Generally, we raise the rescue flap, which I am going to show you on the opposite side. You can raise on both sides. Rescue flap is what? You are not properly elevating the Hadad flap pre-operatively, but you can preserve the vessel pre-operatively, so in case you need a Hadad post-op, you can always apply it, otherwise reposit it back. See on the opposite side. Now, that is your ostium. That is your sphenoid side and ostium. Can you see on the opposite side?
Yes.
And here, on this side, I am going to show you a rescue flap before I do a sphenoidotomy. This is the area where before doing a sphenoidotomy, I want to preserve this vascular pedicle. So in case I need a Hadad later on because of CSF leak or something, I will use it, otherwise I will replace it. So I am not going to use a formal Hadad flap. So what I am doing is, for the rescue flap, I will make 2 incisions. Let me elevate the Hadad flap. See this, my superior incision is just wash section. My superior incision, show. Yes, section. See, that is my ostium. My superior incision is just below the ostium. And I will come little horizontally up to the anterior end of the middle turbinate, you know. In any case we raise the Hadad, I want to leave this mucosa because this may contain the olfactory fibers as well. And whenever need, then I will rise it up at the anterior border of the turbinate. That is the superior flap, and the inferior flap is over the roof of the choana. So this is in between these two where the pedicle of the Hadad is. See this? Like this. This is the pedicle of the Hadad is. So in rescue flap, what you need to do is elevate this flap at these incision points. Elevate these flap partially. I am not elevating a formal Hadad, just a partial rescue flap like this. Similarly, I will elevate from below as well, and I can push it down. What I want to push down at this point of time, so that while doing a sphenoidotomy, my flap will stay below, and I will not damage the vascularity of the flap. See this? Can you?
Yes. Yeah. Yes.
You can easily push it down by going more and more lateral. You don't have to formally elevate from both sides, but yes, it's always better you can. And this contains the inferior branch of the nasoseptal artery. And this is how you can elevate it, push it down further, and this will not come in your way any point of time when you do the rest of the surgery. Okay? Now, having done this, since I am not raising the rescue flap on the other side because of the spur I had, now if I elevate the mucosa like this on the opposite side as well, what you see, what is coming into your picture is the rostra of the sphenoid. Can you see? Hello?
Yeah.
Rostrum clearly was.
Give me the, yeah. Here I will sacrifice this, the opposite side, because I am not raising the flap on this side, and I want a common opening. This is all exposure part, and believe me, this is the most important part. Any compromise in the exposure is something which is going to invite the problem. Which we are not supposed to. Here I am sacrificing. You can otherwise raise, if you want to, the both side rescue flaps as well. The coagulator. This is something I can raise with the coagulator elevate. This is part of the exposure. Depending upon how you are used to, you can do this. The most important thing is the opposite side where I raise the, you can see the rescue flap on the opposite side. Chota merocell there. And see the sphenoid rostra coming into the picture. This is a marrow cell which I am keeping here to protect my flap. This is wash, remove all blood stain. Now from this point onwards we can remove all bone pieces, since we have to work later on in the cellar with lot of soft tissue structures around. Any bone piece coming in your way, better to remove at the same time rather than giving a possibility of a problem later on. This can be a big source of problem. Now we can see on both sides the sphenoid ostium, see the mucosa of the ostium, and see the anterior face of the sella. Could you? Yes. Now this rostrum or this thing has to be removed. You have to do 3 osteotomies. Once sometime the bone is thin, you can do without that. You can remove it by various ways. You can remove by the chisel and the hammer. You can remove by, to be very precise, with the micro drill. There are many ways to do the same thing. The goal is to remove this rostrum and acquire widest exposure. See the superior bone I have removed even without debrider. Without the need of the chisel, it looking so thin. Let me show you. On the sides I need to have that is the anterior face of the sella behind. The next 10 minutes will be dedicated to my exposure of the sphenoid and the sella. That is the anterior face. See how it is bulging. We could see on the MRI how the tumor was bulging below. This is what Narayan was saying about the post-ethmoidectomy. We should ideally be done on both sides. See, never ever compromise with the exposure. If you compromise with the exposure, there will be compromise with the surgical work. So my superior limit of exposure. Yes, I have not removed the rostrum yet. Yes, please.
When I was talking of anterior ethmoidectomy, I was talking on the right side of the patient where we use it for exposure. We are doing, the whole world does a posterior ethmoidectomy. I agree with that. People do not even remove the middle turbinate. Agree with that totally. But my reasoning for doing the anterior ethmoidectomy on the right side is it improves the exposure. One.
That is great.
There's no reason for me, if I'm doing a posterior ethmoid, to leave behind some anterior ethmoid cells which are pro-sinusitis and further. It takes just 2 or 3 minutes to knock off the anterior ethmoids on the right side, but it improves your exposure like crazy.
Yeah, I would like to see that, Narayan. I understand what you are saying must be good. Must be good, that's why you are doing. But we never found any need to do so. I would like to see you.
Yeah, definitely. It showed the pictures.
We can ask Professor Vijay Anand if he is doing the anterior ethmoidectomy as well.
I think we would not be doing it.
रुकना क्या हो जाता है बोल Whole? Like there. Chota. हेलो हेलो किधर से आ रहा है कॉल लेटर है डाल दे इधर आगे क्या हेलो 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 हेलो
To answer that.
Hello. Hello. Hello.
Yeah, boss.
Yeah. Are you getting the picture now?
Yes. Yes.
Yeah. There was some disconnection, so I was waiting for that. How's the picture now, Rajiv?
It's good, boss.
See now what I'm going to do for further exposure inside the sphenoid. I'm going to do these osteotomies to remove this rostrum. See this? Yes. On the opposite side. Yes. Okay. On this side, I hope it is visible there.
Yes.
Clear, boss.
Yeah, see this rostrum is dismantled.
Yes.
And I will tell you our exposure, what I want to see from where to where. Superiorly, right from the planum sphenoidal down to the clival recess, I should be able to pass at least one section below, maybe more, but at least one section below the floor of the sella.
May I ask a question, please?
Pardon?
Well, I noticed you remove the rostrum with a chisel and a hammer.
Yeah, I can remove with a drill also.
Yeah, I would think that a drill would be a more safe and controlled way of doing it because you can really fully control.
Yeah, it is more controlled, more controlled.
Yeah.
Agree, sir. But now the rest of the job I will do with the drill to flush everything. And my drill of choice here is from the Medtronic stylus drill. Now see the cellar floor coming into the picture. And there are a lot of septations within the sphenoid.
Yes. So,
as I mentioned, I will go up right to the planum to visualize the planum on both sides to the lateral OCRs. I should be able to see that. Debrider. Drill ready. See, this is a part of the post-ethmoid anterior. Whatever I can remove with the micro debrider, I will. I am working on the cellar, face below.
This
That is the
septal has to the ICA, no, boss?
Pardon? If some septa is going to the ICA, you have to be careful. You are not supposed to plug them. You can drill them, you can use a through biter. Whatever you do, you have to be using the sharp instruments. I am exposing more and more sella. Next 5 minutes, I will be able to reach to the level of opening the sella once I, remove all these septations. Okay.
Regarding the mucosa of the sphenoid sinus, you just remove the mucosa of the salar region or of the lateral recesses region also?
Even lateral, wherever, until I flush everything. Okay. My goal is to flush the, bone all around the sella. I should be able to see the OCRs thoroughly. I should be able to see the planum, and all these septations, I want them to flush off completely. See, that's why I am removing this bone, so that I can flush all this. I am removing this mucosa. And this leads to little bit of the bleeding, which anyway will control before going to the cellar part.
There is also a school of thought which says preservation of this mucosa, but I personally think that this mucosa gets shredded when you really drill off the septations and try to smooth up the cavity. But yeah, definitely a philosophy where some people would preserve the mucosa going lateral.
But sometimes when you have large recesses, then you can leave the mucosa. Can we leave the mucosa in the those large, highly nucleotized sphenoids?
Yeah. Ted, what do you do? Preserve the mucosa or strip off the mucosa?
Preserve the mucosa in cases.
Yeah, a lot of people, there are many ways to do. A lot of people preserve the mucosa to make the flap of the mucosa sometime. Done?
Satish, Ted is answering that. Ted is answering that.
So the maneuver you're doing now, removing mucosa with a tissue shaver, I think is a bit dangerous, because if the carotid is not fully covered with bone, you are very close to the carotid artery on the sides there, and you can easily grab the carotid and damage it. So exactly. What we like to do is, first of all, we would drill out the bone more superficially and drill out the bone of the septations with a diamond drill, and it has to be a diamond drill so you avoid damaging, God forbid, the carotid is not fully covered. And then if we have a large pituitary macroadenoma, we think there's a high risk of a big CSF leak and we need a big opening, we remove all the mucosa of the sphenoid. And we do it by pulling on the mucosa, not with a tissue shaver. And if you just pull on it, it will come, and you can dissect it off the bone, and you don't risk damaging the carotid artery.
Yeah, I understand your concern, sir.
If we have a small pituitary adenoma where we don't think there's going to be a big leak, we don't have a nasal septal flap, then we'll try to sweep the mucosa aside so we can reapproximate it at the end and try to save as much of that mucosa as we can, because we know it'll be a smaller opening. But I would drill out a little more of the bone before removing the mucosa.
I am going to do, sir. Before drilling,
drill and smooth out all of the septations.
Yes.
First.
Yeah, your point is valid. We have to be careful, and I am going to drill out everything. And before that drilling, I need to remove a little bit of mucosa so that I can go to the bone.
Yeah, we do it the opposite way. We remove the bone so we can get to the mucosa.
Take your Sure, sir.
Yes.
With an upright pituitary forceps.
I will show you. I will flush everything with a diamond drill. I will flush everything with a diamond drill to the landmark which I have already mentioned, from the plenum to the floor and from OCR to OCR. We'll map the carotid with our Doppler and then we'll move on to the cellar. So this part, there are many ways to do quickly.
You notice you leave it's like a cottonoid in the bottom that you pick up and use to stop the bleeding. Is that right? Is that a 4x4? What's in the bottom of the nose that you use to dampen the bleeding?
Give me the drill. Yeah, this bleeding will take care in no time. Ribbon gauze.
You leave a sponge in the bottom of the nose there and use it. Can you hear me?
Hello, sir.
Is that a sponge you leave in the corner?
Hello. Hello.
You left something over there at the bottom, right? That's a gauze piece, right? A roller pack.
Yeah, is there a piece of gauze rolled up in the bottom of the...
Yes.
That's
the
a
gauze,
nice little trick.
What was it? You mean to say? Hello?
Show us the floor. Show us the floor of the nasal cavity. Can you?
No, if there's an Onodi cell, that tissue shaver could damage the optic nerve.
I am using very gently right onto the mucosa, having confirmed that no carotid is there. I am into the posterior cells, just taking away all those cells to expose. Now give me the drill. Let me show you where exactly I was. The coina is there below. See, this is the coina. And this is my gauze piece I have kept here. Here is my cellar, face. And this is my section. This is my coarse diamond bar. Pani kam karna. Section rakh. Marak. Oh. Yes. See, this is a coarse diamond bar with a 15-degree angle. I will remove all these septation, flush them completely without using any pressure on the drill. Section, blood ho wahan karna. See, whatever this mucus is oozing, I don't need to do. If I have a patience for 5 minutes, doing all this maneuver, that will disappear. That is the face of the cella. And I still want to go.
There are a lot of junior people watching. You must tell them how much to drill that edge at 6 o'clock and why.
The lower one?
Yeah, why would you drill it and how much would you drill it? Because there are a lot of junior people watching it.
Yeah, see, this lower part, my limit is, see how the cellar floor is bulging. I should be able to pass at least one section below it to maneuver my instrument at this level. At least one section. See, this little bit of the oozing, that will take care. Now wash. I am just removing the sedation, nothing else.
So people, ENT people watching, whenever you are doing this, remember the person assisting you has to have a very straight orientation of the endoscope. And all the time, the rostrum of the sphenoid or the septum is a landmark which reorients you back to the center. If that orientation of the endoscope changes, I think then you would be headed the wrong way with the drill or any other instrument.
Yeah, we should have our orientation, I mean complete orientation. Give me a gauze piece. This looks like my carotid prominence here, this one. I will confirm later. Still a lot of exposure is required.
May just be that the bone is overgrown there. Not just, that may not be the carotid.
This one?
Yeah, it may just be bony overgrowth. I don't know on the scan if it looks like the
Yeah,
sphenoid.
I have a good intercarotid distance, particularly in this patient.
But that is an area of the carotid only.
See, this is sella. This is going to be my paracellular carotid here.
Yes.
That I will show. And my exposure will go on either side till carotid to get the widest exposure, you know.
So you can just cauterize this oozer. I think this is from.
I can cauterize, yes.
I think you prefer bone wax rather than cauterization.
थोड़ा फ्लोसिन दे दो, थोड़ा फ्लोस देना, और give me a diamond दे, और I can ये नहीं वो दूसरा. I can, you know what? There are many ways to control this venous oozing. I can use a flow seal. I can use a, you know, surgery flow. I can keep my gel foam pressed, or I can use a dry diamond as well.
I use the diamond drill, like just like that. It completely with the bone dust. It seals up the blood vessels nicely.
Yes.
And if it still doesn't work, you use a suction cartridge.
Yeah, give me the some surgery flow a little bit.
I would use, yeah, thrombin soaked gel foam and just leave it there for 20
Yes,
seconds.
that will. Hold on. Just you can put for a few seconds and it will stop. We'll do it later. Chalo. Now, give me the, hold it. See the exposure laterally on this side. Laterally, inferiorly, I'll go to the other side, and then, you know, superiorly to complete a thorough exposure. I should not, that is the advantage of the endoscopic approach, that is the exposure. And this is a very important time. See, my sella is there in between, but still I have to expose a lot. A lot.
So on the right side, it is well exposed, boss. But on the left side.
Yeah. Yes, sir. Left side will require a lot of exposure. Even the right side, I have to flush these some of the prominences. They know. For venous bleeding, wounding, this is very common in when you work in the carotid around, this pituitary around. Pakad na. Lo, gel, please. No. Lag, watch please. See this? I'm bringing my surgery flow here. And just press with the gauze for a while. debrider.
Professor Mandurul from Dhaka is asking for the landmarks for cavernous carotid and how to prevent carotid.
Yes, sir. I am going to show you. Map your carotid on both sides completely with my Doppler. Now, little bit of the exposure I have to increase. Meantime, I have packed below. This is superiorly. And that is the region of the plenum. You can see the anterior limit of transplanum, that is posterior artery. Can you see?
Yes, you can see very clearly on the right side.
Yes, that is the anterior limit of, that is the anterior limit of the plenum.
Plenum approach.
Yes.
And it is the posterior limit of transcribiform.
Transcribiform. Debrider. See, that's how the anterior exposure is very important. That gives me full anterior exposure. This is in the midline. I have now adequate anterior exposure. And going to the opposite side and then flush away everything. Not to compromise with the exposure. It may take 5-10 minutes extra, but this will make our surgical course much easier for us.
I think the bleeding at the bottom is from both. If the diamond doesn't work, I think bone wax would be a very good option.
Yeah, I will do it. Let it be for 5 minutes.
I think Ted was making this point. Satish is using the debrider in this sphenoid sinus.
I know his concern, but you know, there are many ways
passing a message to the junior people that Satish is experienced, so he's using a debrider. Else, I'm sure Satish will also teach people, juniors, not to use the debrider in the sinus. Right?
Drill. I know, but here, you know, looking at the, I am just removing the mucosa and part of the thin septation. That's it.
Yeah.
There's if there's a dehiscence over the carotid, over the optic nerve, a dehiscence of bone.
Yeah, it looks dangerous. I understand it looks dangerous.
Yeah. So the message is for the junior people who are watching. It's not that you're doing anything, but I'm sure that's the message everyone want to pass.
Yeah, in your hands it's safe, but it may not be safe in everybody's hands.
I can see the optic now on the opposite side very good. Above my drill.
Yes,
you can see. Yes. See, this is the optic on the opposite side above. Wash.
Satish, again for the junior people, what are your limits of exposure? That's for the junior people. You must explain why you are exposing so much. What are your limits of exposure?
My limits of exposure superiorly is the plenum, laterally is the lateral opticocarotid recess, inferiorly I should be few millimeters below the floor of the sala, and floor is already coming down. See, this my floor space is already minimized.
You see, you still have, Satish.
Yes, sir.
You still have the keel of the sphenoid. If you take that out, it's a V-shaped, molar-shaped bone. You dissect out with a caudal elevator. Right there, where you're suctioning, anteriorly. You will see right there. And you dissect it out, it'll be unbelievable exposure to the floor of the cellar. And also when you rotate the flap, you won't know when it's completely healed if the flap is from the right or the left side. You got to look up your nose.
See now the floor. See now the exposure of the floor.
Just come anteriorly with your suction. Right there. That's the keel.
That's the keel which I am now removing.
Use the Takahashi to come right up.
Yes, that's the keel which I am removing. See this? That's the keel. So now you see further the exposure. See the exposure now improving? Pack this photo. Now I will check each and every corner now. See our landmarks. I have to flush little bit more and then we'll go ahead.
So
I usually use
all of the sphenoid you have exposed from orbital apex to orbital apex and posteriorly from lateral OCR to lateral OCR, right?
Yes. See on the right side. पतला रखा करना है. See on the right side, that is your posterior model artery.
Yes, very clear.
That is your.
You can even see the two branches.
Are you sure that may be a little posterior for the posterior ethmoid?
Yeah, let me show you. So I will show you all corners now before I go ahead. That is the region of the carotid artery. That is the optic nerve. You can see that's the optico-carotid recess, which I am going to flush. Increase my exposure here. Though I had a good intercarotid distance in this particular patient. Drill. I will flush some more septations, you know. With this bar, you have a very good control. You can have like suction. $100.
That's the clinoidal segment you are drilling.
No. This is in the region of the medial optico-carotid recess.
Yeah.
See the bone I am removing?
Yes, boss.
That is the region of the tuberculum.
Yes.
I am just exposing. This particular exposure is very important, you know. Right angle though. And give me a debrider. See this little bit of the mucosa. I want to remove from here. Expose thoroughly. See, any compromise in the exposure calls for a problem. I'm little more particular about the exposure. Like in JNA, you have seen several times. The majority of the time is spent in exposure.
That is lateral OCR on the left side.
Yes. Chala drill. Yeah. Yeah, see this mucosa? I can expose the bone only when I remove the mucosa. Drill. See, all this bleeding will take care of in next few minutes before we go on to the cellar phase, and I will make sure there will be no bleeding when I go to the cellar phase. Now this is another important area, medial OCR on this side. Can you see?
Yeah, that's medial OCR. Yeah.
पानी डाल इस पे.
So generally this is the segment of the carotid which is dehiscent most of the times.
Could be.
But here it's covered with a thick bone.
Yeah. Now you can see my exposure from lateral OCR to lateral OCR, medial OCR on both sides. Give me the irrigation statement. Let me irrigate, show you. I'll pack with my, pack for 2 minutes and then we'll go on to the cellar phase. Let me explain what I have exposed so far. See the cellar phase, and above this bone, see what it is? That is the tuberculum.
Yeah.
Can you see very clear? And this exposure of the tuberculum I showed on the skin. The moment you remove this bone, the moment you remove this bone, your tumor will bulge. Professor Schwartz, anything you will do more for the exposure?
No, I think for this particular tumor, you've done a great job. I think maybe in the bottom right-hand part of the screen.
Bottom right hand.
Yeah, a little bit of bone I would drill out. On the patient's left, our right, there's a little ledge of bone I might drill out to make sure I can get.
Yeah, this one.
Yeah, a little bit lower, but a little lower. Yeah, right there.
This one.
Yeah, just a little bit of that bone I would drill flat.
Yeah, I got your point.
But that's about it. Everything else looks perfect. I think you've done a spectacular job.
So this is my exposure all around. Back there. Back there. Now, next 2 minutes, I will ensure a complete hemostasis. I will see my carotids are covered with the bone very well. There is nowhere they're exposed. Even my Doppler may not pick up the carotid. But I have to make sure my carotid where they are. Generally, in the side exposure, in such a big tumor, particularly if it is going laterally, we remove the bone over the carotid as well, partly.
But in this case, we don't need to remove.
Yeah, because we don't have a lateral extension.
Don't have a lateral extension.
That's why I'm not going to remove that. But in this case, the superior bone is crucial.
Yeah. So you will remove the bone till tuberculum.
Yes, sir. I've already exposed the MOCR area.
Yes.
Back. Using this diamond drill, I will thin out the bone completely and then I will flake it off with my elevator. Back. Just 2 minutes time, this is for hemostasis. Until now, I was not, much worried about the little bit of the oozing going on and all that. I know this will settle down.
Okay, can I ask Ted a question?
Yes?
Yeah, Ted, if you have cavernous sinus extensions, okay, how do you handle them? Non-functional tumors and functional tumors, how do you handle the cavernous sinus extensions?
Yeah, it's a great question. So that's actually one area where the consistency of the tumor is very important. If you have a functioning adenoma and you're trying to cure the patient functioning tumor, then you have to go into the cavernous sinus and be as aggressive as you can without causing a cranial neuropathy. For a non-functioning adenoma, then if the tumor is very soft, I'll chase it into the cavernous sinus and take as much as I can safely take out. But if you leave a little tumor in the cavernous sinus and it's non-functioning, that's okay because you can always treat that later with radiosurgery. You don't want to cause a cranial neuropathy. So I'll only be very aggressive and take more risk if it's a hormone-producing tumor and I need to get a complete cure. But I will try to take as much as I can take out in non-hormone-producing tumors if it's soft.
And what is your technique for the cavernous sinus extensions? Do you take off the bone of the carotid, move the carotids, or would you go for a lateral compartment?
I remove all the bone over the carotid artery. And then I first take out as much as I can take out in the medial to lateral corridor and also work inferior. By removing all the bone, it allows you to be able to lateralize the carotid much more aggressively. And then in some circumstances, I'll open the dura lateral to the carotid, but very rarely do I think that that's really indicated for adenomas. Remember, these are benign, slow-growing tumors, and it's only if I think that there's a hormone-producing tumor out there that I really have to get out.
The lateral compartment, do you go for a transpterygoid approach, or how would you go about it? Just extension of this?
Yeah, you extend it laterally as far as you need to get the exposure you need. So with a modified, transpterygoidal approach, open up the maxillary sinus, drill out as much of the pterygoid you need.
Yes. Can you see the exposure?
Yeah. So the bleeding is now well controlled, boss. So
hello.
We are all good.
Like that. Sir, are you happy with the exposure part?
It looks very good. Excellent. So Satish, do you use thrombin in the gauze?
Pardon?
Do you use thrombin topically in the area of the gauze?
Thrombin? Huh?
Yes.
Topical thrombin.
Topical thrombin.
What I used was the surgery flow. That is not thrombin.
No, the gauze you have right now.
No, this is just simple saline and adrenaline.
I see.
So I have almost a bloodless field now, almost.
Satish boss, would like to discuss your experience and of the panel regarding the management in microadenomas.
Any particular question about microadenomas? Obviously, it's a complicated
Microadenomas, yeah, Professor Ted, yes.
Well, I was saying, is there a particular question about microadenomas?
Yeah, please, carry on. Go on. Am I supposed to say something about microadenomas?
Yeah, go ahead, boss.
Rajiv, direct your question to Ted. What were you asking? Repeat the question.
So, I was asking about his experience in microadenomas. I mean, how they manage and what difficulties he faced.
Yes, Kapila, Rajiv.
Yeah, boss.
Microadenomas, are mostly, when you operate, are functional.
Yes.
Non-functional microadenomas or incidental need not to be operated. So once it comes to functional tumor, assessment of the hormone function and everything, that is obviously the part of the management. When it comes to surgical areas, surgical issues, microadenomas pose more difficulty sometimes, you know. First of all, in macroadenomas, the intracavernous sinuses are almost always blocked by the tumor itself. Wash. In microadenomas, you may come across the bleeding of the intracavernous sinus, you know. That you have to tackle, number one. Number two, in functional microadenomas, it is almost always something what you need is an extracapsular dissection to give a cure from the hormonal issues. Microadenomas from the, you know, the ACTH nomas more commonly are most difficult to handle. The diagnosis is sometimes so difficult. You know, in spite of a negative MRI, patient may have a ACTH noma. In up to 30 to 40% patients may have ACTH noma and get negative MRI. So many a times your diagnosis is so difficult, and sometimes you have to resort to the issues like, you know, sampling from the inferior petrosal sinus or something to ensure this high cortisol is due to a ACTH forming tumor from the pituitary or some other cause. And sometime when you have established your MRI is saying negative, you may have to explore. Even in the negative MRI not showing any adenoma and you have a persistent high cortisol, you have to explore it. You may have to cut pituitary into pieces, you know, to find even a 1 millimeter microadenoma, and that can be the cause of the problem. So microadenomas are always challenging. We'll have Professor Ted's opinion.
Yeah, look, that's all true. Every microadenoma, you know, we obviously deal with ACTH-produced tumors, growth hormone-producing tumors, and then prolactinomas. The prolactinomas we deal with are the ones that are refractory. Medication, or the patients don't tolerate the medication, or patients who just want to be cured of their tumors. You know, I agree with everything that was said about the management and the case selection and the difficulty of ACTH producing tumors. But the most critical thing surgically is to do a wide opening of the cella. Just because you have a microadenoma, a hormone producing tumor, don't make a small opening in the cella. You still have to go from cavernous sinus to cavernous sinus, medial cavernous sinus, and from the superior intercavernous sinus to the floor. You need a very big exposure. And then you have to find the margin of the tumor and do an extracapsular dissection to try to take it out in one piece. And that's the only way you'll know for sure that you've cured the patient their microadenoma. And the other important thing is if the tumor goes up to the medial wall of the cavernous sinus, you often have to remove the medial wall of the cavernous sinus to cure a patient of their microadenoma, because the tumors can invade in the medial wall, they can invade in the dura. If the tumor extends down to the periosteum or dura at the floor of the cella, you have to remove that as well to make sure you get all the microscopic tumor cells. So you have to be more aggressive in the microadenomas that are hormone producing than you do often in the macroadenomas, because you really need a microscopic cure of them, which you really don't need in the macroadenomas, although it's nice if you can get it.
Yeah. Do you also use intraoperative MRI in these functional tumors or microadenomas, or how useful are they?
No, we do not use intraoperative MRI. You know, for the microadenomas, the resolution of the intraoperative MRI is often not good enough to see them. You know, I don't think that's very helpful. I think the only role for intraoperative MRI is really for the giant macroadenomas, where maybe you have a piece that's lateral to the carotid or in the middle fossa that you may have trouble getting at, and you're not sure if you've removed at the end of the operation. But I don't think there's really a role for intraoperative MRI and microadenomas at all, because all the anatomy is right in front of you, and you can see it better with an endoscope than you can with an intraoperative MRI at that point.
I was talking of functional tumors. Is your intraoperative MRI good for functional tumors?
So that's what I was talking about as well.
Okay.
Right? So your resolution with an endoscope is underneath, below a millimeter, right? You could probably see 100 microns with an endoscope in your naked eye. You can't see that with an intraoperative MRI. You don't have that kind of small microscopic resolution with an MRI scan. And for microadenomas, that's the resolution you need to get a complete resection. Whereas for a macroadenoma, there may be big chunks of tumor that are in the middle fossa, lateral to the carotid, very anterior, and the intraoperative MRI will show that to you. And if you accidentally leave it behind, you'll be able to see that.
Wash. Hello?
May I add something here, Dr. Satish?
Yeah, so what I'm doing, I'm thinning out the floor of the cellar. See, with a drill using like painting, you know, without using any pressure over the drill. Pani kam karo. Wash. Come karo. Yeah. See this, I am thinning the bone over the sella and drilling the part of the tuberculum. Can you see? See, my approach is between the optic nerve to optic nerve. And this part of the, you know, the bone of the, on the face of the sella, I'm thinning out. I'm not intending to remove it with a drill completely. Suction, अंदर रखना. हाँ. See this? कम कर दे पानी भाई. फिर डाल दे बीच में. And this is how the sella is completely, the bone is thinned out, exposed. Laterally in this particular patient, I don't need to go right onto the carotid, you know. No need. Funny. Can you see the wide cellar face coming into the picture? वो देना वो Doppler. What I'm trying to see here, in any given situation, the carotid artery, if it is, I can, because the bone is thick over the carotid. Can you hear? Can you hear? Can you hear? This is my carotid artery. Can you hear? Hello? That is the medial OCR. Can you hear? That is my carotid. I have seen my carotid on both sides. Yes. And now I can start opening the face of the sala. I will start removing this bone. Let me clean everything before I go about. Yes, please.
I need to log off for 5 minutes, but I will come back, okay?
Okay, sir.
5 minutes. Thank you.
Thank you, sir.
What do I have here? That's a take up back. But that's correct stuff that you use, right?
Sir, Vijayanand, sir.
Yes.
Are you happy with the exposure?
Yes. Very good. Excellent.
Okay, now I have met my carotid as well. And now I will start, removing this bone. See this bone? I've already thinned out this. And this from over the tuberculum as well. Some people do use, we don't. But nice. See, this was the face of the sella and this is the level of the intercavernous sinus. Could you see? This is the region of the medial OCR.
Most important thing here is you extract urine and have an intact urine, the bleeding is not much. Once you open up the
Carry some, carry some.
then the game starts. So you have to completely clean yourself and have a good exposure and use a 1 millimeter kerosene. And you use the curved kerosene on here. You take out the tuberculum and the plenum.
Yes, sir. This is right over the medial OCR here on this side and the medial OCR on this side. And this part of the, the tuberculum has been removed. That's a bony decompression of the tuberculum. Just bony decompression. And this is allowing the tumor to bulge, particularly the supracellular component. And this will be a, very important thing. See that? exposed more and more. See, the tumor is bulging. Removing this part of the floor more. See how the sella is bulging more and more. See, in these non-functioning adenomas, our goal is decompression. Of course, we are supposed to remove the tumor, being complete, but not at every cost. In functional, aim is complete. You know, complete means complete, otherwise you will not get a biochemical cure. So we need to understand, in non-functioning, you are not supposed to chase everything at the expense of everything. Pardon? Yes, yeah, that will not give a cure, no? Bipolar, Doppler. See now this exposure? Yes, please. Yes. Yeah, then it is not possible. Yeah, you know, many a time what happens, the tumor is partially soft from inside and then you get onto the pseudocapsule. So many a time when the tumor is partially short, partially fibrous, you can again get onto the pseudocapsule to do the extracapsular dissection. Again my Doppler before I open. I am making sure everywhere again and again about my carotid artery. Can you see? Hello? The knife. Yeah. So that is important. Now, section level. Knife, cut in. Keep here. Yeah. Cut in.
We can appreciate that the carotid is well covered with the bone and all that is exposed is dura, cellular dura only.
I think the message that is being conveyed is maximal bone exposure and maximal dural opening. No small bone exposure and no small dural opening. The reasons for recurrence or residues.
And now, once I have incised.
What incision are you planning? Your U-shaped flap you are planning or dural?
I am using my Carlsso's rotatable scissors now.
Okay.
Are you going to use navigation in this case?
Navigation probe, please.
What about the cruciate incision? We give it.
I believe in this flap.
The only problem with this was it keeps falling back.
Yes, that's the.
You can fix with the Surgicel, sir.
Yeah.
This is the part of the dura. Okay, so scissors there. Scissors.
Okay, I'm back. Hello, hello.
Hello, sir. I have opened the. See, this part of the, flap was having a little bit of the glimpse of the tumor. I removed and I am reflecting it up.
Yeah. So I see the beautiful dural opening, and I would probably take a scissors, but that looks great. Yeah, you're finding the capsule between the dura and the tumor, and there's a bit of normal pituitary gland probably draped over the top there that you can see.
Okay. Yeah. See, this is the tumor, and first I'll take a biopsy.
You see the normal gland draped over the top, perhaps?
See, this is the biopsy I'm taking. Section. And it looks soft where I biopsied. That was the biopsy, and now I have to assess how the tumor is. Our policy is not to use sharp instrument within the cella. Give me a surgery cell. Small.
Best way to assess normal pituitary and adenoma on the endoscope.
So we use generally either 2 sections or 1 section periosteum or 1 section together, because section periosteum many times acts as a good dissector. बोला दे pituitary वाला. So I'm waiting for my sucker. अरे वो यूँ straight angle है ना यूँ straight section. The straight section. Yeah, just I'm arranging my instruments for a minute.
Nobody recommends suction curate now. It is very dangerous. I think.
Yo. नहीं, चलो, मैं रखवा देते यार. Section.
Do you prefer intracapsular or extracapsular dissection most of the times?
Sit there. Pardon? Just let me suck this soft part and then we'll decide.
I'm asking Ted whether he would prefer intracapsular or extracapsular dissection most of the times.
Right. So for a tumor of this size, I would decompress the center of the tumor first.
Yes.
And the bottom, the bottom of the tumor, I would take it to the floor, and I would decompress more of the tumor, because it's hard to find the capsule when you have such a firm, large tumor pushing around it. So you need to decompress it first, and then you find the capsule and work around it. Starting with the medial wall of the cavernous sinus on either side, and then working above.
Hello.
Yes, Satish.
So what we'll do, we'll start with 2 sections. See this, I am starting at the lower part first. Give me other section. But both motor. Give my regular one. Yes.
Satish, both the suctions are in your hand, or are you holding a scope in one hand?
No, I am holding both the sections now. This is not a good one. The tumor is not as soft as we are believing. Just a minute. Pani. Pani tule. See now what I am doing, I am trying to clear the tumor from the floor first. See my left section, I am holding the right section, blocked.
You know, I don't use a two suction technique. I don't find the two suctions to be the best way to do the surgery. I prefer to use a ring curette in one hand and suction in the other hand, and use the ring curette to retract and move the tumor around while the other suction is removing.
Ring curette is safe. Actually, people say ring curette is if we do blindly, then chances of damage are there.
Yeah, you never use it blindly. I'm not saying you use it blindly. You use it where you can see right in front of you. It's a great
See what I am doing. I am removing the tumor first from the floor. Can you see? I am removing first tumor from the floor. Always from the floor, because if you try to remove up, your diaphragm may start descending before, and that may not allow your, tumor to.
Yeah. I think you can remove quite a bit more of the tumor above before the diaphragm descends. I think you're working through a very narrow area here. I would try to debulk more of the center of the tumor. I think it'll make it easier for you.
So, sir, what I am trying to do here, see this. I am trying to remove from the floor part first, going toward the dorsum.
Yeah, I think it's very safe to put a ring curette down low and just sweep the tumor backward.
This is if you want to use ring curette, is a safe area.
Yeah.
See the floor being cleared off? Then I will go to one of the lateral side. One of the lateral side towards the cavernous wall. See this? Go to the other side, the cavernous wall. Clean the.
But then, you have to tell about the mecomyriad that we use.
The cavernous wall on this side now. Going behind and before coming anteriorly and up, I would like to remove from behind and up. I don't want my diaphragm to fall down premature.
Satish, if you hold on for a second, Ted is going to tell us about the mecomyriad, the power instrumentation. Ted, you want to explain that?
Yeah, there is an instrument that's good for very fibrous tumors called the mecomyriad, that is like a side-biting, aspirating device, almost like a very small tissue shaver that you can use to debulk the center of the tumor. And it's side-biting, so you can see the biting part, and it can be done safely as long as it's used correctly and you're always seeing what you're removing, but it does speed up the removal of firm fibrous tumors and allows you to debulk the center of them pretty quickly.
Good. See the big chunk of the tumor. Section. So my goal is I remove a lot of tumor, which is after removal of the floor part, after removal of the lateral part. See the lateral part. This is the lateral wall here, where the carotid artery is. See the cavernous wall there? Can you see